Awesome. All right. Well, welcome to everybody in the room and everybody online. So happy to have you all here today. For those online who can't see me, I'm a little cross-eyed. Um, it's been a crazy few weeks. Lots happening in the world of sickle cell disease. I think that's the good news. The bad news is everybody put it in October, which I prefer that they hadn't done. I thought that was supposed to happen in September. But anyway, I'm really excited to have everyone here for Embrace Education and Mentoring to bring access to care for sickle cell disease. First, I want everybody to please give Sonia a round of applause. To say that I didn't know where the meeting was until a week ago, 3 days ago, is not a lie. This is all Sonia. So, I mean, I knew what city we were going to. I knew, but that's about all I knew. So, this is all Sonia. So, definitely hats off. This is certainly a fabulous hotel, and we are lucky to be here. I'm sure it looks even better during the day. I'll let you know. Myself and Dr. Momo both rolled in right at about 1 a.m. last night. So, we were so tired we didn't even notice we were going to the same place. So let's start off with just a couple of quick announcements. Here is our agenda for the day. This is your brief welcome. I don't hopefully have too much to say. And I also want to remind everyone to thank Dr. Alvarez for our name of Embrace. That was all Dr. Alvarez. That was what, 8 years ago now, 12 years ago, something like that. So pretty fabulous. It's definitely stuck with us. We're almost as cool as Synergy, but we're much more warm and loving. Yes, exactly. So any questions about the agenda, see me and then I'll see Sonia, or you can see Sonia. But hopefully everything here is as it should be, and we're looking forward to a really great day of a lot of conversation. Real quick, both online and in the room, I want to go through some introductions. I think we want to remind everybody who everybody is. I know we have a couple of new faces. So if you would tell us who you represent, who you are, and your favorite place to travel for fun. For fun. All right. So we're going to start front row, Dr. Fu.
East Carolina University. To travel back to where I went to medical school. But that's where I had it from. That's Marburg, Germany.
Oh, wow.
Camille von Bering, the guy who first Nobel Prize for medicine.
Hi, I'm Sierra Golan. I'm at Augusta University.
Hello. Right here. Sierra Golan, Augusta University, and my favorite place is Italy, specifically Sardinia.
This is Vishwas Sakalkar from Augusta University too, and my favorite place, wherever I am. Thank you. I'm very happy to be here with you.
So my name is Alazio MacArthur, and I'm with Piedmont Health Services and Sickle Cell Agency in North Carolina. And any place Caribbean is where I'd like to travel for fun.
Keysalon Wright from Sickle Cell Foundation of Georgia. I'm still trying to figure out what's my favorite place to travel because I'm still crossing things off my bucket list.
Good morning, everyone. My name is Justina Williams. I'm the Patient Engagement Coordinator with Piedmont Health Services and Sickle Cell Agency in North Carolina. My favorite place to actually travel is here to Miami. I've been here, this is probably my sixth time. To say that I've had fun here is an understatement, but I also love traveling to the mountains as well. It's one of my favorite places to be.
Good morning, everybody. I'm Jeanette Newman with the Sickle Cell Foundation of Georgia. I'm the Director of Operations, and I have a list. So my favorite place depends on what I'm trying to do. If I'm trying to see my grandkids, I want to go to Doha. If I want to be by myself, I go to Toronto. I like going to the mountains. I like going to the beach. I like going to the islands. So yeah, away from my house.
Khalid Al-Bashir, I'm from St. Jude, and my favorite place to travel is Sudan.
Good morning. I'm Alexis. I'm with the Sickle Cell Foundation of Tennessee, and I like to go anywhere there's a beach and where it's warm.
Hey, Carrie Gann, sickle cell nurse practitioner at Johns Hopkins All Children's in St. Pete. Since moving to the beach, I like to go to beaches that are on islands now that require a passport.
Tamara New, also from Johns Hopkins All Children's Hospital. I've been thinking through all the places everybody's mentioned. I don't think I've been to my favorite place yet, but from the places that I've been to, I will say Italy.
Good morning. I'm Sonia Smith from UAB, and I guess my favorite place that I've traveled has been to Havana, Cuba.
Hi, my name is Shimona Johnson. I am the transition coordinator for Children's Healthcare of Atlanta. My favorite place now, it's the top one, is Nashville.
Good morning. I am Eldrita Randall. I'm the transition coordinator for the Emory Grady Health site. So I guess I would say my favorite place recently to travel. I had never been to London, and I went in September, and I had a blast. It was totally different than what I thought. You know, I was thinking countryside. I didn't know it was just like New York, 10 times New York City, but I enjoyed it. And then my local place, I love music. So I just came back last week from Vegas. I love going to residencies in Vegas. And I met New Edition, Bobby Brown, New Edition, all of them. So Vegas is one of my favorite places.
Good morning and welcome to Miami. Bienvenidos a Miami. I'm Ophelia Alvarez from the University of Miami, and my favorite place is Spain.
Good morning. My name is Priscilla Hawkinson, and I'm from the University of Miami, and my favorite place is London as well.
I'm JJ Strauss from Duke University, and my favorite place is Oregon. You know, the coast, the mountains, the waterfalls.
And you're also the co-PI of this program.
Well, I hate to come behind him. My name is Gerald Alfred. I'm the executive director of Sickle Cell Disease Association in Mobile. I'm 4 weeks old, okay? And as far as traveling anywhere, there's good food, particularly jambalaya. I love New Orleans.
Hi, I'm Courtney Abrams. I'm from Sickle Cell Disease Association in Mobile. My favorite place is Gatlinburg, Tennessee.
Hi, my name is Keegan Calloway. I'm at Duke. I work with the Sickle Fit program, if anyone heard about our exercise program. Current favorite place is Hanging Rock State Park in North Carolina. There's a lot of rock climbing there that I'm trying to check off all the boxes.
Hi, everyone. I'm Marquita Nelson, and I'm from Memphis, Tennessee. I'm representing Methodist University Hospital in St. Jude, and my favorite place I've traveled is Barbados.
Good morning. I'm Priscilla Ketter. I am from Prisma Health System with Dr. Alan Anderson. My favorite place to travel, I don't have one. So anywhere there's some good music and I can dance, that is where I will be. So if you hear something tonight, let me know.
Good morning, everyone. I'm Carrie Stoker-Postier, also out of Prisma, working with Dr. Anderson. Favorite place to travel? You name it, right? So I'm a mountain, beach, all the things in between girl. But recently went on an epic trip to Tanzania. So that was amazing.
Good morning. I am Artie Pack Mabian, coming from the University of South Alabama, Dr. Johnson Haynes Jr. Comprehensive Sickle Cell Center, where I am the director and nurse practitioner for both adults and pediatrics. My favorite place to travel is Nashville, particularly the Gaylord. I love that place. I've been there multiple times. And then also I like abroad. I love Canada. It's a beautiful country. So I really love being there. Thank you.
Good morning. I am Shamika Perryman. I am also from the Johnson Haynes Jr. MD Comprehensive Sickle Cell Center in Mobile. I am the adult RN as well as the pediatric transition coordinator. My favorite place to travel is anywhere that requires my passport to be stamped. The goal is to touch all 7 continents. I've done 3, And yeah.
Good morning. My name is May Welch. I'm the Vice President of the Sickle Cell Chapter in St. Petersburg, Florida. And I've did a lot of traveling, but my favorite place is home, St. Petersburg, in my house.
Nice. Good morning. I'm Elizabeth Clark. I'm the outreach coordinator at the St. Pete Sickle Cell chapter. I love traveling to the Caribbean because that's where I'm from. But so far, my favorite place has been Sydney, Australia.
Online. I have you guys unmute.
I think most of us put our introductions in the chat, Jiggly.
Well, just say it out loud, Dr. Honeycutt.
Okay. I'm Melody Honeycutt. I'm the executive director at James R. Clark Memorial Sickle Cell Foundation in Columbia, South Carolina. And my favorite place to travel is any beach, anywhere.
I'm Molly Mandernock. I'm the adult sickle cell director at the University of Florida. And I have a lot of favorite places to travel, but last summer we took a family trip to Yellowstone. That was a really great trip. I'd love to do it again.
Hey, I'm Shelley Martin. I'm RN here at the University of Mississippi Medical Center. I am the research and education nurse for our pediatric sickle cell patients and their families at the Children's Mississippi Center for Cancer and Blood Disorders. I'm new to the staff as of April of this year. I'm not a huge traveler, but I do like to go to Florida with my family every summer.
Good morning. I'm Stephanie Bankston. By profession, a nurse practitioner, but I volunteer as the community outreach coordinator for Advancing Sickle Cell Advocacy Project here in Florida. We have a wonderful CMO, Dr. Alvarez, and my favorite place to travel is Jamaica.
Good morning. This is Valentine Joseph, founder and president of JJ Foundation for Women and Children. We do a lot of sickle cell outreach and advocacy. I am in West Palm Beach, and I do work for one of those airline industries, so I do travel a lot. My favorite place is the entire Europe.
Good morning. My name is Kim Bagosia. I'm president of Advancing Sickle Cell Advocacy Project. I'm located here in South Florida. What else? I really don't have a favorite place to travel, but I'm happy to be on this meeting.
Hi, good morning. My name is Mandy David. I am a senior public health analyst at the Health Resources and Services Administration and project officer for the Southeast region, as well as an adult provider of sickle cell patients as a physician assistant. And Jamaica is where I love to go.
Hi, my name is Maria. I'm a clinical research coordinator at the University of Florida, and I work with the adult population with Dr. Mandernock. And my favorite place to travel is North Carolina. There's a lot of North Carolinians out there, so that's my favorite place to go.
All right. Well, thank you, everyone. Thank you for telling us your favorite place to travel. Admittedly, right now, my favorite place is absolutely my house. I would like to spend more than 7 days in a row at home. It's been a minute. And in fact, good story, during the COVID pandemic, we had some friends who bought lake houses to get away from others. And I said, that sounds like a great idea. We should do that. My husband was like, but you don't like swimming in the lake. Fair point. So I said, well, let's go to the Gulf Coast, because that is probably my favorite place in the world is in terms of relaxing and lots of good childhood memories on the Gulf Coast, from Mobile over to the Panhandle. And we looked at that and we could maybe afford a shoebox that was like, 10 blocks off the beach. So that was a no-go. So we put the idea aside for a long time, and fast forward a few years, and we decided maybe we do a fixer-upper somewhere just near in the country, just to be able to have a place for the next pandemic, right? To get away. So we started looking around and I found this amazing house that we could not afford as a second home in Mount Olive, Alabama. And then I'm not from Alabama originally. So then I Googled Mount Olive, Alabama and found out it was 20 minutes from work. So we moved to the country. We live on 11 acres. We have 18 chickens and we're giving away roosters. If anyone needs roosters, we have a few too many. We would love to share. So that's my story for the day. I'm looking forward to being home, but I'm really excited to be here with all of you for now. So without further ado, move it along. Sonia, take over.
Okay, so we'll start with our presentations. As a reminder, you have 4 minutes for your presentation so we can stay on time this year. I have a sign after 3 minutes that I will show telling you have 1 minute remaining. So, all right, and we'll start with Miami. I have the clicker here for you, Dr. Alvarez.
Morning again. All right. So this is a presentation for the Dreaming Demonstration Project, or people who have been involved. Do I point over there like that? Okay. Yeah.
Don't worry, get the minute back.
Yeah, thank you. Okay, so this is who are we, the two programs, pediatric program, me being the pediatric hematologist, and two wonderful nurse practitioners, Vicky and Katie, who help me in clinic, Alisa, who is a nurse practitioner for the newborn screening follow program. And we have Alejandro, QI transition program, Priscilla, who's here, clinical research associate, and the other group, Aida, Naomi, community health worker, and the rest of the group. And the adult program with Tom Harrington and Maya Bloomberg, nurse practitioner. And then we have some funds to hire a case manager and mental health counselor, thanks to Florida Department of Health. And the residents who have contributed to the QI project. Next. So in terms of our volume of patients, we have about 800 patients, both pediatrics and adult. The oldest is 84 years old. And 62% are African American, 30% Haitian, significant population here, and 8% Hispanic. The transition services, we have 80 patients between the ages of 14 and 21. And we are funded by several grantors, NIH, HRSA, and the CDC, and also industry. And of course, we have a very busy clinical service. We participate in GRANDAD and in Teleco of this region. And we have hematopoietic stem cell transplantation and gene therapy. And we work very closely with the community, which I'm very proud to say. Next. In terms of the adult project that we have for QI, we have this important project, which is to improve the care in the emergency department. And I have presented that before in terms of Jessica and looking at what she wanted, what was the present situation and what she was aspiring to be. And you see in red that they were somewhat satisfied with the care for pain, rating 5.5 out of 10. So it was very mediocre, the satisfaction with the Jackson Memorial Hospital ED. And the aspiration was to have less time waiting because the time was too long. And that's what we concentrated on in our project. We first interviewed 10 high utilizers, those were all adults, and we surveyed what their experience was and the frustrations, aspirations. That's how we came up with the figure that you have there. And we decided to have the ED waiting time as our focus for QI. Next. When we look at the baseline data, we distributed at the time per different steps. And so you see here, 14 minutes was the average for triage for the nurse to see them. 54 minutes for the nurse to find a bed. That was the highest time waiting. And to get an IV was 31 minutes. For the provider to see them was 33 minutes. And then to administer the opioid was 41 minutes. So total average 173 minutes. So that was outrageous. Next. So our SMARTY aim was that by December of next year, 80% of the adults we will see within 60 minutes from arrival. And you see in the bottom, the steps that we have taken from December of 2022, we created a protocol. And then they started with the nurse training to get IV access with ultrasound in September of 2023. This is when we created the avatar and interviewed the high utilizers in October. And the baseline data, well, this is wrong in there, but the baseline data was in October. And one of the important steps was that they hired a flow nurse. So that shortens the time from coming and the person to assess, but we have to improve that step further. I actually came with one of the residents to interview 7 ED staff to get their input on what were the problems. One of the problems was obviously the waiting in terms of getting the bed. That is the worst scenario. And we have tried to look for ideas. That brought us to have Dr. Sweeney talk to the providers, because what they do at Duke is basically as the person comes in, they get the opioid there, even in the waiting area. But that's something that our ED leadership doesn't want to do. And we are facing that issue. Okay. And then Dr. H, that's Dr. Harrington. So you see here, we are pretty bad. I mean, the average is only 19% of the patients meet that goal right now. So we have a very high hill to escalate to improve our care, but we'll keep fighting. Next. And these are the great residents who have helped us. Dr. Dan Fan, he actually wants to be a pediatric hematologist. He's the chief resident for the Jackson residency program, pediatrics. Dr. He, who's actually a pediatric hematology fellow right now in Oakland Children's, and Dr. Lewis, that helped me to interview the providers in the ED. Thank you. So I'm supposed to talk about the FP now, huh? Because there is another part of the FP, but you want me to do it now? Okay. So the FP is the Florida Community Embraces SCD Network. And we have wonderful partners. And I actually have 2 logos of that, but I see that one of them was removed because we have 2 SCDA chapters, one in St. Pete that Elizabeth is here, and the other one is here in Miami. And we have ASAP, Advancing Sickle Cell Advocacy Project. Kimba and Stephanie are on the line, and JJ Foundation. And we have the wonderful president on the line, Valentin Joseph. Next. So this is who are we. At the University of Miami, there are 4 people involved. And SCDA Miami, Mildred and Howard, ASAP, Kimba and Stephanie, and SCDA St. Pete, Mary Murph and Elizabeth Clark, who's here. And also we have partnership with Broward Health, with Dr. Rodriguez Cortez. And Naya is the CHW that we pay with HRSA grant. And she belongs to ASAP, but she helps Broward Health with their newborn screening program. And of course, JJ Foundation. And these are the pictures of the two community health workers that we pay with the HRSA funds. We have created a network of 30 different CBOs in Florida that we meet quarterly. And we talk about a lot of stuff, including everybody, can share what the activities are, what the goals are. So we meet virtually every 3 months, and November is one of the times that we're going to be meeting. Next. Next. The population that we serve, this is the data from 2023, distributed by the different categories. In total is 939 individuals that we counted, where the majority are pediatrics between 1 and 21 years of age. Next. And the services, next. You can put all of them. So we have different support groups. JJ Foundation actually going to start a support group very soon, and she told me, Valentine, and we have support groups for SCDA Miami and for ASAP. And actually ASAP has 3 different categories of support groups: the young children, the teens, and general. And we do a lot of educational activities, mental health counseling. I pay for that too. With the SCDA Miami group, and the group from ASAP also do mental health counseling. And they have actually a very nice program called COPE that is for parents. So the parents that they may feel stressed by the situation of having a child with sickle cell, they get mindfulness and other techniques, art techniques and all that they can express themselves. And we have also pain management counseling with Ms. Gauthier. And of course, the other things that you see there, including the newborn screening follow-up, that we have the help from the CHWs. Next. So my QI project is actually the newborn screening follow-up. I think that's very, very important. And we combine 2 sites. So that is a referral center in Broward, which is another referral center, with the help from the CBOs and the CHWs. And this is data starting in 2021, the last quarter, to the most recent quarter in 2024. The median of, we have a median of 44%. This was to have the confirmatory testing of these babies before they turned 90 days, so within the first 2 months. And you see here that CHW was hired in August of 2022. We have improvement. And then there were some issues. So I decided to have weekly meetings with the SCDA and the CHW and us and the nurse to make sure that all the children were followed properly. And I think that was very, very important that we start these weekly discussions. And then we hired a wonderful ARNP, which is Alisa. And with that and Naomi tracking the children, we have achieved a median of 88%. So that's great. Next. Now we have challenges. We are also helping the group from North Broward and Palm Beach. This referral site, they face challenges to actually capture these children. And these challenges also refer to language barrier, because some of these families, they speak Haitian Creole only. They live far away from Fort Lauderdale. So the solutions that we have looked into is to involve the community health worker and interacting with that site, and also the addition of JJ Foundation, because Valentine speaks Haitian Creole and lives in Palm Beach, so she can be closer to these families and trying to engage them so they can bring the children for follow-up and confirmatory testing. Next. And so I want to acknowledge Dr. Valle Santos from the Department of Pediatrics. She helped me in the creation of the front chart. Thank you. And this is, you have Kimba, you have French, who's just show up from SCD in Miami, Stephanie, and Regina Hatfield from National SCDAA. And this was during a blood drive that we have about a year ago. Thank you.
Good morning, everyone. I'm Dr. New and Tamara New, and Carrie again is our nurse practitioner for our program. She's here with me in the meeting. Next slide, please. We're representing Johns Hopkins All Children's Hospital. This is a picture of our team. I call us small and mighty. So not here is Don Gates, who's our sickle cell nurse coordinator, Lori Wilson, our social worker, and Anna Eidenberger, who joined us this year as our clinical research nurse coordinator, clinical research coordinator. Next slide. So our goals for 2023 to 2024, you can see we have completed most of them, and we're really grateful for that. It may seem odd to many programs, but we were trying to bring pneumococcal vaccine to our clinics. We didn't have them physically in our clinics. They had to get these from their pediatricians. And so I'm grateful that we have that in 2 of our 3 locations. We were able to expand red cell apheresis to our Tampa Outreach Center so that our patients that live a little further away did not have to come to our main campus every month. So that was a huge win for those patients. We were able to update our clinical, our sickle cell clinical pathways so that our inpatient and emergency center could have guidelines on how we felt our patients should be treated. And then we also were able to improve the quality of our annual TCDs. We were able to convince our radiology department to send their techs and their radiologists to get new training so that we could actually get results that we could rely on, which we were grateful for. And then ongoing, we've been evaluating the 72-hour return to the EC rates as well as our 7-day hospital readmission. And we're just kind of going through the data and trying to come up with our next steps from that. Next slide. So we were able to this year, within the last month, actually, we have approval to expand TCD services to our Tampa OCC, which is really meaningful for our patients in our Lakeland location, which is over an hour away for some of our patients. They'll now be able to go to Tampa instead. And so that our families have been very grateful for that. And we've just started scheduling that. We have standardized and published our transition education materials, and that is available now on our Connect intranet, which means that our providers have it available, and it makes it easier and more accessible for us as providers as well. And then we've been able to incorporate our goal is actually to incorporate a clinical pharmacist to our sickle cell clinic to see if that will help improve some of our medication adherence. So our QI project was to improve infant education provided in our clinics to our families with sickle cell disease. And we wanted to go from 0 to 80% and our start date was December 2022. And we wanted to be able to measure this in EPIC, which is our electronic medical record, as well as through a tracking document. And by the end of 2022, 90% of eligible families had received the updated newborn education. 2023, we were up to 95%, and we're now up to about 99%. And so we're really proud of that. The thing that I think was key in that is that we now have all newborn education available in English, Spanish, and in Haitian Creole, because we have a growing population of Haitian Creole families. Okay. Thought I was talking fast, but not fast enough. I think next slide. Oh, I think that was it. So let me go back one, please, so I can just say that last little point. So we wanted to make sure that we're improving the comprehension of about their disease for our families of newly diagnosed infants. We provide the education, and we provide a midterm exam as well as a final exam for our patients' families, so that we, one, make sure that they understand, but then two, make sure that what we're saying they are receiving. That's it.
Dr. Honeycutt? Okay.
I thought we were going this afternoon.
I can move you to the afternoon if you like.
No, I don't care. I'll do it now, but I thought this morning with the TDPs and this afternoon with the follow-ups.
Okay.
But that's fine. I'll be glad to do mine now.
Okay.
Okay, so I am filling in for Hilton. Not Hilton, but unfortunately, she had 2 deaths in her family and she is in Philadelphia this morning. So you're stuck with me. So this is just a brief 3-slide update on what I had presented last year. So next slide. This is our project title, Project LEAP, Locate, Educate, Assess, and Place. So our goals are to identify unserved and underserved sickle cell disease patients in South Carolina, to place patients in medical homes who do not already have a primary care provider, and connect with specialty care providers. As part of our service array, we provide ongoing assessment, monitoring, educational, and support services. We also provide transition services for adolescent and young adult patients who are going from pediatric to adult medical services. Next. So just to kind of bring you up to date of what we have done in the last year. We have done 26 comprehensive initial assessments for new patients. Our CHWs, as well as our nurse case managers, do monthly patient check-ins. The nurse case managers do that via home visits. Our CHWs do that telephonically. So we had 9,023 monthly patient check-ins in the last year. But by phone and text, 1,353. By emails, 7,515, and in person, 155. In terms of ongoing educational and support services, we did 732 referrals from our patients to community resources and or medical providers. We had 544, and this is attendees at our support and educational groups and events, including our back to school bash, where we distribute back to school supplies for sickle cell patients and their siblings. Then we do quarterly Can We Talk educational and support groups via Zoom. We had 301 participants in our Giving Tree Party. We have a number of them. We have them throughout the state because we serve the entire state. So That's accumulation of all the different locations where we had parties last year. In our transition services, we have identified 191 across the state, 12 to 26-year-olds who have transition needs, and we have successfully transitioned 91 of them. We also provide emergency patient assistance, which is financial assistance primarily with utility bills to make sure they can keep their heat and their air conditioning on whatever the season is. We also do some medication assistance, some transportation assistance. But in the last year, we assisted 337 patients with utility funds. Next. Okay, this is our QI update where, all of us have a goal with regard, all the follow-up programs have a goal with regard to, our project goals between now and 2026 to lower the number of patients who have unmet needs. So I'm going to try really hard to look at these wonderful charts that my CHW, who does amazing things technologically, did for us. So the first question is, do you have a medical home or access to medical care? And you can see that 92% answered yes to that question, which I thought was fabulous. Then if needed, do you have access to mental health services? And again, the vast majority, like 75%, said yes. Okay, if you answered no to any of the previous questions, do you want assistance gaining access? So obviously the majority of that was no, because they already have access. Do you have access to dental care? And 86% said yes. If needed, do you have access to social services? Again, 83% said yes. And so then we asked, which services do you need assistance accessing? And there were, out of all the responses, the largest one was none, which I thought was fabulous. You can see there are some other needs, because not every question was 100% yes. So that's the distribution among the other services we asked about in terms of patients who wanted help with those. Next, I think that's it. Does anybody have any questions?
No questions.
All right. Thank you, Sonia, for helping.
Good morning. I'm Priscilla Ketter. I'm the I'm the research coordinator from Prisma Hills. I'm sorry. I didn't say that earlier, so I feel like I need to say it now.
I'm Carrie Stoker Postier. I'm a clinical social worker with our comprehensive lifespan team. And here's our very brief slideshow. Am I starting this? Okay. Oh, wait, go back. Sorry. See, it was very brief. So we just did some really brief site updates. Some of our highlights, we're continuing to build out our transition program. That's been like a big part for us. Just making sure that we have that. We have a very small team. Small and mighty is what I heard earlier. That's how we feel like every day. Our bandwidth is like, how are we doing all these things, right? But we're doing them, right? So the transition program is a big part of us. The use of the EMR, we make sure that every transition age patient has a problem list in the EMR. It's a way for our whole team to be able to track that and to look at that. We've created smart phrases around things as well. We did some improvement to our transition readiness assessment questionnaire with a lot of patient voice in that, like what's important for them too. So we're building that out, not just the medical side, but psychosocial, community resources, understanding of budgeting and finance. There's a lot of pieces to that. We've increased our education too, as far as local resources as offered. We found some resources out there that we didn't know about that are been free to our patients. And we've also created some incentive program with the help of our CBO for engagement in that transition program, which has also been really helpful. So bringing back your binder and like setting up your own My Chart and just pieces like that, and finding goals and then following those goals.
Okay, since we embraced speaking last year, we've increased our granddad enrollment by like 55 new patients. Our goal is to try and get all of our patients. We have about 450 patients, so we're trying to get all of them enrolled. And of course, we've had some to say no, but we'll give them another year to think about it. And we'll go back and ask again, because that's what we do.
We've also had some really focused efforts to coordinate with some local specialty programs, specifically our recovery medicine and pain medicine, especially in our adult world. There's just such a lack of resources for that. So we've really done some good engagement and coordination about those pieces and other healthcare organizations across the state. We're kind of rural, so we have families that come in from a lot of different areas, patients that come in from a lot of areas. So really partnering with other healthcare organizations that may not have access to our EMR, right? So they have to be able to build up their own information so our patients are served well.
And we are also continuing to access our clinical trials, with the closing of Oxbryta, that hit all of us pretty hard. So along with that closing, that also closed Prospect, which at Prisma, we were actually getting ready to start consenting for. So I never had the pleasure of consenting for Prospect, unfortunately, but we are still working on new clinical trials that we have coming down the pike, and hopefully next year we'll be able to report more on those.
So we don't have like a built-in school liaison program or anything like that within our group. So we've really worked hard to create this multidisciplinary school team. We call it like a school squad to support specifically our students that have sickle cell disease across the ages. So starting school all the way into college, and really looking at that as a multidisciplinary team of who can fill in the gaps and who can be at point, whether it be at a 504 plan meeting or whether it be transitioning to college, and then like helping with scholarships and things like that. So that's been a big part of what we've been doing too.
Okay, so in addition to our small but mighty team, we have added another physician to help us. As you can see, Dr. Anderson's not here. He's currently actually on his way to Africa. And so to help with his absences, we have added another hematologist, oncologist to help us more with our sickle cell population. And she has been a great asset. Actually, while most of our hematology team is out of the building right now at this conference and another conference, she's like her and our APP are the only ones who have in the office to handle the patients today. So it's been a blessing to have added another physician to focus primarily on sickle cell.
And since we already got our notice for 1 minute, we've maintained our involvement with our local community advisory board. That also includes community members, but also patients and patients' families. And we've had some challenges.
High turnover rate, but we've replaced those people, and we're currently trying to train them and get them on board with everything.
So because we've had that high turnover, that struggle, you guys have probably all experienced it in some way or another. Communication fails. There's just all these gaps that happen. We don't meet as regular. So we felt that. So we've really taken this year to try to beef back up our QI goals, our communication within our team, and try to resolve some of those things. Next slide, please. Maybe we'll just be able to look at this, but some of our progress. We've really standardized our transition education and measured that documentation. We're spending a lot of time making sure that we have good measures in place and making sure that patients are learning from pre to post. So by the time they're graduating from transition, like, are they actually getting the information, right?
We've added pain care plans in everybody's records. Well, we're still in the process of doing that, but that has been a major help in the emergency room department. And we're increasing our QR project to include those ages 26 and up, because we were only previously doing ages 16 to 25, but we do want to follow them after they've been transitioned to see how they are handling everything.
DMTs, we're working at like how to work with our EMR folks to be able to, how do we pull these things that's not just manual? So that's been our biggest struggle, is like looking at access, looking at use, looking at barriers to use, but utilizing EMR, because it is very difficult to try to plug all those things manually, track those things manually. So I'd be happy to, outside of this, be able to hear what maybe some other people have done to be able to do this, because this is a struggle for us, but this is super important to what we're doing.
For community engagement, we've have our attendance to monthly local and our monthly local sickle cell advisory board and our ASHCAP community advisory board meetings. Our goal is to have at least one physician or APP present at each meeting, and one study coordinator and one CBO member and a parent or a patient or a parent of a patient. And we have actually successfully done that and been able to track it. So those are our updates at Prisma.
Oh,
Dr. Brianna Murphy.
okay, thanks.
Tennessee.
Yes. All right. All right, good morning, everyone. So I'm Alexis. I'm with the Sickle Cell Foundation of Tennessee, and we are a part of the Improving Care Throughout the Lifespan sickle cell newborn screening follow-up program. Our organizational structure is listed here. We did have one individual who rolled off, who was our hematologist, but he's still available to us as well. But here's a kind of a listing of our psychologist. Is Dr. Geraldine Porter. Our Meharry contact is Dr. Aguanawa. We have Dr. Henry, who serves as a co-PI, and Renisha James as a co-PI, who's a warrior. Our administrative assistant is Tiny Rufus. We have our community outreach organizer, Jasmine Brazier, and we have Andrea Morgan as our digital engagement consultant. Dr. Marie Milam is our compliance consultant. And we have two community health workers as well, Dr. Brianna Burris and Shelfina Wilkins. We also have three warrior consultants, April McGorry, Joshua Lewis, and Brandon Carter. Next slide. So so our overview for our program highlights. When we started we started 1 year late for this project, but we jumped right in and started doing our trait testing and our genetic counseling, which we do as an organization already. So we had a goal of 50 in our objective, and we hit that goal probably the first 6 months of being a part of the project. We've had focus group sessions. We've held several adult focus group sessions as well as a caregiver session. So we're moving forward with being prepared to transcribe those different recordings to prepare for our deliverables for the project. Next slide. So these are our objectives, the collaborative conversations piece, the resilience toolkit for caregivers of children with sickle cell disease. So really quickly about the collaborative conversations piece, we've identified probably more than 500 now, statewide contacts in the state of Tennessee. And we're looking to try to schedule a bi-monthly contact webinar, if you will, with these individuals, talking about what services they offer for our patients as well as our caregivers, as well as sharing information and spreading awareness about sickle cell disease with them also. We've identified some topics to be discussed, everything from real estate to financial management to meditation sessions that we will be going over in these different sessions with them. The resilience toolkit, as mentioned, we had a focus group and we were looking to we interviewed those different parents and caregivers, and we've also held trait testing sessions also. Next slide. We've also had the resilience toolkit meetings with the adults. As mentioned already, Through the adult sessions, we've identified some topics that to include for our caregivers toolkit, as well as topics that we are going to include in our adult toolkit. As mentioned, we've reached our sickle cell testing goal, and we are doing genetic counseling for all of those that come back with a positive trait test. And we also have a virtual module that we're creating, a virtual transition module that we're creating is also an objective of our project. And we have hired, as mentioned, our digital engagement consultant, and the community health workers are working to try to develop the content for that module. We're also having dissemination strategy sessions because we want to see what's the best way to disseminate what we have. Whether that's putting it on our website, whether that's starting a YouTube channel, or whatever we need to do to try to get the message out about transitioning. Next slide. So here are our partnerships. We partner with St. Jude in Memphis. We partner with Meharry in Nashville. We also partner with the grad chapter of Delta Sigma Theta in Memphis. Okay. And we have some additional partnerships as well with Vanderbilt University, Regional 1, Lamont Owen College, University of Memphis, and several medical associations and numerous community organizations as well. Next slide. So I put this on here just so that we'll know kind of what our supplemental award was used for in the state. We were able to hire the digital engagement consultant as well as our community outreach coordinator. We're also using those funds to expand to Middle and East Tennessee as well for our messaging as well. Next slide. So these were some of our initial updates. We get this data from Meharry Medical College, and these are just some of the initial trait testing sessions that we had in the Tennessee area. And we listed those items as well as the age range and those who were tested. And that was the initial data updates. But as mentioned, we're over 50 at this point. Next slide. So our next steps, as mentioned, we're doing the analysis of our focus groups that we have, that we recorded. We're looking to have the community focus group sessions and the collaborative conversations. We're looking for, as mentioned, the strategy for our deliverables and the best way to disseminate that. We have some themes that were defined in our description for the project, but we're looking to see what works and what's best, utilizing our other stakeholders and patient stakeholders to kind of give us some information about what those themes need to be. We are also onboarding some youth ambassadors, as well as some additional warrior support resources. Our youth ambassadors, typically, we're trying to get them on for like a 2-year period to be the youth face, and provide a message for sickle cell disease in their arena. As mentioned, we're doing our statewide expansion of the project, and we're getting ready for our DGIS submission. Next slide. That's it. Oh, yeah.
Hi, for your youth ambassadors, do you all use transition age, or like what age do you usually?
Yeah, great question. So we started, we typically try to use a teenage age, right? So if they're getting ready to graduate from high school and getting ready to move into young adult age. So typically we try to start in the 10th grade time frame so that we can follow them through high school, support them through high school, and however they are getting ready to transition. But we've had some middle school parents to reach out to us as well. And so we're engaging them also, but we're happy to start in the teenage age range is the goal.
Thank you.
Yeah. Okay. Oh, sorry.
You mentioned you do the testing, the sickle cell trait testing or sickle. Could you tell us a little bit more about that?
So we basically have testing sessions. We don't do the testing ourselves. Meharry Medical College is the only institution that's in the state of Tennessee that can actually do the testing. So we get our contract nurse. I think there were some nurses on the team on my first slide, but we get our contract nurses to come out and do those trait testing sessions for us. And that can be at our walk, that could be at our 5K, that could be at a blood drive, that could be at giveaways, back to school. We just kind of contract with them to come out and do the trait testing. Meharry sends us the blood sample capture material supplies. Yeah. And so we utilize what they send us and pack it up and send it back to them. And they send us the results. And so our contract nurses then reach out to those who were identified as having sickle cell disease, and we do that consulting.
All right, Dr. Nelson. You pass this. You pass it.
Good morning, everyone. So I'm Marquita Nelson. I am the co-PI of our site here at obviously not here, at Methodist University Hospital in collaboration with St. Jude Children's Hospital. My co-PI is on paternity leave, so he couldn't be here today. Can you go to the next slide? And just click through everything. So since we're a collaboration of an adult hospital and a children's hospital, we want to focus on transition. So our global aim was to improve transition care for our sickle cell patients as they transition from St. Jude to Methodist University Hospital. Our first smart aim was to improve the no-show rate from 85% to 100%, meaning they would make the first visit 100% of the time. At their first transition appointment within 6 months of leaving St. Jude by April 2023. And we also wanted to improve engagement in adult care after transition, because we find that although you may have made your first appointment, what happens next? Do you keep going? A year later, are you still in care? So we were finding that a lot of patients kind of got lost. You can go to the next slide. So this is the first aim where we were trying to target improving the no-show rates. So instead of having like a 15% no-show rate, we wanted to have a 0 no-show rate. So you see in the beginning, the data is from 2021. The red bar is the median, the green is the goal. So in the beginning, it was a little bit shaky. We had some periods of downtrend, but now we can say that we actually are at goal of 100%, and that is the median. So we have patients who are making their appointments within 6 months. They may not make the first one, but within 6 months, they're making an appointment. Next slide. Also, this is the slide I talked about engagement. So we wanted to improve engagement to 70%, meaning within a year, they're still in care. So in the beginning, you see it wasn't that great. So over time, we have definitely gotten better. We hired a transition navigator around the end of 2021, which definitely influenced the result of this. And now we're doing much better. We are above goal. Our median is around 80-ish%. Next slide. So it's clear that our transition navigator is great. So she's calling patients, she's reaching out, she's going to the hospital when they're sick, she's going above and beyond. She's kind of like a second parent to some of these patients who are recently transitioned. So we want to delve deeper. So our next project is to figure out how can we improve our retention. We're giving out this survey to patients, looking at how difficult is it for them to keep their patients. And basically, we're just trying to figure out the barriers that we can help with. Next slide. So this is a result of our transition navigator. So we're looking at patients who are lost to follow up. So we have a lot of patients over time, they go from St. Jude, they go to Methodist, and then they disappear. You know, they go to college, or they just stop showing up. And so we wanted to improve our loss to care. And what she did was she just has a list every month. She calls them, she sends letters, she essentially just tries to pull them back into clinic. And we have seen that since hiring her in 2021, this is all 2024 data though, we've gotten much better since the intervention. She's just been really aggressive about contacting them. Next slide. So future directions, this is my last slide. So we want to improve collaboration with other other hospitals. So Methodist is not the only sickle cell center in Memphis. We have Regional One Health, the Diggs Krause Sickle Cell Center, which is the oldest sickle cell center in the country. We want to improve our relationships with them. We're going to look at the survey results. We're going to think about how we can use telehealth better. And we also have a great collaboration with the newest St. Jude Gene Therapy Stem Cell Clinic. And so we're going to see if our relationship with them can also improve our adherence to care and in collaborations with them. And that's all. JJ has a question.
So can you go over again? So how does this work? How do you get them to show up and engage? Is it the second parent? I mean, how did you find her and how do you retain her? And does she want to come to North Carolina?
Yeah. So yes, essentially you have to find somebody who is very caring and goes and above and beyond. She has text messages on her phone at like 3 a.m. from these patients. I told her she needs to have some boundaries, but they talk to her like she is family, and she will go and visit them in the hospital no matter where they are in the city. And she has that good relationship with them. She magically, she already worked in our system and she just applied for the job and we had no idea she'd be so magical. So you just have to find somebody who has a heart for our patients. She is a mother. I think that helps because she has teenagers, so she can kind of understand the way they are. Is there another mic back there?
Problems which are associated with transition. We know that that can be a process, a problem, bottleneck, etc. No, and that's when it's within one institution, same institution. You spoke about Methodist to St. Jude's, right? Right, St. Jude's to Methodist. Okay, how is that process? Additional problems, probably, or challenges?
Yes, so St. Jude has a phenomenal transition program that starts at age 12. With education about, growing up. They do a skills lab. They teach them how to call pharmacies, call their insurance, make appointments, kind of be independent before they transition. At 17, they assess their transition readiness. They have a whole panel that decides if they're actually ready to go. And then myself and another adult hematologist actually go to the teen clinic twice a month. I go twice a month and she goes the other 2 weeks. So we try to make relationships before they even transition and capture them. We also do transition tours so they can come visit the two hospitals and decide where they want to go. We try to do our best. and then the day that they transition, they meet the same people that they met at St. Jude. So they have familiar faces. So far it's been working. But with COVID, we definitely saw a dip in patients. I think we all did. And I think now we're kind of seeing them come back.
Thank you.
Are there any questions for any of our sites that presented this morning? Okay, great. So we're about 12 minutes behind on our agenda. So we'll come back from our break at 10:40 instead of 10:30. Oh, okay, no, we're back. We should be back in here. Sorry about that.
I can't hear any volume if you guys are talking in the room.
There we go.
Ah, yeah, now I can hear you.
Okay. I know you've got your screen. All right, so I'll let you go ahead and get started.
Okay, great, thanks. So I'm Molly Mandernock. I'm the adult hematologist who runs our sickle cell program at UF Health. Next slide. I just wanted to give a quick update on our team members. In the last year, our pediatric department has hired Rima Kashif. She's been a wonderful addition. She is running our pediatric sickle cell program. So she and I are working on transition program right now. We have a few other kind of ideas and projects coming down the pipeline as well. So she's been a really great addition for our patients. Next slide. And then the next update, just real quickly for our team members, I also wanted to say that we, in the last year, since this last meeting, we have gone from basically one extender RPA who works both inpatient and outpatient to we now have 3 additional nurse practitioners that are working in our clinics. So this is really helping to expand access for our patients for appointment availability as well. And next. And finally, our last team update is one of our part-time research coordinators has left to pursue a career in nursing. And so currently Maria is our full-time research coordinator. She's fabulous. She keeps our QI project going. She keeps our registry going. So she's really an integral member of our team as well. Next. So in terms of where we stand with the registry, just an update. We've enrolled a total of 121 patients, 71 of which are female and 50 are male. Unfortunately, 4 of those patients have passed away in the last year. We have fully completed data on 59 patients, and this is including the original consent, reconsent, ask me for years 1 and 2, and baseline and extended data. And we estimate, again, this is adults only, not our pediatric population, but we estimate this is about roughly 60% of our active patients in our adult population. Next. So in terms of our QI project, the updates from last year. So just as a quick summary, what we were doing initially is I was looking at hydroxyurea prescribing practices and noticed that for folks with hemoglobin SS and S beta 0 thal, our prescribing practices were pretty low. And so as a part of wanting to increase our prescribing within our outpatient hematology clinic, we did a number of things. We have developed an intervention, which is a standardized note template that has a hard stop on hydroxyurea so that the provider, in order to sign the note or complete the note, there's a hard stop where they have to answer questions about hydroxyurea prescribing. Within that note template, we also did include measures for standardized care to, again, really try to get our providers to make sure that we're kind of following those metrics for our patients and making sure that we're doing everything that we need to from a standard of care perspective with their visits. We also created and distributed educational resources for our patients about hydroxyurea. And the goal was really that every patient who is either already on hydroxyurea or who's eligible to receive it, about 80% would receive it at least on an annual basis as part of their clinic visit. We have it as a printout, but we also have it, we use Epic as our EMR. So we have it as a patient instruction guide that can also be included in their MyChart app. And so where we are with these things, we've already done the retrospective review, the chart review, to confirm an estimate of the prescriptions written. And obviously the note template and the educational handout were new. And then we've also completed both provider interviews and patient surveys to try to assess current barriers and potential facilitators for prescribing hydroxyurea and patients filling those prescriptions. The intervention's been completed, so the outpatient note template and the patient education materials have been available now for 7 months. We initiated the intervention 7 months ago. And then where we are in terms of our outcomes is this is in progress. So we actually just finished completing the post-intervention data collection. And so we're in the process of getting ready to pull that data from REDCap to review the total number of prescriptions that were written. And also through Epic, we can track the use of the template and distribution of education materials. So we'll see if we've had any impact on our prescribing practices in our clinic. And then we'll be able to take that data into the next cycle. And I think that's all I had. Yep. Thank you.
Thank you. Are there any questions? Okay, all right, we'll move on.
I'm Toby Moma. I'm a co-PI for the Embrace program at University of Mississippi Medical Center. So we what's that? Thank you. All right. So University of Mississippi Medical Center, I'm a co-PI with Dr. Melissa McNall and Erin Jackson. We just hired 2 new nurse investigators, research nurses, Shelley Martin, Rhonda Hayes, who I'm sure they're online. And I think we have Toby Breland, who has been working with us. We participate in the Granddad QI Echoes. We have at least 400 in the pediatric section. Our adult section is still work in progress. The goal for us in UMC was to improve our meningococcal B screening for our adolescents between 10 and 17. I don't know if it's unique to Mississippi, but a lot of them at the age of 18, they're not eligible to get vaccines because of the Medicaid restrictions. So we rather want them to get their meningococcal B vaccine. We're using Bexsero before they turn 18. So we started about 2 years ago, but we amped it up when the research nurses came on board. So recently we've gone from maybe at the beginning of the year, April, 62% had 1 dose. And then by September, it had risen to 72%. The latest data is at about 86%. As at October, 86% had at least gotten 1 dose of the Bexsero meningococcal B vaccine. Those who have had 2 doses, 36 to 45%. The approach has been to send a list to the providers when they're in clinic of the patients they are seeing who will need a meningococcal B vaccine. Sometimes put a sticker on their computer monitors, and also inform them through Epic that these patients need a meningococcal B vaccine. We just recently had an upgrade to our clinic facilities at UMC thanks to a grant. So we are able to do a lot of education in the clinic space as well as see the patients as well. So it provides time for education and also implementation of the things we want to do. So we've seen an uptick in our meningococcal B vaccine, at least in the first dose. So we're hoping that we can get that up to at least 80% overall for both vaccines before the end of the year. So we're looking forward to that. That's it. Any questions? Yes.
What was the restriction you mentioned at the beginning of after 17, 18?
Medicaid Mississippi doesn't cover meningococcal B vaccine. So some states, it's difficult for Medicaid to cover vaccines when you turn 18 and above. They cover it when you're an adolescent, but once you hit 18, it's more difficult to get vaccines covered.
Okay, interesting. I grew up in Mississippi. That's why I was asking.
Yeah.
And it's just for meningitis, you said?
I think it's for more than meningitis.
All of them. It's all vaccines.
It's very, let me use, I'm in clinic, I'm a family physician, but most of my patients, once they hit adulthood, to get them covered, it's very difficult.
Interesting. Thank you.
Very difficult. Mhm.
Any other questions? All right, sounds good. We'll keep going. All right, so let's see, Louisville. Oh, it's online. Real quickly. All right, so Louisville wasn't able to have anyone to come or be present at this time, so they sent in a video for us.
Hello, everyone. Happy Thursday. I'm Spencer Mormon, research scientist at the Norton Children's Cancer Institute, affiliated with University of Louisville in Kentucky. Unfortunately, our team was unable to be down in amazing Miami with you all in person, so we're very thankful for the opportunity to share some updates from our site with you today via this recording. In Louisville, we care for about 350 pediatric patients and about 150 adult patients with sickle cell. Some of our site updates that we would like to highlight include the addition of a new hospital in the underserved west end of our city called Norton West Louisville Hospital. This is a new building, and we hope that it's more than just a healthcare facility. It's a symbol of hope, healing, and community collaboration to address existent health disparities. As the first hospital built west of 9th Street in over 150 years, the state-of-the-art facility aims to improve access to care and well-being for our West Louisville community, hopefully for many generations to come. This new facility will allow our team to conduct bi-monthly sickle cell clinics closer to the homes of many of our patients. We also have Emily's Law now in Kentucky. It's a sickle cell oriented effort that requires the Cabinet for Health and Family Services to conduct an annual review of all the medication services and forms of treatment for our Medicaid enrollees. This prioritization of sickle cell in Kentucky now has dozens of PhDs working on its third year of a report to gather yearly stats that help paint a picture of what care patients with sickle cell are really receiving across our counties and demographics in the Commonwealth of Kentucky. In addition to this yearly state report, which has helped raise awareness and paint a clearer picture of the true sickle cell landscape in our state, we also have a Connect program. It's a site for specific resources related to family unemployment, reentry, substance abuse, foster care, health, and medication needs. This mechanism has helped expand exposure and reach of Kentucky community-based organizational supports and resources in various areas. And it's easy to use and for our patients. Our main CBO, Sickle Cell Association of Kentuckiana, has expanded their reach and impact in the last several years. They're offering several webinars, educational opportunities, monthly community meetings, health fairs and blood drives, virtual and in-person support groups. They've raised money through annual walks and another gala, which brought participants from out of the state to help support the STAR program, which helps patients with medication and grocery expenses, hospitalization assistance, utility bills, transportation supports. We also have new staff a full-time embedded genetic counselor on the pediatric side. We're really excited to have her as part of our team, full-time embedded pharmacist on the pediatric side, and a new full-time hematologist on the pediatric side. We are well resourced on the pediatric side. So we are extremely excited to have a new registered nurse navigator helping Aaron Semyon and Nick Sansone on the adult side. Aaron completed the support program with Dr. Cantor. She was able to shadow UAB and learn a whole lot from their program. We also have a new chief of pediatrics in the HEMOC division at U of L. In terms of QI, we've been able to integrate a promise screening on the pediatric side. It's been integrated into standardized care for patients and parents. We've been able to utilize our community health worker to help with this QI process. 90 parents have completed the survey and 70 pediatric patients have completed it. We have an embedded psychologist who follows up with the identified needs that this survey reveals, and the team can now refer to this promise flow sheet in Epic. We also have a multidisciplinary transition clearance protocol that we are trying to implement, and it aims to incorporate several team members and disciplines from a chaplain to social work, psychology, pharmacy, the medical team, and now a genetic counselor. So we're trying to incorporate a clearance consult from all these different disciplines so that the green light transfer of care comes from the entire team and not just one provider. So far, we've had 10 patients transfer, incorporating this process, and 70% of those who've transferred have attended 2 adult visits. So they've been successful per the NASAC definition of a successful transfer. And the other 3 patients have just recently transferred, so we don't have enough time to see if they are going to follow up in adult care just yet. And on the adult side, they've developed an order set for partial manual exchange to be utilized inpatient and outpatient at Norton Cancer Institute. They're currently implementing partial manual exchange for the first time for patients at NCI, and the team is working on an order set for that. They're finalizing inpatient standing orders to better manage pain crises in adult sickle cell patients that incorporates the most up-to-date guidelines, working on individualized care plans for all adult patients with sickle cell that hospitalists and ED doctors can access, standing orders for the adult ED staff to utilize. So our adult team is fairly new. They started a year ago. They're super dedicated and determined to help patients. And so they're really trying to catch up to all the other QI initiatives that are going on in the Embrace network. So here are just some of the things that we're doing in our site. So thanks for your attention, all that you do for children and adults with sickle cell, and have a great time in Miami.
All righty. I'm going to attempt to set a record today. They asked for 4 minutes, I'm going to give them 4 minutes. I said I was going to attempt to do that. Who has the clicker? This is it right here. All right, so my name is Elazier MacArthur, and I'm with Piedmont Health Services and Sickle Cell Agency out of North Carolina. We are one agency with 6 offices across the entire state. We cover 19 of the 100 counties in the state of North Carolina. And just recently, we found out that there was about 3,219 individuals living with sickle cell disease in the regions that we cover. Our caseload is not that big yet. Okay. All right, so just some of our updates really, really quickly. We've increased the number of clients who receive specialty care that also have primary care that's separate. A lot of times individuals thought that their specialty care was also considered their primary care. We've done a really, really good job of fleshing that out. One of the ways that we've done that is that we've included rural health centers and federally qualified health centers to provide primary care to those individuals living with sickle cell disease. I didn't do that. Oh, okay. We've also increased the number of clients that have received care coordination and counseling education within those regions. We do a really, really good job working with our North Carolina Sickle Cell Syndrome program and to be able to provide those services. We've conducted what we call our roadmap to transition within clinicals. That's not what I'm doing. What are we doing? Okay. All right. That's where I'm supposed to be. All right. So we've increased the number of clients that also said that they needed assistance or that they had unmet needs. One of the things that we found out through this process is that the biggest barrier is transportation. Our clients, particularly those that live in rural North Carolina, have a hard time accessing transportation to their specialty care. One of the things that I mentioned earlier is that we have 6 offices across the state of North Carolina. Of those offices, all of our offices are in close proximity or have direct contact with comprehensive sickle cell clinics. So our Goldsboro office works well with East Carolina and Dr. Bangfu and his team. The Fayetteville office works really, really well with Dr. Strauss and his team at Duke, as well as Dr. Little and the team at UNC. The office in Greensboro works well with Moses Cone and Wake Forest Baptist. And then the office in Charlotte works with Atrium Health and Novant Health. So it's really, really helpful to have those close working relationships with those comprehensive sickle cell clinics. I mentioned unmet needs. Transportation is one of the biggest. The second one is housing, affordable housing, and then access to medications is an issue that we find that our clients have. VISCA continues to build and strengthen partnerships with healthcare facilities and community stakeholders. That's with other CBOs or community organizations within the state, like Bridges Point, Sickle Cell of the Carolinas, the Robinson Foundation out east. So we work very, very well with them to provide education and awareness and advocacy across the state. We're currently fully staffed for the first time in a very long time. I'm excited about that.
Very long time.
I'm excited about that. We did have one office that was unstaffed for a very long time. That office is now fully staffed and we are hitting the ground, cooking with LP gas. So our quality improvement project, life skills transition. We wanted to revamp our transition program. It used to be called Transitioning to Independence. We changed the name to the Roadmap to Transition to really talk about the different phases that we laid out in our transition program. We thought it very, very important to include what I call the 3 Ps, which is the patient, the parent, and the provider, having them all collaborate and to talk about and be a part of the curriculum that we've laid out. And then we created educational activities to bring them together. One of the things that we found out is that our transition age kids did not want to talk about sickle cell. They've talked about it all their lives. So they wanted to talk about them. They wanted to talk about what they wanted to do. And so we created fun activities to bring them together, also providing education and awareness doing those fun activities. In Region 1, we had 74 participants over the last 2 years to participate. The majority of them participated in our camp Carefree, which Justina has been a part of practically half of her life. Yeah. Our Charlotte office, that number has actually changed. It should be around 27 participants. Our Goldsboro office, that number should also have changed to be about 30. And then the Fayetteville region, about 45 participants. And that's because we just recently did these prior to me having this put together. One of the activities that I wanted to talk about was what we call Education by the Seashore. We took about 92 participants to the aquarium out on the coast of North Carolina, provided this huge all-day education program. And one of the biggest things that happened for me was that we had a 16-year-old female who, for the very first time in her entire life, verbalized that she had sickle cell disease. We created a space and a space for her to feel comfortable enough to say amongst her peers, my name is X, Y, and Z, and I have sickle cell for the very first time in her life. And so what we're finding is that when we provide fun activities around educational programs or educational events, that we get better participation. And then we show that there's an increase in knowledge that takes place before the individuals participate and then afterwards. And so we're really excited about that. Our patient engagement coordinator, Justina Williams, I'm going to leave space for her to really quick because you ain't gonna mess up my time.
I'm not gonna mess it up, I promise.
Are we done? Are we finished? Or we got one more minute? We got one more minute. All right,
Okay.
come on, you got 1 minute.
All right, so during these transition simulations, like Alazia said, it is a safe space for kids to verbalize that they have sickle cell, but it's not information about sickle cell. It's what can happen during sickle cell. So what I mean by that is you drop off your parents' insurance. What college are you going to go to? What job are you going to get? What if your car breaks down? Do you have enough money for medication? So we set up these safe spaces for the kids to actually enjoy and learn about life from the adult perspective. And you will be surprised the conversations that these children have, because you think that they're not listening and they may not know, but they are very well informed about themselves. You just have to share that space with them. So yeah.
Did I do it? Did I do it?
Ah, look at us.
All right. Now that time does not include Q&A. So you guys have any questions, quick pass to them.
As you can see on my first slide, all right, so I wanted to highlight the people that work mostly on this, not our whole team, but it's me and Jen Rothman are the pediatric and adult sickle cell people, providers, and then Tegan Calloway, who's here with us and can give us all some fitness advice, and Rania Muhammad, who is away currently. So these are our major activities. We do the North Carolina Sickle Cell Echo, which is every first and third Thursday, coordinated by Rania, who I know all of you have heard from and know. And we've done a total of 60 sessions since January 2022. We've had a total of just over 1,700 participants since May of 2022. We appreciate you all coming and joining us to learn and teach each other. And then our faculty, we've expanded it. So in addition to me at Duke and Sarah Leonard at ECU, who I think many of you know as a pediatric sickle cell expert, we have two of our nurse practitioners from the adult program, Joy Curry and Katie Colosimbo. And we would love to have a pediatric nurse practitioner, which maybe we will have soon as we replace someone who recently left. For community engagement events, we've partnered with Piedmont Health Services, Bridges Point, and the Durham and Wake County Sickle Cell Support Groups to do a number of events over the last year, and also doing more events with UNC, including Full Court Press for sickle cell disease, which was their event that they invited us to join in, which really served as both a community education event, trying to reach outside of the sickle cell community, as well as a fundraiser for the sickle cell programs. And I was not able to make it this year because I was giving a talk on sickle cell disease elsewhere, but it was I'm told, a great event. And we had a team from one of our local mosques who took it all. They won it, that was affiliated with Duke, but basically just signed up to play basketball. So they were one of our teams. So we're proud of that. We've been having trouble beating UNC for our men, and at least last year, women's basketball team. So we'll take what we can get, though this year we're very hopeful. And then we also in addition to doing some disease specific webinars, and we have one coming up that we're going to do yet another webinar on the Oxbryta withdrawal, because that remains a topic of tremendous community interest, despite there being some wonderful events already on it. We also did a Harvest Research Festival and partnered, really focused on participation in clinical research by people with sickle cell disease, that we partnered with the School of Nursing and the School of Medicine at Duke. And then we did a North Carolina sickle cell conference with UNC this year as well in September. For Granddad, we've had 191 participants consented, and we're continuing to collect data on those participants, and we're about ready to start rolling out the patient-reported outcomes and actually collecting some biorepository samples as well for individuals that have consented for that. All right. And then I'm just going to take one slide to talk about one of our QI initiatives, and this is QI measures for individualized pain plans. And for this project, we've had individualized pain plans for our adult patients with sickle cell disease for many years, and have really been working quite a bit with emergency departments to try to get them to consistently use them and really revamp things. And it became clear as we were doing this that while we thought we had plans on everyone, we did not, particularly for people that didn't get their emergency care within the Duke Health system. And they're important too, but we have a lot of people that just get their emergency care in Fayetteville, or maybe it's farther east in the Carolinas. Maybe they're in the Raleigh area and they like Wake Med as opposed to Duke, which if I had sickle cell disease, I would probably like Wake Med more in the Raleigh area too. So we realized that we needed to revamp things. We had 4 outcomes that we wanted to look at, and then one that was aspirational. So that was that they had a pain plan in their snapshot. Snapshot's very useful within Duke Health, but you can't see it in the same way when you're outside of Duke Health. But that's what they use in the Duke Health emergency departments for our 3 hospitals. The second was pain plan in their last hematology note. And that's important because for anyone who's on Epic or has a sharing agreement with Epic, they can usually get to our last hematology note and look there. And the emergency department providers were very comfortable with that idea of looking for the last hematology note as a place to find the pain plan. So we wanted to see if we could get it there. And then that it was updated in the last 12 months, and then finally discussed with the patient within the last 12 months. And the aspirational goal was pain plan letter. So based on a study that was recently completed and published in Blood Advances that was done through the Sickle Cell Disease Implementation Consortium, it's clear that you can put these pain plans in a letter to the patient. They can pull it up in MyChart or another patient portal, show it to the emergency department provider, and they'll actually listen to it because it's a verifiable source. I'm old enough that I remember when we did these on paper or sometimes on a little card for patients. And when we tell that concept to an emergency department provider, they kind of laugh at us and say, wait, I'm going to give someone opiates based on something that you could print out on your computer at home. Not going to do that, right? So they want a verifiable source. That's a way of doing that. And then I have 3 data points from when we started. So you can see July 2023, August 2023, and September 2023. And when we started, we only had pain plans in the snapshot in about 50% of our patients. Only about a third were in their last note, and only about a third were updated within 12 months. And then no one, had they been documented that we discussed it with the patient, that it was what worked for them, or that they had a pain plan letter in their chart. And then you can see we had some improvement. We went from a little under half to almost 2/3 having a pain plan in the snapshot. Didn't really change when we, if you look at the September 2023 data, didn't really change the other metrics very much. But then over the last year since then, we've increased to almost 80% of people having it in their snapshot, about 2/3 having it in their last note, over 70% having it updated within 12 months, and then a third that it's been documented that we've discussed it with the patient in the last 12 months, and another third that have their aspirational goal, that pain plan letter, that's been updated in the last 12 months. I'm going to stop there. I'll talk some more about emergency department care and pain plans tomorrow, and when I have more time to yak.
Good morning. I'm Bang Fu with ECU, and I'm glad Elazio went before me and JJ. So all from the great state of North Carolina. As you guys know, we work very closely. I think JJ will probably talk tomorrow more about some of the statewide initiatives that we're really undertaking to make sure that people, when they go from one region to the other, they get good care. And Elazio mentioned we work very closely with Piedmont. They serve the state all right. Let me see here. Does it have a pointer? All right. It's not showing up here. Since we talked about Greenville, South Carolina, and Charisma with a very nice name of Charisma, I wanted to point out where we are. So let's see, it's okay. You can see it? Okay. For some reason I can't. All right. Okay, good. Oops, we went all the way now. No, continue. There we are. Good. So North Carolina, we are all the way out here on the East Coast. So we have ECU there, we have ECU Health. And if you drive all the way from the Triangle area, you go through farmland, and then all of a sudden you will see a huge medical center. That's ECU Health. So this is the Children's Hospital where we sit. The Cancer Center where the adult sickle cell is. HDU where we do transfusions, and the medical school is back there. So it's a pretty extensive system. So ECU Health has several hospitals spread all across the East. And then, of course, the medical center is seated right here. We are the second largest hospital in North Carolina. Duke is the largest hospital in North Carolina. We have, the system has about 1,400 beds. The medical center has 974 beds. Most of those in the 29 counties east of I-95 are covered by us. So just a few updates. We have pediatrics, we have adults. We do work very closely with one another. I am in pediatrics. Dr. Lies is on the adult side. As JJ mentioned, we have Sarah Leonard who helps a lot. A lot of our work is really done by our APPs, Chelsea and Jessica. Jessica actually put together this slide. So if I'm messing them up, it's because I'm just reading and trying to come up. But before I go on here, I just wanted to mention some of the things that have happened over the last year. We had Dr. Lies really short of staff for several years now. That has led to us having some adults. We have patients on our service who are 27, 28 years old that we are still treating. But she did recruit a nurse practitioner. So we have started moving some of those patients now. So hopefully we won't have those troubles of someone coming in at 25 and the ICU saying, we're not admitted to PICU, you have to go to the adults. We recently hired an embedded sickle cell psychologist who sees them both inpatient and outpatient on the pediatric side. We don't have something like that yet on the adult side specifically. When it comes to how we run, we've actually brought together what we call a sickle cell interest group, which brings together community, brings together the medical center, but also people of interest from throughout campus, so that we meet monthly. It's actually headed by Todd Savitt, who is also heading up the sickle cell syndrome program. So we develop programs together, implement them together, but also advocate, which is really, I think, one of the biggest issues we face. So I wanted to just spend a little bit of time on our QI project. There are two major QI projects. On the adult side, it was really improving the number of people who get the annual flu vaccines. As you guys know, adult health is a lot more fragmented than pediatric health. We don't have those slides here. Dr. Lies has been busy, didn't get those to me on time. On pediatrics, we, at the beginning of this, we really looked at how well are we doing when we come to optimizing the doses of hydroxyurea. We first looked at people who were on the Twitch trial and how well were they doing after they came out of the Twitch trial and they were on hydroxyurea. We found that we were doing horribly poorly. So in several levels, once we were not optimizing the dose to MTD the way it was on Twitch. Two, their iron still looked horrible. And even those we optimized, their dosing was horrible, their compliance was horrible, and their hemoglobin F had fallen to somewhere from 30 to 15. Some had basically gone back not to having anything. So we're like, okay, since we are using this now to really prevent those who were not on study, we need to optimize that. So we're really looking at that. So going through the PDSA cycles, we came up with several modalities looking at that. And we settled on the fact that we really needed to come up with educational material. Coming up with this, you have to go through branding at ECU Health. It takes forever. You won't believe how many steps you have to go through to get all of that material. So we've now created 2 patient education FAQ documents, how we transition from transfusions to hydroxyurea. Those have now gone through all the ECU systems, and we plan to implement these starting the beginning of the year. Just to give you an idea, these are those documents. One is really talking about iron overload and how that's really important, even when you are done with your transfusion, to make sure we get those back down to normal ranges. And then looking at hydroxyurea, why is it important? What's going to happen when you are not compliant and you are no longer on transfusions? And so hopefully, now that they have been approved, we will roll those out and we'll give some data next year. I think I didn't go over my 4 minutes. Yeah.
We got it, okay. Again, good morning, I'm Gerald Alfred from Mobile. And first of all, you see we tried to color code this. Okay, that's the first thing we tried to do. But again, I'm Gerald Alfred, Executive Director, and I brought one of my social workers with me right here, Courtney Abrams. We're going to give a high-level overview of our programs that we've actually done over the past year. First slide, please. Oh, it's on me. Okay, first program will be Positive Perspectives, which is a affirmative form designed to provide our clients and their families the opportunity to discuss topics of interest, learn about different treatments, and to share their experiences coping with sickle cell. This also gives clients opportunities to socialize, have fun, and be more supportive by other warriors. We have the Perspective meeting monthly. With each meeting, we provide refreshments and a virtual option for those that can't attend. We offer education to all 500 clients, as well as non-clients seeking information. The next program is Welcome to the Family. This is one of Courtney Abrams' brainchild, actually. This program actually introduces newborns and clients to our agency. We provide education and information about sickle cell and the services that we definitely offer. Next would be case management services. The case management program is designed to ensure that all individuals with sickle cell disease have access to the full array of medical, social, educational, and community services that are available in our service area, which is actually 9 counties. We offer services again for 500 sickle cell clients in the area. Financial assistance, we have assisted a total of 48 clients and their families with rent, utilities, and food. Transportation services, we assist clients with getting to medical appointments. We provide gas cards, rideshare services, Z-Trip, Uber, and Lyft, bus passes. We have actually assisted 74 clients in transportation. I want to brainstorm on that a moment. I've been here for 4 months, but my background is actually public transportation. I worked there for 20 years. So that's one area that we're definitely looking to create that partnership for the most part with the city and tap into some additional funds with that, because there are some funds available within all of that. So we'll be reaching out to local public transportation as far as additional programs with that, more so like VIA and those agencies. Parent Academy and Back to School Bash. The Parent Academy Back to School Bash is a 2-part event that empowers parents with knowledge for the upcoming school to meet the needs of their child and sickle cell disease. The second part is a day of fun before school starts back. Children, of course, gets to enjoy a day with other warriors and just have fun for the most part. We provide 50 clients, we provide service for 50 clients and their families at this event. Prior to me starting, actually, we had a Shining the Light Gala. Unfortunately, the weather didn't cooperate with it, but this gala was a night of elegance to educate the sickle cell disease as well as to honor the warriors of sickle cell disease. 200 people were invited to this event and 12 warriors were honored. And last but not least, before I go into her part, one other thing is this. I've been there 4 weeks, I keep saying that, but coming here, I used to always wonder, what is it that these other agencies are doing that we're not doing? We hear about the American Cancer Society. We hear about all these different social services. Well, it's interesting. They're being heard. So on that note, I'll give you a soft introduction of what we're getting ready to do. Moving forward, we're actually going to have a branding campaign for the city of Mobile for this program. And the theme, and don't take it back where you came from, is going to be heard. So you'll see it on social media, you see it on the vehicles, you see it all around the city. We work in South Alabama for us to be heard. Thank you.
I think your expertise as a transportation specialist is really, really important because as Elazio mentioned, I think one of the biggest issues we have is really transportation for families. I know you have only 5 or 4 minutes, so you don't have much time to elaborate on how you get those funds, if it is something that's limited to your region, or this is something some of us can learn from to use those skills or those funding sources.
I'll try to answer that in about 30 seconds, okay? Prior to coming here, I was the COO for the city of Birmingham, for Birmingham Jefferson County Transit Authority. And prior to that, I was actually the assistant CEO, I was assistant COO for the city of Mobile. There are funds appropriated annually and appropriations through DOT for the most part. And it's all your areas, go back and research something that's called a Human Services Coordinated Transportation Plan. That would be Human Services Coordinated Transportation Plan. That program is actually going to be facilitated through your local MPO. Within that program, it actually identifies Metropolitan, I'm sorry, I'm still talking this transit acronyms, please forgive me. Metropolitan Planning Organization within these areas. Now that basically is going to be the area that manages your transportation funds. So if you hear things like streets getting paved, pay as you go as far as taxes, as far as getting roads paved, or VIA, or demand response services, or fixed route services, or infrastructure, all that's tied to that for the most part. Like I said, I can go on and on with it, but again, it's tied to appropriations that comes down from DOT, and it's based upon ridership numbers, and it's based upon passenger miles. Now, those funds come down annually, but those are gaps that are identified for the most part. And you can sit up and take those gaps and identify your need to sit up and do a good example. And I'll be finished in a moment because I've got about 1 more minute. You have sale programs like the senior citizen centers and stuff. Believe it or not, those centers are actually getting funds from the MPO. They've identified a gap as far as seniors needing transportation to get around. So they apply to those funds. And honestly, they'll say it's a match requirement, but this is that grant writing coming out of me now, forgive me. But again, that goes back to match requirements. Now, for those that do write grants, you got to understand, all match is not cash. So the creative part is, watch this. The creative part is to sit up and be in kind. Good example, the in-kind match could be the property that you own. If you own it, get it appraised. That's your match. But again, I'll be glad to talk with any more. That was 5 minutes. Thank you.
Looking forward to it. So I am Artie Pack-Mabian, coming from the University of South Alabama Health, Johnson Haynes Jr. MD Comprehensive Sickle Cell Center. We are a regional level 1 trauma center and the only regional academic center along the Gulf Coast. Last year, as a new member with this Embrace team, I gave you a nice overview of the Sickle Cell Center. This year, I wanted to focus more on our QI project and the objectives of the Sickle Cell Center. So with that being said, our goals are to improve the overall access to quality healthcare for individuals with sickle cell disease residing in the southern region of Alabama, to facilitate a smooth and seamless transition of adolescents and young adults with sickle cell disease to adult care, to provide educational programs for affected individuals, healthcare professionals, and the community at large, to conduct clinical research related to sickle cell disease aimed specifically at reducing disparities and improving health status, and then lastly, to encourage individuals affected by sickle cell disease to participate in basic and clinical research. And so looking back at our objectives, we thought, let's look at that in terms of identifying our specific aim in terms of our goals and our statement. And it was derived from our third objective, which is to provide educational programs for affected individuals, healthcare professionals, and the community at large. With that in mind, our aim statement was to increase the number of nurses caring for patients with sickle cell disease on sickle cell wing of the 5th floor medical surgical unit with basic knowledge of sickle cell disease, including pathophysiology, complications, transfusion therapy, baselines at the state labs, and disease management as it relates to nursing management in the inpatient setting, from 0% to 80% between September 1 of 2023 through September 1 of 2024 through continuing education offered by the center's APP and attendance by the nursing staff on the 5th floor biannually, and the development of an educational sickle cell disease health stream module created by the center's faculty and APP staff, with the completion by the nursing staff on the 5th floor as evidenced by data collected and extracted by the USA Health Staff Development Department and IT on a quarterly basis at the end of each quarter during the month of December, March, July, and October. So very specific. As a result of this, what we found, and we did offer those CEU classes twice a year, and you'll see it coordinated with September as National Sickle Cell Awareness Month and June as World Sickle Cell Awareness Day. In September, we offered a total of 4 classes, and you can see for the first session, we had 42 out of 87 nurses to attend, and these include the APPs as well as RNs and LPNs at 48%. For the second session, we had 39 out of the 87 at 45%. And then in June, we had a total of 40 nurses of the 87 to complete that offering for 46%. And it was well attended, considering these are nurses leaving the floor. They actually came in either early for their shift or they stayed late for the shift. And then we have staff development. And because we involve nursing administration, the academic leaders within nursing came down to watch patients while they were allowed to come to these classes. We also developed, as a result of our program, a sickle cell health stream module. This module has 6 components. And again, because we had nursing administration, College of Medicine, the educators involved, and they wanted this when we look back at the nursing staff because of COVID, high turnover, the number of nurses who knew about sickle cell, taking care of the sickle cell patients on the 5th floor where the patients are housed, knew nothing about sickle cell. And we went from 0% to 23% within 3 months. Then we had a drop down to 19% because of turnover. People were leaving, new people coming on board. Then in that 3rd quarter, we jumped up to 66%. And then when I got my final numbers before coming here, we were at 100%. All 87 nurses on the 5th floor caring for our patients had successfully completed that 6th module on sickle cell disease. And this comes with a lot of hard work because actually on the front end, I got nursing administration to buy in. I got hospital administration to buy in. We had the medicine guys on board. So medicine was there and then we were there. And so it's like, if you want to see a change, then I need you to commit to sickle cell. And so I was very happy, you know, she was a young lady who's working with me from staff development and IT collecting this data. She says, Miss Artie, I kind of pushed them. I really pushed them and I greatly appreciate that. And so with that being said, that was our QI project. Now looking forward, we're going to address patient care with the individualized care plans. People are really screaming about these care plans. Patients are not happy. And so we're now with our next project, did the same process. We went to nursing, the College of Medicine, hospital administration, nursing administration, QI, to get their involvement, and pharmacy to look at, okay, let's identify who these patients need to be in terms of these individualized care plans. And we've made a definition of high utilizers, high risk. And we've actually defined what is high risk, what is high utilizers, say, okay, this is where we're going to start with these individuals to get these individualized care plans going. So our target is going to be 26 by our next cycle. So when we come back next year, we can report on that. So at this point, I will stop, stand within that time frame.
Thank you. They actually have sickle cells on them. I have a question in regards to how you got that buy-in from the nurses. Like, what did you have a meeting? I see you had CEUs. So that is one portion of it, but like, did you have a talk with them? Like, how did you get them to really buy into what your program is doing?
So we did. We had a big meeting, and that meeting included the nurses because they were complaining, and they wanted to have a quote gripe session. And so I went for that gripe session, myself and the other APPs and my medical director. We all attended. And so I asked that not only were we going to be there to receive that, but I wanted nursing administration had to be there, the College of Medicine had to be there. And from that, I had to have a commitment from them. If you want to change, I need your commitment to make that change. And so the CEU was one way to do that. But then also being a former NICU nurse in the hospital, knowing I don't have time to stop to go to a CEU class, then my next thing was, how do I bring it to the nurse at the bedside that maybe during a break or at home could go to a web-based program, go through that process and take the modules. And so they would actually go through the video, watch it, take a couple of questions, and then pick the right answer. But it wasn't just a matter of picking the right answer. I had the rationale as a part of that teach back method to make sure they understood why that was the right answer and why the other answers were not correct. So, and like I said, it's been very successful. They like the CEUs. They like being able to take time to stop and just do the modules. And so I'm going to watch it to make sure we sustain that 100% as we work on our next QI project. So I have been doing just basic interviews with patients to see how they notice a difference in the nursing staff since we've done this. And our patients have come back and say they really see a difference in terms of nursing attitudes. And that's critical in terms of taking care of our patients. And so, you know, nothing formal in terms of, analysis and all of that, but I've just talked to the patients that have you seen a difference? And then nursing are not complaining. So I do plan on having my own invitation to a quote, let's kind of go back and touch bases behind this gripe session we had a year ago. What are your gripes now? What are your concerns now, to show that we are truly interested in meeting their needs to make things better for the patients? Yes, ma'am.
Who developed the modules?
So I developed the module as the director of the Sickle Cell Center. And then I had my medical directors look at the module for content, look at the study questions for the modules, and then also the answers. So both medicine and nursing and the center itself.
And one thing we do want to do, not just for nurses, but for other groups as well, is have a national bank of those types of modules. So there is an international nursing group of IASCANAPA who has a lot of that data. So, and a lot of those slides and teaching courses, and then we have them for support, which is our APP training program. These are all national resources. So if others are interested, you don't have to reinvent the wheel. I think we've spent enough time in sickle cell doing that. So those are available. And certainly if Dr. Pakmabian wants to lend her slides, I'm sure that that would be another option. All right, so I'm going to give a couple of updates. So we have lots of goals. I think we want to continue our interprofessional reach. We've been really working hard at getting more people involved in sickle cell disease across UAB. UAB is huge. For a small city, we take over 100 city blocks, and UAB actually just acquired a whole nother hospital system. It'll probably take 3 to 5 years to have that actually impact our patients, but it was a desperate need. We don't have enough room for our patients. So very, very exciting. And I think it allows us to increase the interest we're getting from health professions, which I think will be huge. So that's exciting. continuing to identify areas of unmet needs. They're constant. I feel like every day I find another unmet need. I'm just keeping a list and trying to go through them one by one. And then, of course, working with our community partners around Alabama on joint projects, on funding and goals. Enhancing our sickle cell disease surveillance program. I'm going to get to show you some data tomorrow when we talk about that. I'm also going to show you something really cool. It's going to make Granddad that much more useful in that we can now basically link all our Granddad patients to our surveillance data. That's huge. That's what we need to make a true competent sort of registry across the country, but at least we can start in Alabama, but a lot of your states also have the SCDC program. So one of our long-term goals is going to be to do that in Georgia, Tennessee, and North Carolina and other places. So really and truly, I think this is going to be huge moving forward. As a result, we knew that they needed more infusion space in Mobile because USA has done an amazing job, but we need more of an infusion and day hospital space. Mobile Infirmary partnered with our cancer program. And I give them some kudos. They came to me and said, we can't do this equitably without partnering on the sickle cell side. You don't get to hear that very often. You don't hear a cancer director come to you to say that, at least I never hear it. So we have a dedicated nurse practitioner. We just hired a dedicated social worker. We're going to be able to take patients from UAB and USA for day hospital treatments as time moves forward and as she gets sufficiently trained. What I've seen there is horrific. I think it's happening more than you could possibly know around community hospitals. The number of people who have sickle cell trait getting treated for crisis is abominable, among other things. And I just think there's a lot of work to be done. We're going to hopefully be able to have a second affiliate site at Russell Cancer Center, which is also a UAB affiliate, and that helps serve our Montgomery population. We're looking at new space in Montgomery. That's a whole nother story. Our goals is improve outreach to improve outcomes to improve quality. And we're also just got a grant from Dr. Ted Love to the Lifespan program. And that's what's going to really allow us to increase our mental health capacities. And then we don't have time to go through the data. And when I do have it all together, I'd be happy to share it. But we've been using Uber Health for the last 3 years. It has dramatically improved our show rate in clinic. It's also dramatically decreased the number of patients who try to drive home after they get IV opiates. So that's been obviously something important and something we're trying to show on paper. All right, so other things, we opened a new clinic in May of 2023. We outgrew our space. We've, of course, already outgrown the new space. That's how this works, right? But we now have 8 exam rooms, 2 of which are fully PCP compatible. So they have GYN chairs and all the GYN needs, so our primary care doctor can do that. They have much more office space, though we're already out of office space. We've increased our day hospital space from 4 to 10 chairs. If you've been in our center, it's completely embedded in one location. We've increased our social work staff to 3, recognizing that they were insufficiently staffed. We've added a transition and transformative care coordinator, finally added at least a quarter of a sickle cell specialist. His focus is in palliative care, Dr. Patel, and I think it's going to be a really just great additive to our clinical experience. And we're adding, as many of you have heard, a fellow Embrace member is moving from, sorry, Atlanta, but we need help. I know, I'm very sorry, but you got everybody else. It's our turn. So Elna Sa will be joining us in July of 2025. I could not be more excited. I feel like salvation is coming. She's really going to take over some of our young adults. She's going to take over the medical director of the clinic so that I can focus more on the programmatic and funding issues, and honestly to focus more on the National Alliance, because I think in the long term, that's what I as an individual can do most to help the world of sickle cell. And I'll tell you a little more about some updates there tomorrow too. We're hiring a new clinical psychologist and psychiatrist, and we're making some improvements in apheresis. Our PEDS program, they haven't changed as much as we have. They've been more set in stone. They did reopen all 3 of their outreach clinics and have booming success in those areas. They actually take TCD to the clinics, so definitely a unique model in Montgomery and Tuscaloosa and Opelika. But otherwise, they are just continue on and really doing a great job. And that's it. So I could stay under time. Questions? Okay. Yeah.
How do you pay for Uber Health? I know.
No, we're running out of money actually pretty quickly, and that's why we're putting our data together to demonstrate just how incredibly useful it is. We received a very generous gift before I actually came to UAB from our Sickle Cell Disease Foundation in Birmingham. They're now the Sickle Cell Disease Association of Birmingham, Central Alabama. Yes, they've changed leaderships like anyway, yes. So they gave us a huge grant several years ago, and we're still able to use that funding. But we have some other options for funding. And one of the things that we have asked HRSA for is, can we use some of the HRSA funding for this? And could it be expanded to other places? If you are in a city, if you are in Miami, if you are in anywhere that has Uber, which is almost all of us, it is unbelievably impactful. You do have to have a contract with Uber Health. For those who don't know about Uber Health, you can follow the patients, so it gives them a much more secure feeling. You can see where they go. They can't change where they go. They can't request to go, I don't know, to the 7-Eleven. We can send them a link to get home and send them a link to get to us. We use it even for patients who need to go pick up when they live in Montgomery, but they need to go to see a psychologist in Montgomery. We can give them an Uber to do that. It is just it is more impactful than almost anything I think we've done. And so we're trying to figure out how we put that together in terms of data to support it. As something for our state to take on, as something for Medicaid to take on if Medicaid doesn't get cut, but also just as something I think that HRSA can help take on as well.
You have any significant discount based on number of patients when you use Uber Health? I'm asking because 2 years ago, our medical foundation gave us $5,000, and within 2 months, it was gone. Right.
I mean, we have to limit. So as you all know, we have some adults who would come every single day or every week if we let them. So everybody is limited on how often they can use it. Our biggest expense is it's $150 round trip to Tuscaloosa from Birmingham, but many of our patients are transfusion, stroke patients. That's the only way they get to us. And so, but we limit them, and it isn't fair. I'm not going to lie, right? It's not fair that if you're in Birmingham, you can come twice a month to the center and get paid for. And if you're in Tuscaloosa, you can only come once a month. We know that it's not fair. We're trying our best to work on it, but we have to keep our dollars alive as long as possible. But there are no discounts. I did recently hear that Lyft has a similar program. So there's now a Lyft Health program. So, competition always breeds discounts.
Good morning. Am I on? I'm still on. Okay. Just to follow up to what Julie was saying, we actually used our HRSA supplemental funding to We actually used our HRSA supplemental funding to purchase vouchers. And so we found that to be very successful in providing transportation. And the way it works for us is that either the CHW or somebody from the sanctuary will place the order. The person indicates that, and we can use it all over the state. So it's not just in metropolitan Atlanta. So it's been very, very successful. So I would encourage everybody to look for funding to purchase those vouchers. It's so easy. We have one person who makes the call. She arranges the transportation. And like Julie said, we can track. And so it's made it a lot easier for people. So when we met last year, I kind of talked about all of our services and the programs that we offer. What I'm going to do today is really just give you updates on what we've done since we last met. So one of the places where we made some changes is with our Access to Care program. So our Access to Care program is our largest is our largest program. And one of the components of the Access to Care program is the hematology care. So last year I talked about us putting a hematologist in community health centers. We service the entire state of Georgia. There are 159 counties in Georgia, and we're responsible for 159 counties in Georgia. We have people who live with sickle cell disease in 153 counties, and we service in a year anywhere between 70 and 85% of all the counties in Georgia. We are located in metropolitan Atlanta, our main office. We partner with federally qualified health centers, community health centers, FQHC lookalikes, county health departments to place CHWs in those locations to partner with local health organizations to provide care coordination services. So we have CHWs in Savannah, Augusta, Macon, and Columbus. We have 2 in Atlanta. We're adding 2 more in Atlanta because one is transition specialist. She only serves transition age clients, and the other serves everybody else. And so it's a bit much. So one of the things that we were able to do with our state funding was to place or share the cost of an advanced practice provider in Columbus. Columbus has a sizable population of individuals with sickle cell disease, and it's growing. And we received appeals from our senator who serves Columbus, from the hospital that's seeing people who have sickle cell disease, as well as people living with sickle cell disease. We send a hematologist down there once a month who works out of Valley Health. And what they were saying to us is that it's not enough. The hospital is saying we're seeing too many people in the emergency room. There's no aftercare when people live. We can't wait a whole month. So we are paying for a portion of the salary of a nurse practitioner and a certified medical assistant. So this program is just starting. We're having our first meeting with the executive director and the nurse practitioner and the CMA next week. And we've already been in contact with the support program that she'll be participating in, as well as shadowing our contract hematologist. She'll also be making visits to Grady Comprehensive Sickle Cell Program and University of Augusta University. So we've had some conversations with Dr. McLemore, and we've also had some conversations with Dr. Kutler about her training. And we're establishing a partnership in Columbus with Piedmont Regional Hospital, both the Northeast branch, and then there's one more, and I can't remember the other one. The other Access to Care program is the Sickle Cell Sanctuary. So I talked to you last year about the Wellness Center. So the Wellness Center is not a clinic, but it provides 1 minute. All right. Sickle Cell Sanctuary. So last year we started it with mental health services, and now we've expanded it to a full service, proactive wellness center. These are the services that we offer. So I can't talk about them because Sonya's gonna beat me up. Transition services. So we've had transition services, but we revamped our transition services. The other thing that's new is that we have a new program coordinator. Kisalan, please stand up. She was our CHW transition specialist for a long time. She's currently training the new one. I've been there for almost 10 years now, and I have to say she gets it. We've had lots of program coordinators, but she gets it. Thank you very much. So what we did was that we revamped and we relaunched our transition series. We had to collect some data from the kids to find out, because we kind of shut down during COVID. We had some virtual sessions during COVID, but our participation was waning. And so rather than just kind of starting and doing the same thing as before, we started talking to the kids. Kisalan did some research, came back with some great ideas. So what we do with our transition program now is that we've integrated social activities very similar to what you're doing in North Carolina, because the kids want to get together socially. And what they said to us is that this is how we want to start our sessions. We want to start our sessions with a social activity. So they do things like make candles, and they make soap and paint and shea butter. And the kids say this serves as an icebreaker for them. And so we partner with our clinical partners. They come in and they come in as subject matter experts. We had Justin. I don't know if you can see Justin on this picture. There she is on the right. She's the psychologist from CHOA. She came in and she did a mental health session with them. So they talk about things that they need to talk about more than just, as Elizio said, more than just sickle cell. So we are starting a mentoring program that will launch in early 2022. That should be 2025. We're currently in the process of recruiting mentors, and then we'll be training them. We will use not only what we learned from the Step Up program, those of you who may remember that, but we also have an intensive training program that we do with our camp counselors. So we'll be combining those two things to train our mentors. So I kept to my and then so this is community outreach. So we actually have a talk show called Unveiling Sickle Cell Beyond the Pain. So we bring in people living with sickle cell disease, we bring in warriors, we bring in research. And the reason that we did that is because when we're dealing with other media, whatever they put on the air is what they want to put on the air. It may not be our complete story. You know, when we started talking about, when the news broke about the new therapy, they interviewed Dr. Kutler and they interviewed our executive director, Tabitha McGee. Neither one of them said that this is going to cure sickle cell disease. Neither one of them made that statement. But the line at the bottom, a cure for sickle cell disease found. So we said, okay, we need to do our own thing. So that's what we do. So this is brand new. This is our studio. This used to be our multi-purpose room. I kind of fell out and had a temper tantrum when it went away, just like I fell out and had a temper tantrum when Elna sent me that text. But, you know, who cares if adults have temper tantrums? You know, you just kind of move on. So far we've done 12 episodes, and our guests have included researchers, SCD experts, caregivers, family members, and we're really excited about it. All right. Did I do it?
Is that podcast video? Can we link to it? Because I think that would be a great.
There will be a link to it. Okay. It's kind of over my pay grade, so I can't. But all of that, we'll send all of that out. They just finished the 12 episodes, and so I think it's the first of the year. I think the first one will be at the gala, so we'll get to see the first one at the gala. And so, of course, we're going to send it out to the sickle cell community, how you can access it. And yeah. Yes. Thank you. You know, we really wanted, you know, people who have sickle cell disease, there's so many places where they're not wanted. I mean, we have a huge hospital, Northside Hospital, that will only see 10 sickle cell patients a year. 10. I don't know how they picked the 10, but you know what, and so we really wanted to create a space that just kind of wrapped around you, that was like, we want you here. We're here to serve you. You are important. And they can go anywhere to get those services, to be, you know, these services, the services that we're providing, they're not unique. You know, there's massage therapy, reflexology, nutrition, fitness, you know, counseling. You can get that anywhere, but you can get this all here, and it's for you, and it's for people who have sickle cell disease. And the other thing is that we're in Southwest Atlanta, and you're not going to find those services in Southwest Atlanta. So that's the other part. That's Thank you. Thank you.
I'm gonna breeze through. I intentionally limited myself in what I can present. Oh. This one. Okay. So thank you. I'm Sierra Gollin, one of the QI research nurse coordinators at Augusta University. I'm going to give just some brief updates on both the adult and pediatrics. We're separate but together. We continue collaboration. I think that's even improving more over the last year and a half with Sickle Cell Foundation and CHOA and Grady. You know, we're kind of off to the side. We like to do our own little thing and pretend like there's nobody else. So we're trying to coordinate more. We've been doing more with, we have outreach clinics in Southwest Georgia. So we're doing more with the Department of Public Health and Children's Medical Services staff to educate them and to get them more comfortable with sickle cell because they help us run the clinics. And then we've been really engaged in the TCD working group at the state level. We've just revamped some policies, procedures, helped the state with the manual to really, be cohesive because there's two main newborn sickle cell coordinators in the state, us and at CHOA. Okay, so this is very, very important to me. So I didn't add pictures, I didn't do anything because I'm just going to talk about it. So I have lupus, so I know what it's like to grow up with a chronic illness. And I can tell you at 18, 19, and 20 years old, I was not interested in talking about lupus. And I thought my 20-year-old body was going to continue. So that's part of that delusional thinking that you have when you're 20. So I love data, makes me crazy, but it also makes me elated. So I looked at we had our baseline data, and we have pretty robust internal data. And this is not out from the medical record. So looking at, my first thought was, what is our baseline for transition? So when I talk about transition, I'm not talking about pediatric transition. I'm talking about you came to your first appointment, hallelujah. And then what? Okay, because everybody says hallelujah. And then maybe we'll watch you for another year or two and and kind of go from there. So I thought, no, I'd rather look at them long term. So I looked at data from 2016 to 2024, ages of patients greater than 27 years. And we had 139 what we would consider new visits, like they hadn't been to see us before. And so part of this, 75% retention over the last 6 years. Now, definitions and research is everything. So this is, they came to at least one visit every year since their first visit. Okay, so it's not terrible. It's not great if you're SS, but it's not terrible. But then I looked at that data again. And so I also looked at those people and I said, of all of those who came during those years, 84% of them have had a visit in 2023. So, so you can cut the data in lots of different ways. And so, we cover Augusta, but we also cover outreach, in South Georgia. And one of the things I haven't looked at yet is the differences between our outreach clinic retention versus our in-city retention. So I think that might be very interesting as well. We've implemented transition readiness assessment at their first visit. So for those of you in non-comprehensive centers, but just adult care, we don't do that kind of stuff in adult care. They just come. We talk to them and we have a nice visit, but we don't really measure anything, or at least most of the centers I've talked to. So we've implemented doing that transition readiness assessment just for us to get a baseline understanding of where they are at. Okay. And so we did about 90% of our folks. The other 10% was on days I wasn't there and somebody forgot. So we looked at, what were the most frequently cited deficit areas. And this is not a surprise to anybody. Appointments, making their own first appointment, although our PEDS team is really good about now, before they leave their last PEDS appointment, they have to call right there and make their first adult appointment. And then purpose of the screening, retinal, echoes, urine, why do we do these tests? They don't know why. They just go. They give specimens. They have no idea. And then how do you refill your prescriptions? Okay. So with the focus for me on retention, and so our program is called Engagement in Adult Care. We're developing, we have a couple things we're still working on for a QI project, developing this process to ensure that all staff are documenting appropriately for transition. You know, the social worker will often talk about insurance stuff, the docs talk about the doc stuff, you know, the coordinators talk about other stuff, but to actually document it. And then also, you know, how long do we continue to document? Because hopefully we're going to see them for the rest of their lives. So those are things that we have to think about as well. And this is my love project right here. This is developing a social support group. And so, you know, it's already been mentioned a couple of times. These young people do not want to have more education on sickle cell. You say sickle cell and they're like, oh, you know, this type of thing. So we did focus group dinner, you know, so if we are to have social events and this kind of, what do you want? So we started an Instagram page. I had to get an Instagram account. I set it up and I said, now what? You know, so I don't run it. I mean, I'm more of a Facebooker myself. And they said, we want recipes. We want job postings. We want resume help. We want these other things. And then so they have to send us funny videos like, okay, so when we send things, we want them to open it. And part of it is I'm in the process of purchasing a mass texting platform with analytics, you know, where they can opt out. It's no HIPAA. You know, this is just messages out. And so if they get a text from us, which we're making them put our phone number into their phone, they'll open it and say, I wonder what my center sent to me. I wonder what the clinic sent. You know, it could be random stuff like Happy Earth Day, or here's a funny video that you might share with somebody. Or it's engaging on a personal, appropriate developmental level to know who they are and what they want. And then if we can sneak in some sickle cell, you know, then that's what we'll do. And they also say they don't have people to talk to about it. Well, guess what? We're having these social activities where, just like what Ms. Newman said before, is now they in a space where they can talk about these things. So we talked about what kind of quarterly events do you want? So next week, we're going to go watch a scary movie, Thursday. I have to fight with grants people though, because they don't want me to spend the money on entertainment. So we'll have to see how we do that, but we're going to buy the ticket. They've RSVP'd, give them a voucher for popcorn and a soda. And then we'll meet, you know, with that. And some of them, their mama's coming, you know, so it's, you know, so these are all people we have seen at least once in clinic. And I think we have 14 RSVP'd. 12 of them we've never had. They're very, very new to us. So I think it's a good opportunity to create that community for them, okay? And so hopefully the mass texting platform will work well. It has analytics. So if we send a link, we can see did they click the link? Did they not click the link? And again, it's no PHI, and we will do this as a quality, you know, have to figure out all the measures for showing improvement and engagement and pre and post and all this other type of thing. But I figured someone gave us some money, so let me do something with it before, you know, they take it away, and we'll see if this works. I just know I have a perspective of, I remember what it was like to not want to take your medicine, to be like, oh, I'm fine. Well, you are until you're not. And that's another way that we can connect with them. Okay, thank you. Yeah, I have to. Well, you know, it is difficult. So our branches are super difficult. Is it on? Oh.
Hello.
Hello, everybody. I am Shimona Johnson. I am the I'm the clinical data coordinator and the transition coordinator at Children's Healthcare of Atlanta. I work closely with Dr. Elna Saul, who's currently the director of the Sickle Cell Transition Program.
I'm Eldrita Randall, and I am the transition coordinator for the adult team. Our PI is Dr. Morgan McLemore, and as much as I am grieving Dr. Saw leaving, I will say, Dr. Cantor, I am happy that you will have her, because you all are two of the most passionate people I know in terms of working with patients with sickle cell disease. So I am just happy to see what you all are going to do once you have her.
So just want to go over some things that Dr. Saul went over last year in terms of the Embrace Project. It was mostly of just remaining engaged with our triad. Her form of triad is getting not just the pediatric side involved, but the adult side, as well as our community providers. And we have a good partnership with the Sickle Cell Foundation of Georgia, as well as collaborating with the Grady Emory side. Our team has improved a whole lot. We've actually facilitated our transition registry. It's up and running. Between me and Aldrita, whenever I get a patient that has completed their transition at Showa, that email goes directly to Aldrita, letting them know that they are ready to transition to Grady. As well, it also goes to our transition coordinator, who used to be our transition coordinator at the foundation. But it does also goes to the foundation as well for those patients that who are transitioning to Grady, but also to any other facility in the Atlanta area. We are currently putting a lot of process SOPs in place right now for communication plans. We're trying to update a lot of our operations in our EMR, our Epic system, by facilitating a lot of their transition documentation. Currently, right now, they're able to do the ASH assessment that they get every 6 months, just so that they're prepared before their scheduled appointments. Just key questions, seeing how prepared they are for transition. So that goes to them through their MyChart, or they're able to do it when they come into the clinic through a kiosk, which is automatically registered into their record. We are doing our transition clinics, which we call teen clinics, now twice a month at our new hospital that just opened in September. And we have it once a month at our Hughes Spalding location. And also, we just reinstated our Transition Grady Day. We call it now Transition Education Day, to somewhat collaborate everybody who's not just going to Grady, but also who's also maybe deciding to go to other facilities once they've transitioned out to us. Some of the focus that we've done for 2024, we have hired, on the CHOA side, hired 2 sickle cell staff members. We have a health educator right now who is actually helping re-innovate the SCD info website that Dr. Eckmore actually implemented. So they're doing that right now, and that's going to include a lot of our transition videos and modules that currently Dr. Saul has been working very hard of getting implemented for, I think, over the past year.
And on the adult side, the Grady side, Grady Health is the adult clinic. We service about, maybe in a year, about 1,800 individual patients. And Dr. James Ekman, many of you probably have heard of him. He started the clinic many years ago. This is actually the 40th year celebration of the clinic being in existence. And he kind of always did everything solo. didn't have a whole lot of adult physician help. So we are ecstatic now that we have 2 new sickle cell physician providers, Dr. Justin Yu and Dr. Tarun Aurora, who are fantastic. Dr. Yu and Dr. Aurora are both pediatric trained, I think, and then got the adult hematology training as well. And I this is just my personal opinion. I haven't done a QI project on this or not, but I do think those physicians that have that pediatric training, sometimes they connect better with transition patients. It's just something about Dr. Yu, Dr. Aurora, and Dr. Fasano, Ross Fasano, who absolutely connect with them, and it just makes it all easier. So we are ecstatic to have them on board.
Like I previously reinstated the Sickle Cell Education Transition Day. We had our first one in March, which was very successful. The patients were able to actually get a lot of information in reference to transition who never maybe attends our team clinics. Within that, they got to meet a lot of the staff members that were at Grady who were in attendance, as well as the Sickle Cell Foundation of Georgia. And for those who wanted to participate, they got a full out tour of the Sickle Cell Center at Grady. We've implemented an electronic transition referral process between Grady and CHOA. So it's basically an order referral that Grady will get once we have transitioned a patient. It's just given basic patient information, insurance information. It's sent directly through Epic, so that way it's easier for us to give that information to Grady, but it also is that allowing us to somewhat help with the follow-up process. So within the Epic system, we can see whether they have either been scheduled through Grady, or if not, that's where me and Aldrita do our hard work and making sure that those patients are either in contact with her, or if they're not being seen at Grady, making sure that they're in connection with any other providers in the Atlantic area. We've activated our post-transition surveys that we've developed in REDCap. Those are mostly just surveys, just trying to get opinions of how we actually gave them tools to prepare them for transition, what we can do better, as well as if they had any key points of what we can do to improve the center or improve the program overall. Like I said, we combined 2 of our sickle cell centers into 1 new hospital in September. So the Arthur M. Blank Hospital opened in September. We have designated 3 floors dedicated just for sickle cell patients, including 1 floor that's all an infusion center, as well as I believe 2 or 3 designated inpatient floors for those sickle cell patients who need care. Over the year, we've updated the registry as well. Aldrita and her hard work has indicated there are some patients that are not uninsured because of their age. So we implemented something in the REDCap system to send an alert to the Sickle Cell Foundation of Georgia to somewhat help with that. As well as we're starting to collect post-secondary education. We have a dedicated school teacher at one of our centers who helps with a lot of our patients who are maybe either going to college or some type of workforce. He keeps a lot of that data throughout the years, and he also follows up with a lot of those patients. So we started to collect a lot of that educational data to see where they're going, and possibly see how we can utilize a lot of that information for further QI projects. And also, we've also implemented a lot of special circumstances. We've noticed within the last year, we've had a couple of patients who were transitioned out of our care due to pregnancy. So we want to track those patients to not just say that we're just pushing you off to adult care, but making sure also they're receiving the proper care they need, or if they're in contact with Grady as well.
If I may add, Shimona, our original QI project was to develop a REDCap registry that would help us to know where transition patients are going, but most importantly, help us to know which ones aren't coming to Grady, because Grady and Choa already had the collaboration. And one of the first things that we did in starting this QI project was to post the position that we needed a transition data coordinator. And thanks to Dr. Saw, who reached out and pushed so that we could have that position, position got funded. And Shimona is being very modest here, but she has done everything. She has been phenomenal when she calls me and she's like, and I'm like, don't tell me you quitting, please. Whatever you do, why are you sighing? Because this has been something that if Dr. Saw and if they had not hired Shimona, this wouldn't be in place. And so I just want you to know she's being very modest. All of these additions, I call her and I say, hey, this patient isn't insured. I can't schedule this patient. What do we need to do? Oh, well, okay, let me go in, talk to somebody, and let's get that registry updated. She's done a phenomenal job in keeping that registry updated. And I'm just very happy to work on the team because I think we have collected a lot of good data that's going to help us in the future as we continue to try to track these transition patients. Go ahead. Oh, so the QI project progress. Our statewide planning and education QI project, we have been attending, of course, I think they call it Synergy. Is Synergy trainings? And we really love Jarvis Gray. Oh, I'm sorry. Okay. So Jarvis, we're working with Jarvis so that he can help us with our statewide planning education. And we also are collaborating with Pfizer through their sickle cell disease, rare disease group on operationalizing care and transition processing and optimization through the electronic medical record. Shimona and I have had a meeting with him and with that team, and we are looking forward to expanding on that. And if Miss Jeanette hadn't taken up all of our time, we could talk some more.
All right, lunch. We are sitting.
Okay, so we'll go ahead and get started for this afternoon. So everyone completed our CBO work plan report that we sent out to you guys. So we wanted to review that information and then turn everything over to our FPs so that they can lead the discussion and how we can use the data that was collected to modify the work plan. So this is just looking at the 22 versus 23 numbers in terms of population. And this is just based on what was submitted. So we know that it's a lot more, but this just gives us a general idea of what's happening. And we can see here with 2022, okay, we can see here 2022 and then the 2023 on the side. You can compare what's happening with FPs and TDPs. And then we have it in bar form here for you. And so we have the number of individuals that you will report as being in your state with sickle cell, the number that are in your service area, and then the number that you actually serve. And we have the TDP, FP data to the far left, and then on the right, TDP, FP for 22, 23. And I can send these slides out to you guys. So that's the number that the FPs reported that they served in 22, 23. I'm sure it's more, but that's just what was reported. Okay, and then looking at the patients linked to care, and I have this in a bar, I think it's in a bar form also. So the number of individuals linked to care, primary care within your institution, outside of your institution, and then the number of unaffiliated patients served. I'm sorry.
Just kind of using that for number of individuals in the institution versus outside of the institution. I think the numbers would be reversed for all programs because most of us don't have but we've got Miami.
How well is it defined? How well was the question defined? Like, what was within your institution? How was that defined?
I don't think there was any definition of what was.
Within your institution.
Yeah, so I think people could use it in different ways. If some people may have understood that as, I'm just giving an example, Central Alabama's not here, but Central Alabama might have claimed UAB as their institution as they answered that question.
But then with Miami in the mix, I could see how that would increase because they would often have their facility and they are.
Okay. All right, and then patients linked to specialty care. So the number that are linked to specialty care, and then the number that are linked to specialty care within a 50-mile radius of their residence. And then the numbers that are linked to primary care. So we can see there between 22 and 23. So for the most part, the numbers were about the same. They went down a little bit though. And the same thing, but in bar form. Okay, so the TDP successes, coordinating care with other providers. So this is what you guys said was what worked well in terms of working with other providers. So for those that responded, you mentioned that you do have relationships with providers across the state, that there seems to not be too many problems. It says, at least in pediatrics, we do not have problems coordinating patients with providers. Strong relationships with PCPs within and around our institution, and then some of the other providers that you all have relationships with. All right, and then the challenges of linking to with other providers. So long wait times, transportation, communication. Okay, and then strategies that was mentioned in terms of how to overcome those challenges. So having personal relationships with providers.
Can I ask a question that came up recently for our program, and whether it's happened for other programs as well?
We were in a state that didn't have managed care involved in Medicaid, and a couple years ago they went from none to about 95% of people within Medicaid being on managed care. And then we've had renegotiated contracts, so we'll have an insurer that our institution won't renew a contract with, and that'll cause churn, right? Like patients that need to rapidly be seen unless they can change their insurance, but they can't usually change their insurance in time. This has happened with United Healthcare for us, and looked like it was going to happen again for our Medicare Advantage plan people, though that the day that it was going to change, they finally agreed on a contract. But I wanted to bring that up. How many people have had significant disruptions because of insurance contracts that are at the institutional level?
All right, in Alabama, we don't have much. I don't think we have any managed Medicaid. but we have loads of managed Medicare. And that's where we have all of our problems. So we constantly don't take United or Aetna or Cigna. Those are the main three. And so we try to tell everyone to get straight Medicare. Don't get one of the HMOs. So similar issue, just with Medicare and not with Medicaid.
Okay, and our issue that we're dealing with, and we're going to try and deal with it at the state policy level, is if you come to Atlanta or Augusta and you have a Medicaid PPO, you're okay. But if you live anywhere else, try and find an ophthalmologist within 100 miles of Macon that sees Medicaid Amwell. You know, we've called them all. That most time they'll just hang up on you. You know, so it's significant for us. Problem.
We are in the same part. Something we ran into recently is that we have only one provider in Eastern North Carolina who will do cord decompression sickle cell. And that two of the Medicaid managed programs that he doesn't accept. So it comes up, you're stuck. We have to send them to Duke, or we need to hold off until the patient switches their managed care provider before they can get care. So yeah.
Thank you. Okay, so this is looking at the development of state-based and regional-based referral plans for individuals. And so we have the information that was received from our FPs and then our TDPs. So it kind of ranges from having a plan to with Dr. Alvarez and having a pretty comprehensive plan. And then Tennessee, this is just an example, I guess, of referral patterns from our CBO in Tennessee here and how they've divided the state to be able to care for everyone. All right, so our community support metrics. So these are the number of individuals and families that receive support from our CBOs. And we can see how it's increased from 22 to 23. And then some of the outreach activities. So ECHOs, primary care, education events, and then the target audience. So young adults, healthcare providers, support groups, adolescents, parents, nurses, and social workers. Some more outreach information, health screenings, chronic disease management. So these are some of the activities that our FPs have been putting together for our community. And then the virtual platforms used. So of course, we know during COVID, we started with our virtual platforms and then kind of stuck with it. So these are some of the virtual platforms that are being used right now, as well as social media. Right, and then some more support, young adult retreat, mentors, lots of support groups, back to school bash, giving tree parties. So these are some of the activities that our CBOs have been up to, how they've been supporting our patients. And then community resources. So a lot of housing assistance, food and utility assistance, transportation. Okay, community resources identified within the state. So 30 sickle cell based community-based organizations within one state, with a lot of medical resources, support, and advocacy groups. All right, so the next set of data is talking about the newborn screening program. So the successes. So here we see some of the successes, what's gone well in collaborating with newborn screening programs. You see what's happened between our FPs and TDPs. Okay. And then the relationship with state newborn screening program. So this kind of it varies from having a close relationship to not really having any kind of relationship. And I don't know that I put the one on here that says we don't have one, but you can see here between FPs and TDPs, the relationship that everyone has with our state newborn screening programs.
Okay, so I can tell you a lot about this. So newborn screening is required in all 50 states for sickle cell disease in the United States. There is no quality assurance done at the national or state level that is required. So you have to do the screening. There is actually no requirement to make sure that patient gets to a doctor, to make sure that patient gets to a specialist, to make sure that patient gets on penicillin. Certain states have specific quality assurance programs that they follow. When I was in Louisiana, as an example, I had to sign off on when I saw the person in clinic and started their penicillin therapy. And they made sure when they didn't reach patients, they would, send police and help to make sure what was going on. But we just wrote a paper that we're happy to share, Najiba Galandanchi, who I work with, where we interviewed 14 different newborn screening programs to look at the array of different follow-up, because one of the things that we have seen in the adult world is numerous 30-somethings who never saw a pediatric hematology provider. And unfortunately, we even have, I'll tell you, we have a pediatrician in Birmingham who's very familiar with sickle cell disease. So he manages all the patients and doesn't think he needs to send them, which is great, except that then they don't get any TCDs or MRIs or any other screening that they need. And he's very well known. And so there's a lot of interesting problems, but we are a nation of states. We are not a nation. And I don't know, honestly. I just know what I've seen, right? I have not spoken to this individual about it. I just know what I've seen. But we did a whole project across the board, quantitatively and qualitatively, looking at this, and then got denied on a recent NIH grant because people have this complete misunderstanding that newborn screening is perfect and we have no problems. And it's so far from that, because it is probably perfect in like 75% of people with sickle cell disease, 75% of children. It's probably okay for about 15% more. And then it's really not okay for about 10%. In South Carolina is another example. When we were there, we tried to take it over. And we did for 3 years until people got upset. They didn't even pay us. We just did it for free. And they still got upset because the coordination was so concerning. But there is a real lack of quality assurance. And as a community, we have not done a good job of demanding that quality assurance.
I would just also comment that I was surprised to hear that the parents are not even obliged to allow the sickle cell coordinator in North Carolina to be part of their care. So they provide a service, they can come, you say, no, I don't want you to follow me, and that's perfectly okay. And we've had children who have fallen through the cracks because of that.
So, which goes to some of our challenges working with state newborn screening programs. So language barriers for our TDPs, allowing professional services, but also educating on newer practices. So the communication between the two organizations. So we can see here some of our challenges with our FPs versus TDPs.
Our main problem in South Carolina is that there is a lapse of time between when the heel stick is done in the hospital and then it's analyzed at the state lab, and then they have to mail out the trait results to the CBOs. And a lot of time, by the time we get that list of addresses and phone numbers, a lot of the addresses are absolutely no good. they get returned when we send out letters. We keep trying to follow up with telephone numbers, but a lot of times those have been changed too. You know, it may have been a disposable cell or whatever. So it really causes us to have a lot of lost follow-ups because we just get bad communication, contact information.
Any other FPs have any comments to add? All right. And then strategies used to address those challenges. So a lot of meetings with state officials, meetings with newborn screening program. The JJ Foundation having additional languages. Right, and then our work plan. So this is where I really hand it off to the FPs to discuss the work plan, because we've seen what has happened over the last couple of years, how everyone has worked together, what you've done individually. And so now the work plan is what we had to develop for HRSA to show how we are truly working as a region. So how our FPs and TDPs are working together to provide care and go through the goals we have for Embrace. So this is the current responsibility and actions list for our work plan. And so we see here linking families to specialty care, identifying community-based services, linking to the state newborn screening program, using telehealth and virtual platforms, and then providing education and linking families to primary care. So these are the current responsibilities and actions. And these are some other agreements that were included. So referring individuals to the closest sickle cell center in their state for annual visits. And then also trying to provide training through ECHOs, symposiums, and having sickle cell experts being available. So I put these two on the same page because I know that there was discussion that our FPs wanted to lead in what needs to change here. So I will hand this over. That's fine. Okay. Here you go. You can keep that one.
Okay, so from what we just saw, it seems like linking families to specialty care and linking to the state newborn screening program seems to be the place where, as a region, we're not doing as well. Does anybody else see something that I missed? Is there another category? Yeah, well, I mean, when I look, I think I paid more attention to the challenges, and the successes than I actually did the numbers. Because, I don't, how we collect the numbers is going to be different from every place. And I'm not sure, and we kind of did this in a hurry, so I'm not really sure about the numbers, but it just kind of seemed in terms of the qualitative data that people provided, those seem to be the two areas where we need to maybe put some of our energies as a region. Why is nobody talking but me?
Because you said it all.
Is it because it's after lunch? Unaffiliated patients. Do we have like a whiteboard or something we can write this down? So
I
it's
think we don't even know where some of those unaffiliated patients are. I think both the FPs and the TDPs. The surveillance system tells us where they are, but does not tell us who they are. Right. I mean, we know the regions in our state where there is less access to care very well, but finding the patients that aren't in care that aren't in the emergency department is really hard.
Well, but kind of in line with what I hear Julie saying, at least that's a start. You know, we may not know the specific patient, but we know where they are. And if the surveillance data is telling us that there's no sickle cell center there, we know that that's an access to care problem. So even though we may not know who they are individually, it does give us information in terms of what do we need to do in this part of the state or this part of the region to increase access to care.
Yeah.
You know, and I think that kind of like, I think we have to have some strategic discussions about, you know, one of the things that I'm just getting more sophisticated about is the need to have somebody go to a comprehensive sickle cell center at least once a year, you know?
Yep.
And
Get
so,
linked in.
and so I think it's like, because, you know, coming to, you know, my whole thing about access to care is just get them into care. So I'm learning something a little bit different, that's not enough. There's another step. So I think we have to do both of those things. We have to figure out how do we get care to those people, Sierra, that live 4 hours away from the center? How do we get regular care or semi-regular care to them? One. And then those people that live 4 hours away, what is it that we need to put in place to attach to whatever we're doing in that space so that they can get to the comprehensive center at least once a year, or take the center to them? You know, I've been trying to give Grady a bus for like 3 years now. They don't have anybody to put on the bus.
Yeah, we've been really, really successful in doing that with Duke. The particular region that I serve, I consider it a sickle cell desert. Like there is no hematology.
Y'all have
and-
more centers than every other state though.
But the barriers and the access to getting to the centers is what we're having a hard time with getting through. So, you know, so Duke comes down to the Fayetteville area every other month to provide clinic. And we are still having a hard time with getting clients within those regions to actually attend those clinics. So it's something else that's going on that we haven't really put our fingers on.
So you may not know this, so I apologize if I'm preaching to the choir. So we have a whole project dedicated to this. Sierra is part of the project called Recipe, and it's really trying to identify where unaffiliated individuals are located, identify how and when and where and how they became unaffiliated, if they were ever affiliated, identify what they want as people living with sickle cell disease, and then identify where the barriers and facilitators are. And we're still early in this project. So I can tell you I've had 220 referrals or new patients to UAB in the last 18 months or something ridiculous. And this is without, quite honestly, trying about half of the planes we had planned to try. Sierra can tell you a different story of what they're doing in Augusta, because they've had to work a little harder than I did. I had to throw up my shingle and all this, that was really it. So what we have found so far, though, I can tell you, one is that so we developed, so the whole grant, for anybody who doesn't know this, the whole grant is about not just trying to figure out who they are and where they are, but how do we best engage them and get them into care. And so we've established what we call a linkage coordinator, and this is all adapted from HIV. We all, as a sickle cell community, need to learn more from what HIV has done. I mean, I think that there are so many good lessons. I think we spent too much time comparing ourselves to cystic fibrosis and hemophilia, who do not face the stigma that our patients face. The HIV world knows this stigma. And they have a much better, book to follow. It's not perfect, but it's going to, I think, really help us provide some direction. So what we did is understood what they did, and what they have are linkage coordinators, physical people to go talk to someone when they're in the ER, to reach out to them, someone that's not me, someone that can talk more on their level, whatever that level is. And what we're trying to do is assess the efficacy of that intervention. So I can't tell you what the efficacy is yet, because we really just started it. But I can tell you that people appreciate it. It's what we call a warm touch. And we figured this out when I was in South Carolina. About 90% of new patients wouldn't show up. They were all no-shows, about 90%. And when we added in, at the time, just a social worker who did outreach coordination, reached out to them ahead of time, talked to them, looked at their barriers, it moved to 75% that showed up. And it was a huge difference. And there's a lot of reasons for that. But so some of the top ones are that many of the adults, especially 30s to 50s to 70s, didn't know sickle cell specialists existed. and they feel like I'm fine now. Why do I need you? And that's okay. Do they need us? Yeah, they do. But maybe it's going to take some time. And so, can we call and check on you? Here's what we can offer. Here's why you should be seen. So that's what a lot of what our linkage coordinators do. Surveillance data helps us understand 2 or 3 different things. It helps us look in where the ER hotspots are. So where are their local emergency departments? Piedmont, great example. Border between Columbus and Georgia and in Phoenix City, Alabama. Huge area of need. Huge number of people who go to that hospital unfortunately die in that hospital. Hospitals, Piedmont's a group of hospitals. Anyway. So there's a huge area. So they can tell you that, but they can also tell you if there's a group of people living with sickle cell disease not going to the emergency department. And then that's when you can work with Medicaid and reach out to them and reach out to Medicare and say, hey, can we talk to your case coordinators about how we can help these people? Because they can talk to the patients. And you don't have to do all these things at once, right? Pick one thing. Really don't do them all at once. So you'll get 10 referrals a week. So just some ideas, but there are ways to use the surveillance data to point you in the right direction. It can also be going to the ER and saying, hey, I'm here, call me, let me help you. Some ERs are receptive, some do not want to talk to you, and that's okay too. But we have found that there's like this bag of strategies, and we're happy to share all those different ones, but it really is, it's an incredibly impactful experience. And when the people do come who really want to be seen, they are the most grateful humans I've ever met.
I just wanted to add to that. And so one of the things that this grant has allowed us to do is we've taken our show on the road to providers, because I think in Southwest Georgia, we probably put 800 miles on just going from, if there was a provider, a Department of Public Health, anybody, we'd stop, talk to them about, we've been around for 50 years. They didn't even know because turnover, people don't know. And we also highlighted to them that, yes, you can see your local hematologist and a sickle cell specialist. Medicaid allows it. We don't want to take, and so to the providers, we're like, we don't want to take your patient. We want to partner with you. And then, to all these other places, we're like, we are happy to provide support services to you, CEUs, whatever you want. And most of the time, the reception was really good. We talked about barriers of transportation, that type of thing. I said, these are things that we can work on. And we've established contact people in Bainbridge, in Cairo, Georgia, in all these different little places. And we just reach out to them periodically and say, hey, we have this, but just so that they know that we're even a resource to even consider sending their patients. And then I think, like you were saying, Jeanette, is so many people thought, well, I see hematology, I'm good. We're like, well, actually, let's just take it that next step to see a specialist, someone who really, really, really cares about the sickle cell. And so it's been educating a lot of providers has really been helpful to us as well.
Yeah, somebody mentioned they have no compassion for North Carolina. We do have a pretty, I do think our state has a very comprehensive program, and we appreciate the taxpayers of North Carolina for that. For example, when I go out to our Ridge Clinic, the CBO person comes with me. They call the patients ahead of time. Our social worker calls them ahead of time, yet there are people who don't show up. We have people who are not affiliated by choice. It's possible, especially the adults, they saw somebody 10 years ago and they didn't like the vibe, so they say, I'm not coming. And there is nothing you do about it. You have new providers. They don't even want to come back to see those providers. Then there is a medical system. I will tell you, in our healthcare, if you do not show twice, they're not going to reschedule you. So there are people who coordinate everything. They don't know show, and then they're not going to schedule. They tell me we're not going to make exceptions for sickle cell. This is just a policy that if you don't show, we just say you don't want to see us. And that is your right not to want to see you.
that is lost to follow up, did you contact the CBO and try to say, this guy is not showing up? Can you help me?
We do.
And what happens?
Sometimes they show, sometimes they see.
Okay.
Only do that if either we already have a release of information or they're already a current client and we know that. So that's a big barrier.
So I think that's one of the areas that is, I think that's one of the areas that's different in North Carolina, in that the comprehensive sickle cell clinics, who are also part of the newborn screening follow-up program, or the North Carolina State Sickle Cell Syndrome Program, along with the CBO, we have that access to be able to share client information and to be able to have those communications and reach out. And some, like Dr. Fu says, sometimes it works and sometimes it doesn't. But at least we have that mechanism in place that, you know, we can do that. There have been times that, you know, Dr. Strauss has reached out and said, hey, we're having issues with this client. We're able to contact the client, boots on the ground, and hopefully encourage those clients to make their appointments as needed. So that's one thing that's a little different for us. The other thing is that, you know, we have access to the clinics. Our case managers and community health workers, we show up in clinics. They have allowed us that space so that if there are unmet needs while they're getting their clinical services, then we're able to supply those wraparound services. And so that is another caveat that makes a little bit what we do in North Carolina a little bit different from other places.
Trying to add my own as a primary care physician. So the people Julie sees in Birmingham, I think, outliers. There are rhinos, there are zebras. Most primary care physicians want their patients to have a hematologist. 99% of us want you to be. What I want to ask the hematologist in the room is, please reciprocate. If you have a patient who is a patient of yours, encourage them to have a primary care provider. So at the University of Mississippi, it's standard. Every patient who comes through the door to the hematologist gets referred to primary care, whether they want to or not, whether they show up. So I just expect my hematology colleagues to do what we should do as well. The same way we refer, the same way you guys encourage them to come to us. Because for us, it's due diligence. It's easier for us. It's not rocket science. So I think the guy in Birmingham is an outlier. I think most of us want you to have the lion's share of the care.
Let me ask you a question. How much availability do you have as a primary care provider?
So as an academic center, if you can't see me, you can see my residents within a week to 2 weeks. You can get in within a week or 2 weeks. You may not see the attending, but you'll see one of our residents.
Yeah. This is where education is such a big deal, because I mean, in case y'all didn't know, Dr. Kutlar is also a primary care provider. He's not. They list him as that constantly, and we automatically refer for PCP, but we keep talking to our patients, and they're like, "Well, why do I need to have one?" And we tell them, and they're like, "Well, but I come. It's all I can do to come to my hematology clinic, and y'all do everything for me because I won't go to a PCP." So we're kind of stuck, because do you not do stuff, or what do you do?
You bring a primary care doctor in.
Yeah, I think this is where it comes down to, if you really want to be patient-centered, embedded primary care. I mean, I was a primary care doctor from 1996 to 2000 when I did my internal medicine residency, and was a resident and had some competency. That competency has faded quite a bit with the changing of the hair to gray. But I think that embedded primary care works great if your patients live close. But if someone lives 60 miles away from me, I want boots on the ground. I want them to have a local doctor to do their primary care. And it's something that we talk about. We don't enforce it, you know, and I think that our program historically, when I came, we were doing mammograms and colonoscopy screening and other things that firmly belong in primary care as part of our services, referring to that. And I think that it's a lot to take on, and there's some things that we don't do. You know, I've never seen a note where we talk about injury risk reduction, you know, with people, or ask about smoke alarms or firearms, which I've had a patient with sickle cell disease die of firearm injury, you know, that might have been prevented if we had focused on that.
I did hear you say you enforce. So we have had this tension within our center. I am one of the old school person that if you have sickle cell and you come and you're out of asthma medication, I will refill it. Some of my partners you are then participating in them not going to your primary care provider because you are refilling that medication. How far do you go in enforcing this?
So I actually think that's a great question. And anybody who hasn't heard, and even if you already have heard from Pat Carroll, who's going to be our speaker tomorrow for our keynote, and he's going to talk about opiate use. And I quote Pat Carroll more than he would ever like me to quote him. But one of the things that he says that rings true is if you want somebody to stop doing something, you also have to stop doing it. And I had a patient referred to me from a clinic recently who was taking too much oxycodone and admitted that he was taking too much oxycodone, but the doctors kept prescribing him oxycodone. You can only expect so much of anybody. So I think we put a time limit on it, to answer your question. If it's related to their sickle cell disease care, asthma, psychologic meds, not antipsychotics, but sleep meds, we will continue all of those because I do think it's in my like field where I'm comfortable to manage that. Now, we do have an embedded primary care doctor. She is unbelievable. I recommend everyone have an embedded primary care doctor, especially on the adult side. I mean, I do think there's a little bit easier to convince people to see a primary care doctor from pediatrics, in my experience, because I've been on both sides. But there's something else I want to call attention to, and I was going to put it up tomorrow, but I'll mention it briefly. So there's new legislation. God knows what is going to happen right now, right? Let's be honest. I mean, there's a reason I look like I do today, but, and it wasn't just the travel. It wasn't just the travel. But let's just pretend. So there is new legislation that's been championed by Medicaid that is, I mean, championed by ASH and Medicaid. That's not clear, but like much of legislation is, it will allow for specialized medical homes, which is something that the Alliance has really been trying to push as a payment model. If our centers can be labeled as specialized medical homes, we have access to more funds and more reimbursement, specifically in the area of mental health and care coordination. So there's some really great opportunities coming. There's some separate opportunities coming through the CMMI gene therapy. These are totally different things. But it's another reason to start really looking at a business case, especially for adult centers, to providing that primary care. Because it's going to allow you to become a specialized medical home, which will allow you to tap into additional funds. So there's some other interesting things there, but we put a time limit on it. And usually it will take them running out for a month before they will do it, or we have to help. I think there's, for a long time, I thought everybody was the same as me. And what I mean by that is if I think that if I need to find a doctor, eventually I'm going to pick up the phone or look online, right, and find somebody. And we think that other people can do that too. And that neurocognitive function, it took me a long time in my early days of medicine, right, long before the gray hair, that to learn that. But I think it's something that I know a lot of my nurses get frustrated. Why don't they just do this? Because what seems easy to you isn't necessarily easy to them. And we will call and find them a primary care doctor. That is an overwhelming task. What does that mean? How do I look? How do I even ask the right questions? So I have found that we have to, and I get called an enabler, and maybe I am. Oh, well.
How many of you who are providers use your local community health worker to link your patients to care?
How many have a community health worker?
That's a better question.
We don't have community health.
You know, it's statewide. In Mississippi, community health workers are not a thing.
We want our online health.
So it has to be, you have to go state by state.
I thought I thought all of the states had,
They do, but I
all of the
guess-
states in the region had a follow-up program. But all follow-up programs are supposed to have community health workers. I mean, that's the whole point of the follow-up program is to hire community health workers. So how many people have community health workers in here? Right here.
So you're really asking how many of the not provider, the community-based organizations and the
How many
FPs?
community-based organizations have community health workers? And you're all follow-up program grantees? And how many providers are linked to the people who raised their hands? No?
So I don't know anything about your NOFO to be in this regard, to be perfectly honest, but is it, I'm thinking language and language, does it have to be a CHW or does it have to be someone who links to care?
Okay, so let me do a quick and dirty history of this. All right, so the whole notion of using community health workers in sickle cell started in 2015. And so, you know, community health workers have been very effective internationally for managing community health, especially in hard to reach areas. So I really kind of started as a 2-year pilot program to determine if using community health workers, training them, and then using them in the sickle cell sector could improve health outcomes. 2 primary objectives. One is to get them into specialty care and get them into primary care and keep them there. And then all the other things in terms of addressing the social determinants of health, because you have to address those things for a lot of groups to get them in care. And so it then became, it was funded for another 4 years after that 2-year pilot. And then 4 years, we're currently in I think the last year of a 5-year funding. So the NOFO for this current funding is the same, is to improve health outcomes of individuals living with sickle cell disease. It's also to support their families. And it's also to build a regional network, which is what Ophelia is doing in Florida, and we're trying to do in Georgia, is to build a regional network so that people can access services where they live. That's part of the NOFO for the follow-up program. It is also to work with the Treatment Demonstration Project to achieve the same end that the treatment project is trying to achieve, which is improve access to care. And so on the follow-up program side, the focus is on adults in transition. So that's kind of the crux of it, right? That's the crux of it. So the follow-up program is to have community health workers.
And I was just asking if it had to be a technical community health worker.
I mean, you can change the terminology.
That's what I was asking.
But it's basically, it's somebody who works in the community, has access to people living with sickle cell disease, can establish relationships in the community, get them into care and keep them into care. If they're no longer in care, get them into care, find them and get them into care. So there's a lot of case finding involved with community health workers, you know, and then there's the newborn screening component, which is really doing follow-up to make sure that these children have a confirmatory test after they're born, and then after they get that initial diagnosis, and then that they're getting the appropriate preventative therapies.
Recap a couple things from yesterday. This is going to be really short, no slides. I want to give, since Pat Carroll's here, I want to give him some extra time because I know that he sometimes gets a few questions after talking, but my voice is getting much deeper. I wanted to recap just some of the things that I heard that people were doing that I thought were really exciting and innovative. And I wanted to focus on a couple of areas. One was transition, because I think that we all struggle with transition, no matter how many great people we have working on it. And some things I heard is choosing the right person for if you have the luxury of being able to afford a transition coordinator, choosing the right person, and that's someone who will really connect with the teenagers and the young adults, and invest in them and invest in your institution. And I think that we need to help each other with how to select these people and then how to train them to be successful and to stay, right? Because we all know that turnover. I also heard that turnover was a theme. There have been some programs that have had a lot of turnover in their personnel. And, I'm on my second social worker and my fourth sickle cell educator in 8 years. And the social worker, it's great to only have, I'm I'm on my third social worker. 3 in 8 years is not bad, but for the sickle cell educators, that 4 in 8 years includes three in the last 2 years, right? So that's the same person that does transition. So our transition programs struggle because of that. So I think what are the best practices in choosing and developing the people that work on our teams, particularly positions that might not be something that we have a lot of experience with, like a sickle cell educator or transition coordinator, where there aren't positions like that across the institution. And then I heard about innovative programs that when we are trying to engage with with that group, that they don't necessarily want to be talking about sickle cell disease. So how can we get them talking about other stuff and then have some sickle cell content in there? How do we help them create their own community and have that community be a place which is safe for them to talk about things sickle cell and not sickle cell. And then I heard about some real exciting things in the transportation space, right? So you heard about a little bit from Julia about medical Uber and how that's helped their program decrease no-show rates, and other people that have focused on transportation as a barrier to decrease no-show rates, and thinking about how we can partner better in that area. And then we started to talk about how we could partner with our follow-up programs and our sickle cell treatment demonstration programs in a couple of areas. And while newborn screening follow-up remains an interest, recognizing that there's some barriers with getting data to track that, but how can we really reach out to those unaffiliated patients and connect with them? And also, how do we develop better communication approaches for our transition age patients? All right, and with that, I'm going to move on to introducing, well, is there anything, what things did I miss? Are there other things that really stuck out for people that I didn't pick up on? Oh yeah, well yes, and I'm sorry, and also connecting with primary care, and recognizing, I think, for that and for these other things, that the model needs to fit your program. So if your program is really geographically compact, which we don't have as many of in the Southeast, but if you're in the Atlanta metro area, that embedded care might work really well for you. Or if you have some people that are a fairly good population of patients that are close, if you're in a big city, even if some people come from far away, that embedded care might work. But for other models, you might need to work on a network approach. And how do you get people to primary care and convince them that they need primary care? And sometimes it's saying, no, that I won't treat your rash, or I need to get you to the right doctor for that. And that might not be a dermatologist, because you're going to wait 4 months, right? That you really want a primary care doctor that you can get into in the next few days. Right. The 6 things that are going to be sent out to us to work on, and a deadline, right? That we need to get it. We need to have some progress by that 3-month follow-up by January. All right. Other things. With that, I wanted to introduce Dr. Pat Carroll, who is a psychiatrist and a sickle cell provider. And I think Pat was the first sickle cell psychiatrist, the first person that really focused on sickle cell disease with pain management and behavioral health as their academic interest. There certainly were a number of psychologists I can think of. And like all good things, Pat has worked to train other people. And now we have more than one. They're not enough for all of us, which is what we want. And Pat really has been a leader on how you integrate pain management and also behavioral health services for people with sickle cell disease, and really is, a national leader on pain management for sickle cell disease, particularly for people that have challenging to manage pain and a lot of healthcare utilization. And he is currently an associate professor at Johns Hopkins University in the Department of Psychiatry and works in the Sickle Cell Center for Adults there as well. And with that, I'm going to pass along the mic to him.
Hey, everybody. Get my slides up. Do I just, oh, there's a clicker. All right. Do I have a cap to win it or? Yep. Okay. That work? Okay. Oh, okay. Usually better if I just yell, but anyway. Yeah. There we go. Okay. Hey everybody. I'm Pat. So most of the things that JJ just said are true. I won't tell you which ones weren't. The other thing that he didn't say, and he and Julie are both well aware of, is I'm kind of a pain in the neck. And one of the reasons I'm kind of a pain in the neck is that I am a kind of congenital heretic. If you put any idea, theory, hypothesis, anything in front of me, my first instinct is to tear it to shreds. I'm like a terrier puppy that you can't keep any slippers in the house with, you know? So I'm going to go through some things that we tend to talk about in the sickle cell disease world and maybe accept a little too uncritically and do what I do, which is mostly tear them to shreds. But I sometimes struggle to come up with a synthesis, you know, a set of recommendations for what to actually do rather than what to not to do, but I'm going to try. So at the end, I'm going to talk a little bit about what I think we should do to set right these things. All right, that was long-winded. Oh my God. These people ain't paid me yet. So first, I'm dividing this up into themes. And so I'll talk through it and summarize a little bit and we'll keep moving on. I'll see if I can build something. First thing is, nice shot. First thing is, many of the ideas and even the numbers that we throw around about pain and sickle cell disease are either wrong or deceptive. Now, what I mean by deceptive here is not that anybody's trying to lie to you, particularly around like the numbers. The numbers is what the numbers is. They're calculated straight and all that. But there's words that we think mean something and they don't mean that, like more particularly average and typical. We often think about as synonyms. And there are certain situations where they are, and there are certain situations where they aren't. And with pain and sickle cell disease, it's often kind of a game of outliers. And so in those kinds of distributions, the average and the typical don't often line up. So case in point, pain frequency. You'll hear that like written in a bunch of papers and so on and reported and even used in indications for like transplant. If you read most of those papers, you will hear that the pain frequency for people with sickle cell disease is 2 to maybe 8 times a year, depending on how it's counted. Usually the operationalization of that is contacts with the healthcare system, ED visits, hospitalization, so on and so forth, which is a massive underestimation of pain frequency in sickle cell disease. So this is a slide, well, 2 figures from one paper, the Pisces study, which I assume most people in the room are familiar with, so I'm not going to beat to death, but just to point it out. So this here, these are adults with sickle cell disease doing pain diaries. This thing here, 3.5%, that was the amount of time people said they were in the hospital, ED, admitted, whatever. So that's typically what's been counted as pain frequency, right? Below that, about 3 or 4 times as big is amount of time people said they had crisis pain, but were not in the hospital. And below that, about 3 times as much is the amount of time people said they were in pain, they didn't call a crisis, right? So you want actual pain frequency, it's that, not that, right? Another thing to point out, talking about things we throw around as if they are mutually exclusive, but probably aren't. So here is like pain frequency by severity and so on. But one thing to point out here is if you do a little math here, over half of people had pain most days, and about 30% had pain pretty much every day. And the people who had really infrequent pain still reported not all of it was crisis. So we talk about acute or chronic pain and the acute to chronic pain transition, except people have both all the time. Even people who only have infrequent pain is not all crisis. So this whole idea that acute pain becomes chronic pain rather than non-crisis pain becomes chronic pain, I don't think holds water. All right. And then I told you about, so on the one hand, when you use crisis frequency as utilization, then that's a massive underestimate of pain, right? At the same time, our estimates of utilization are usually averages. And if you think that's typical, you're also wrong. That's a massive overestimate. So this is what the distribution of hospitalizations, ED visits, any kind of care contact in sickle cell disease always looks like. These are two of my papers. I've done some in our own clinic. I've seen other people's distributions. Always looks like this. So there's like a needle right around 0. And then this long right tail that goes all the way out to Mongolia, up to and including, you will generally have one person in a medium-sized state, as many as 5 people in Texas and California who are hospitalized literally weekly or more often. And because means are really influenced by outliers, the mean gets shifted to the right. So the median is almost always 0 if you're looking at yearly data. Back when I had 3 years of data, and this was a while back, and so it may have shifted, the median was actually more like 1 hospitalization every 2 years. The average is usually something like 2 to 4, right? So if you think average is typical, or you hear someone say the average patient with sickle cell disease in the hospital, blah, blah times, they're usually wrong because it's way off from what's actually typical. Same thing for opioids. So if you ever hear anything about the average person with sickle cell disease takes X amount of opioids, that's usually not typical. This here is a slide from our clinic. This is Liz Prince's study, one of my colleagues, also a psychiatrist. But if you look up Jin Han's study out of Chicago, it looks almost exactly like this. It's just they did a histogram instead of a density plot, and I like those. But anyway, so these are people in our clinic that we prescribe the opioids for who are not taking buprenorphine. And you'll see 0 is typical. But again, you do have people who are on pretty darn high doses. Like there's people in here who, for example, are probably both fast metabolizers of methadone and on a high dose of methadone for people who are fast metabolizers of methadone. So it's just astronomical. By the way, none of these 3 people are still on this kind of dose, just so you know. But again, if you calculate the average for this, it would be a massive overestimate of what's typical. Also, by the way, these 2 things don't really hang together. I often hear people talk about the amount of opioid people take and the amount of time they're in the hospital, like those 2 things have this synergy. And in our clinic, turns out I don't think that's true. So if you look at a simple correlation, right, between the amount of opioid people take as outpatient and how often they're in the hospital, there is one. It's positive, but it's real weak. So that's this like gray line here. But if the relationship was all that strong, you should see a lot of people up here, right? You should see a lot of people with, frequent hospitalizations on high doses of opioids, and they just ain't there. So if you do a more complicated analysis, which is this splined thing down here, what it really kind of boils down to is people who average less than a pill a day, the amount of opioid they take does relate to how often they're in the hospital. I figure those are probably people who got treated for a crisis sometime that year, probably got a prescription before they went in or after on discharge, and then, came out and that was their opioids for the year. But then if you get the people who are taking an average of a pill a day or more, line flattens straight out, has nothing to do with each other. There might be a reason this is different in our clinic than other places, but I'll talk about that later. All right, so summing all that up. We underestimate crisis frequency. We use it as a model of how often people have pain, and that's wrong because people have pain a whole lot more than they have crisis and way more than they're in the hospital. So all these numbers tend to be off. Yeah, all right, next. So we talk like things are mutually exclusive categories when they in fact probably are not. And we talk about inconsistent relationships as if they have a lot of explanatory power. I'm going to talk about this a lot when I'm talking about mechanisms of chronic pain and how you tell acute and chronic pain from each other. So chronic pain, it's kind of a mystery in sickle cell disease, right? So we have the story we tell about crisis pain. Sickled cells pile up in blood vessels, they interact with the endothelium, they block stuff off, they cause ischemia, they cause inflammatory responses, blah, blah, blah. It's nociceptive pain, right? There's actual threat and damage to tissues, and that's why. Chronic pain, you can't necessarily see that the sickled cells are doing anything different when someone has chronic pain than any other time in their lives or any time of the day. And stuff that we know prevents crises tends not to do a whole lot for chronic pain. So for one thing, doesn't reverse it. So you can transfuse someone down to a really low hemoglobin S percentage and their chronic pain doesn't exactly disappear. Doesn't even change intensity very much. People with bone marrow transplant who have chronic pain and are already taking opioids, very often a year after they're still taking opioids for a disease that theoretically they don't have anymore. And hydroxyurea doesn't seem to do a whole lot for chronic pain once it's set up, though it might alter the intensity a little bit. So chronic pain don't act like we think it ought to act for it to be nociceptive pain and to follow the rules that we think we know for crises. So one reason that people throw around for this is the idea that chronic pain has a different mechanism, that it's neuropathic pain, whereas crisis pain is nociceptive pain, right? The nervous system has rearranged itself through the disease process to be more sensitive to pain, to generate pain signals and so on. And this happens, and it happens in a lot of chronic pain conditions. There are some chronic pain conditions where that's the only thing you can see happening. So, and there's plenty of evidence that this happens in sickle cell disease. So there's a lot of studies in sickle cell mice that show that they become more and more sensitive to pain as they age. There's studies in people with sickle cell disease I'm about to show you that show that people with sickle cell disease tend to be more sensitive to pain. But the idea that chronic pain is entirely nociplastic and acute pain is entirely nociceptive, and we can tell the difference between the two, I think is incorrect. So I'm going to walk through why I think this. So this is one study, two figures. This is the cleaned up version. The cleaned up version is we took people with, well, not we, Bob Maloki and Diane Wilkie and that bunch in Chicago. So we took people with sickle cell disease and healthy African-American controls, and we did a bunch of stimuli, and we measured how much pain they experienced basically for different pressures, different heats, different levels of cold, and so on. And then set a threshold for sensitive, right? And then how many people with sickle cell disease crossed that threshold and how many people who did not have sickle cell disease crossed that threshold. And you see that the people with sickle cell disease, that's orange, were more likely to cross the threshold more often for mechanical pain and cold. The other thing you'll notice is they overlap by about half, right? So it's not like there's a qualitative difference between this, it's quantitative. Now, what happens if you don't clean the data up and pseudo-dichotomize something that's continuous? That's these blobs over here. It's much uglier, but I kind of like ugly. So this here is healthy folks. This is people with sickle cell disease. This is the cold, the heat, and the mechanical. For this one, this way is more sensitive. For these two, this way is more sensitive. The point I want to make is these blobs overlap a lot, right? It's not like, you know, sickle cell disease is from Mars and healthy is from Venus here. And so this is what happens when you don't clean up the data and pseudo-dichotomize and do all that stuff. And in fact, these quantitative sensory tests, they are always really noisy. There's massive inter-individual variability and there's massive overlap with normal. So the idea that you can do QST and then figure out who has sickle cell disease, much less who with sickle cell disease has chronic pain, don't hold water, right? So you can't reason backwards. So it is true that the nervous system alters on average in the course of sickle cell disease and the development of chronic pain. It is not true that you can say for sure that is the sole mechanism of chronic pain, nor if someone has chronic pain that this is the only thing going on. I think this is why. This is another cleaned up study. I was part of this one. So it is true that when you do look at these relationships, there does seem to be some consistency that central sensitization, for example, that's one mechanism by which people can become more sensitive to pain, does seem to hang together with chronic pain, particularly, but also acute pain a little bit. This is a study where Dr. Campbell, who's one of my colleagues at Hopkins, took people with sickle cell disease, did all these like tests, and stuck together a bunch of them into the central sensitization index, which is an idea of how reactive the spinal cord and the brain are to pain. Bless you. And like I said, this is cleaned up, multiple different measures all stuck together into one index to filter out the variability, and the middle's cut out. So it's comparing the extremes, the low to the high. So this is also pseudo-dichotomized. But anyway, what you find is that central sensitization was associated with worse pain, and most particularly worse non-crisis pain all the way through. There were relationships to crisis pain, but it particularly tended to hang together with non-crisis pain. So to that extent, this idea that central sensitization has something to do with non-crisis and chronic pain, I think holds water. But again, I don't think it's qualitative. I think it's quantitative. And oh, by the way, these are mice. These are normal mice. These are mice that have been genetically engineered to have sickle cell disease. And right about here, poor Mickey is put in a low oxygen environment. And you will see that the sickle mice, when put into crisis, their pain thresholds go off a cliff. So if hyperalgesia causes chronic pain, which is a different thing than crisis, why does crisis cause hyperalgesia? It just does, right? So the idea that crisis is entirely nociceptive also doesn't hang. It's all going on all at the same time. All right, so I don't think we can say acute pain is qualitatively different from chronic pain. Please don't come around me saying, no, that patient's having an exacerbation of acute pain, of chronic pain. It's not a crisis. You can't tell. All you can tell is it's pain, just like everybody else. You cannot, I think, say that if this is a crisis versus this is chronic pain, it has a completely different mechanism, therefore must be treated any better, any differently. And by the way, I don't think we know how to match treatments to mechanism anyway. That's the next part of the talk. And yeah, that's probably what I had to say. All right, next. All right. Claims that we can match treatment to pain by mechanism or quality, I think, are overstated, maybe wrong. And the medicines and such that we use for pain, most of the medicines are a lot more complicated than we tend to talk, and that can be dangerous. Let's talk about other chronic pain conditions, osteoarthritis. So we usually think of osteoarthritis as kind of a fairly nociceptive kind of pain, right? The cartilage wears away, bone grinds on bone. That ain't pleasant. And, nociceptive, the idea is that the nervous system itself is not really altered. It's sort of a true transmitter of true signals of possible tissue damage. It's not amplifying anything. It's just acting like a true reporter. So osteoarthritis we usually think of as just, the knee hurts and the nervous system's not involved, other than just to sort of report to the brain. But people who have evidence of sensitization to pain with no knee pain are more likely to later develop knee pain. So prior setting of your nervous system seems to influence who detects pain in their knee earlier, probably. If you have people who have osteoarthritis and compare them to people who don't, the ones who have the osteoarthritis tend to be more sensitive to pain, just like people with sickle cell disease and almost every other chronic pain condition if you bother to look. And it's notorious that for almost every chronic pain condition, anything you see on a scan doesn't necessarily correlate all that well with how much pain people feel. So, I work on an inpatient chronic pain treatment unit when I'm not looking after people with sickle cell disease. And I've had people come in wheelchairs whose back MRI quite literally looks better than mine. They have pain of 7 out of 10. Mine's usually 3, So there's this gap between what you can see that's supposed to be quote unquote causing the pain and how much pain people experience. And in knee osteoarthritis, if you get radiologists to rate the severity of the knee on an X-ray, again, it doesn't correlate all that well with the pain across people. Across knees, it does. If they're connected to the same nervous system, it does. But if you do quantitative sensory testing and look at the sensitivity thing, how sensitized or sensitive someone's nervous system is to pain does seem to explain some of that gap. Right? So people have more sensitive to pain with lower grade knees might have more pain. Right? I have doubts about that too. And that gets into the mind-body problem. So ask me about that in another half hour. Anyway, so the things that we think are nociceptive pains and the thing that we think are neuropathic pains, we often say, well, we use neuropathic medicines for the neuropathic pains, and we use the other medicines for the nociceptive pains, right? You break your arm, you get one thing, you have trigeminal neuralgia, you get another set of things. All fine and good, except when you actually look at evidence bases and try all the different things for all the different conditions, and then particularly for if you look at the guidelines for all these different things, we basically use the same 4 or 5 classes of medicines for everything in different orders. And most of the reasons we do the different orders is because of different adverse effect profiles in different populations. So this is a set of guidelines from knee osteoarthritis that I stuck together by mechanism. So these are systemic things that you give basically that gets into the bloodstream. NSAIDs, a weird opioid / SNRI combination called tramadol, SNRI medicines, which are used for depression, but also work for chronic pain. You don't have to have depression for it to work for chronic pain and vice versa. And also, although it's not in the guidelines, there are trials of gabapentinoid anticonvulsants for knee osteoarthritis. You look at classic neuropathic pains like diabetic peripheral neuropathy and say zoster shingles, pretty much the same things in different order. For knees, strong opioids are not recommended, mostly because I think these folks tend to be older and fall down. Whereas in neuropathic pain, they do recommend opioids as a last ditch. And then there's the actual specific stuff, which is usually targeted treatments. Injecting a nerve versus injecting a knee, that really is different because it's a knee versus a nerve, you know? But the systemic stuff, we tend to use the same things. So this whole idea that there's such a thing as neuropathic medicines and nociceptive medicines, I don't really buy so much. Yeah, all right, so that's enough. Here's an interesting case in point, the SPACE trial. So this was done in the VA. It's musculoskeletal pain, back, hip, and knee pain. And by the way, nonspecific low back pain is a place where good medicine trials go to die. Almost nothing works for that. But anyway, musculoskeletal pain, not quote unquote neuropathic pain, right? And so this VA population, they were randomized to 2 different treatment arms. One is all opioids. The other is every other thing in the toolbox, and looked at a year. First of all, it's weird because nobody practices like that, right? Who starts with opioids and uses nothing else? But interesting, you know. I mean, the real comparison would be everything in the toolbox and opioids versus everything in the toolbox, no opioids. But anyway, big picture, there was almost no differences. 2 out of 15 measures were different. Pain intensity favored the non-opioid arm by a ½ point. Anxiety favored the opioids. But it's also true that this was a stepped care, treat to target, if something fails, stop it and try something else approach. And in the opioid group, people took 2 drugs. In the non-opioid group, typically they got 4. So more stuff failed. It basically wound up being an NSAID plus or minus topicals versus opioid trial with some of the other stuff on top. So a little thing buried in the data there. So there are people who also, you could combine. You could combine, yeah. They also kept the doses of opioids where I think was reasonable, so they didn't use high dose opioid therapy. So I actually like the way they did most of the things they did, to tell you the truth. Anyway, there are people who will say opioids don't work for chronic pain. I think that's wrong. I think they actually do. And I think there's a whole lot of caveats to that statement. So almost all the trials we've got for opioids for chronic non-cancer pain are like 6 weeks to a couple of months long. They're not 2 years long. So this is one of the biggest problems we've got in the whole field. Now, they beat placebo. I used to say about 0.6 out of 10 on a visual analog scale. Multiple different reviews since then have been stuck together. I think it's higher. I think it's closer to 0.75 out of 0.8. I'll show you some of those reviews in a minute. And they beat placebo, but if you put them head to head against just about everything else, just like you saw in the space trial, they don't distinguish from other things. So the idea that they are, quote unquote, the strongest things we've got for chronic pain, I don't know, doesn't look like it. Looks more like they kind of work mostly like everything else. And so this is a trial of duloxetine, an SNRI, quote unquote, neuropathic medicine for knee osteoarthritis, quote unquote, not neuropathic pain condition. And what you see with this stuff is it takes about 8 weeks for you to know what it does. It does separate from placebo, and about 2/3 of the actual treatment effect is spontaneous improvement or placebo effect. So same basic rules for chronic non-cancer pain. Takes a while for you to know what it's going to do, and usually everything you try has relatively small effects, kind of like the opioids. One thing I think is different about opioids is I think they look better early and worse late as tolerance kicks in, whereas almost everything else, it's a gradual decline in average pain. So I think opioids, it's really easy to see the early improvement and harder to see the gradual decline in effect, whereas everything else, it's hard to see the improvement because it's really gradual. The thing that's mainly different about opioids is they'll kill you. That's really it. You know, the other things have their side effects, but opioids have just qualitatively worse risk. And it's dose dependent. So my fonts got weird, but this here shows the relationship between death by overdose and opioid dose. So 2 points. A, totally dose dependent, right? Straight line. Other point, even at this walloping doses, it's 0.8% per year. So even people on really massive doses of opioids are 99.2% likely not to die of an overdose that year. And the absolute risk is low. It's dose dependent, but it's low. Now, is it uniform over time? If someone's on that dose for 10 years, is it 0.2 times 10? We don't know, right? That starts looking worrisome. So anyway, so there's that. And whereas opioids tend to look good in short-term trials, and we have very few long-term trials, the observational studies we've got don't show them having any great shakes relative to anything else. And observational studies of people who have gone up on their opioid dose past that sort of 6-8 week transition period where you're trying to find the dose that works to start with versus people who don't go up usually show no difference whatsoever. This is a case in point. This is a 2-year follow-up. Here's the pain ratings. You know, who cares which one's which? They're a straight line. The one thing that was different was that people who went up on their dose were more likely to fall down, probably because people with chronic pain tend to be older and so on and so forth. So there it is. You know, that's the real difference. It's about the consequences and the fact that, you know, long-term treatment, we don't know what does. Now it gets even more complex here. So on the one hand, there's a big literature in interdisciplinary pain rehabilitation that people who are on chronic opioid therapy and go through interdisciplinary pain treatment, their opioid doses often go down and their pain gets better, right? Interdisciplinary pain care, lots of stuff is being done while that is happening. So you can't really separate the opioid reduction from the, you know, anything else. This is a relatively pure opioid tapering study. These are people who just sort of volunteered to taper their opioids. One of the things that's always important about these studies is almost nobody volunteers to taper their opioids. You know, the attrition rate is like you start with 4,000 and you wind up with 50 or 100, right? So the enrollment biases are massive in these studies. And when you look at what happens when people do come down, what usually happens to their pain is bupkis. The average is that people improve, but the most typical is nothing. Now, the reason the average is towards improvement is more people got better than worse, and the ones who got better than the ones who got worse. And so the average winds up being to the good, but the typical is nothing. And yet, we're starting to see some signal that both starting up opioids and stopping or tapering opioids are a risk for badness. Recently, there's been 4-ish studies of what happens, and these are large database studies, so that the quality of the data is tricky. Looking at what happens when people stop or come down on an opioid dose if they've been on it before. These are all observational, and the biggest problem we've got in them is we don't know the why or the who. We don't know who decided to bring the dose down or stop it, and we don't know why, right? So it might have been stone cold rational, or it might have been just goofy, but we know the net outcome roughly. There's a lot of these studies. This is both weird and my favorite. The reason it's my favorite is because it doesn't have a whole lot of statistical juju done to it. It's mostly a strict observational study. The reason it's tricky, it's a VA population. Now, so it's really atypical, almost all men, older, etc. On the one hand, if you're talking about anything to do with suicide, old white guys with guns is about the highest risk demographic you're going to get. So this would be the canary in the coal mine kind of population. Back computing that to any other population gets really tricky. But anyway, I will say that I think I buy it, and I think it probably does apply to other populations based on the other studies. So here's what they saw. People who were touched with an opioid, not chronic opioid therapy, not long-term opioid therapy, touched with an opioid. At the time they were touched with an opioid, their suicide and overdose rate was higher than the general population there. The ones who stopped after being touched with an opioid had a higher rate of death by suicide or overdose. It started when they were touched with an opioid and when the opioid stopped. And the longer they were on the opioid when it stopped, the higher the risk. Most people stopped, but the ones who stayed on were on higher doses. And oh, by the way, this has gone off of the slide, but the ones who were on higher doses had prior psychiatric illnesses and were on it for longer were, the higher risk. So all these things hang together in a very scary sort of way, right? Again, absolute risk, like the denominator here is per 100,000. So we're talking like thousandths, but still the risks are qualitatively different. Let's see if this will go. All right. I strongly encourage you to look at this. This is AHRQ's site for guidance on current evidence base for opioids. They've updated it I think for 3 rounds. The most recent one is a really good read. It mostly says what I just said. Oh, people were taking shots. Okay. All right. Next thing. We talk about the relationship between quote unquote depression, and I put it in scare quotes for a reason, and chronic pain and sickle cell disease in pop psychology terms. And we probably need more precision before we can do a whole lot of good. And when I say pop psychology terms, I mean depression is an understandable reaction to a bad thing happening to you. I am depressed because ... my dog died, I lost my job, etc. This is not usually the way that psychiatrists think about major depressive disorder and major depressive episodes. We think about it as a syndrome with a set of symptoms and signs that has a genetics to it, that's a relapsing and remitting course, sometimes chronic, tends to respond to certain kinds of treatment. Not every bad feeling is depression in the psychiatric lexicon, okay? Now, we know that depression, as properly defined, but also when people screen positive for it on screening instruments, goes together with chronic pain like peanut butter and jelly, sickle cell disease and outside of sickle cell disease. People who have prior depressive episodes, more likely to develop chronic pain. People who develop chronic pain, more likely to develop a depressive episode. This seems to hang together with sickle cell disease. Now, This is Pisces also. When they say depressed here, it should have the scare quotes, because this was people who screened positive for depression on a screening instrument. That is not the same thing as they sat down with someone for an hour for a structured diagnostic interview. It's just a number and a cut point on number. Screening instruments have high false positive rates. That's their job. They cast the net wide, and then you're supposed to narrow it down and make the actual diagnosis. Not all these people had depressions. And I'm going to tell you why I think that's particularly important in a minute. One of them is that we have an evidence base of how you treat major depressive episodes. We do not have very much of an evidence base of how you treat I feel bad and screen positive, but don't have a major depressive episode. So if we treat everybody like they got a depression, if they screen positive, we're going to probably overtreat. Anyway, so the people who screened positive for depression had more time in pain, did not show more time with crisis pain. Their non-crisis pain was worse. They used more opioids because, and they had less relief from opioids. So this pattern of more severe, more pervasive chronic pain, it's also more treatment refractory, is what you see in depression and chronic pain generally. So it looks like it kind of follows the rules, with all the caveats I said about how some of these folks don't have depressive episodes. Now, there's good news here. The good news is if you actually identify people who have both depression and pain and treat the depression, particularly if you treat the depression to remission, pain gets better and you can get effect sizes you don't see with pharmacotherapy. I strongly suggest you pick up the SCAMP trial. It's about 15 years old, but it's a really good one. Outpatient trial, people with chronic non-cancer pain, screened for depression, randomized to intensified treatment for depression and chronic pain versus usual care. And what you saw was on pain, more than double the clinically important change in chronic pain. You will never see that kind of effect size for any pharmacotherapy for chronic pain ever. So if we're not identifying and treating depressions in any population with chronic pain, we probably leave a lot of chips on the table, but we got to identify the right folks. Here's why. So this is a big review of treatment response by depression severity. And so this is the mild end of depression severity. This is the severe end. This here is antidepressant medicines. This is placebo. And you will notice that at the very low end, it crosses over. So the placebo actually does better than the antidepressant. So antidepressants actually separate from placebo in the moderate to severe depression range. You can't just throw an antidepressant at everybody who screens positive for a depression, expect something to happen that's good. As a matter of fact, well, it probably happens to get more adverse events. And if you just waited 6 months, it might get better anyway. It's tempting to believe that this is different for psychotherapy. I suspect it's actually not. I think probably the same rules apply to psychotherapy, but it's not studied as well, in this way. So diagnosis matters, and knowing what your treatments do matters too. All right. So we got the hard stuff out of the way. Let's talk about addiction. I think trying to figure out who with sickle cell disease is addicted is a waste of time. And we are responsible when opioid therapy goes wrong. So, yeah, I'm going there. So here's a case. This fellow was, I think, the most frequently hospitalized person in his system at the time. This is time here. This is like visits. Red is ED visits. Blue is hospital admissions. And they move in lockstep because every time he came to the ED, he got admitted. There was a pattern. The pattern was come to ED, have pain, uncomplicated pain, never had acute chest, never had any of the badness. Muslim crisis isn't bad enough, but you know what I mean. Got admitted, stayed 3 to 7 days, was discharged with a short course of opioids with intention to taper the opioids. Sometime a week to 2 weeks in, would call someone and would say, I am in pain, I am out of pain medicine, help. And I'm oversimplifying a little bit, but not much. Whoever got that call would do one of two things. Thing one was, so they would do one thing almost always and then one of two things. Thing one was document something about fear of opioid use disorder, opioid dependence, drug seeking behavior, blah, 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 all that noise. And then say, and so we will send him to the ED, and so we will give him a short course of opioids for his pain until he gets to his next appointment. And then the thing just kind of kept going. Here's his outpatient opioid dose, best that my little compulsive self could plot it. And it's chaos. And it's chaos on account of it's like 5 to 7 different providers who barely know the guy, all giving him what they think are short courses of opioids as he kind of bounces in and out of the hospital, all with the intention that he will stop these opioids, except it never does. Now, if you are a compulsive numbers obsessed sort of individual, like some in the room, you might, what are you laughing at, Cantor? So you might try to average that out over every month or so. And you find that that number is almost exactly 60 oral morphine equivalents a day and never drops below 40. And so here we have someone on chronic opioid therapy being prescribed in the most crazy and disordered and chaotic way you possibly could. So, sorry, my fonts are all messed up. I think this addiction thing is useless for 2 reasons. Reason one is, just like for this patient, it don't change nothing, right? You know, I've seen lots of people with this pattern. It's not like it's not all over the chart and people aren't talking about it. And then what? Nothing happens, right? So the question itself does not seem to guide management in any way that's better for anybody. So there's that, just at the very pragmatic level. The other is, a more fundamental thing is, I think, has to do with the nature of addiction. So I am very much of the mind that addiction is a disorder of operant behavior. So it's what happens when a behavior is emitted and paired with a powerful, immediate, highly reliable, supraphysiologic reinforcer. It's about reward, right? And then that habit burns in and becomes basically a learned drive. So that's how you get addiction. And by the way, opioids, alcohol, all the stuff that's reinforcing, it doesn't care what behavior it's paired with. It makes whatever behavior it's paired with stronger, right? So there's that. Now, the thing is, there's also another flavor of reinforcement. So reward is positive reinforcement, right? But there's also what's called negative reinforcement. So if an organism is in some unpleasant state and it can do a thing to reduce that unpleasantness, it'll do that just like it will for reward. So like the experimental version is you got a mouse on like a hot plate or an electric floor or whatever, and it can push a red button and make it all cool off. A mouse will push that button just like it will for a food pellet if it's hungry, or for water if it's thirsty, or anything like that. So relief works like reward in shaping behavior. Now, opioids do both, right? If you got chronic pain, opioids are analgesics. They may not work great in the long run for chronic pain, but they probably work for a couple hours, right? And immediacy really matters for reinforcement. And they are positive reinforcers. And you cannot look inside anybody's head and figure out if the opioid is either a positive reinforcer or a negative reinforcer, or how much it is, or whether it's shifted over time. And there's no reason on God's earth to think it has to stay one or the other, right? So you can't figure this out. If you think your job to change management that isn't working is to look inside this black box and figure out if it's either positive reinforcement or negative reinforcement, your host, you ain't going to be able to do it. You're just going to sit there paralyzed, which is why fundamentally I think this kind of thing doesn't work. But if you have a good reason to think that the pattern of behavior is a problem, and 32 points, boldface, double underline, good reason, because our people get looked at like everything they do has got a bad reason, right? But if you have a good reason, like for example, you have someone who has chronic pain who's spending 30% of his life in the hospital, who occasionally gets septic because people fiddle with his line who shouldn't be fiddling with it. And oh, by the way, he's not doing terribly well in his life. You may have a reason to take action. Now, the good thing about this operant idea is you don't necessarily have to know the mechanism of the reinforcement. You just have to know the system. The bitter pill for clinicians to swallow is, it's us. The medical system is the Skinner box. and it's our decision. So I get a little provocative sometimes when people are asking if the patient has an opioid use disorder, and I ask things like, so his opioid use disorder is he takes everything that you prescribe and then you prescribe him more? Interesting kind of disorder the patient has, right? So anyway, so every element of the system contributes to the behavior pattern, including our choices. And so if you see it going wrong, trying to figure out who's addicted or not isn't going to help you, nor your patient, but you still have an obligation to do something. Like, for example, you might talk to the people in the ED about how the fact that the patient's on adequate disease modifying therapy and never has acute chest and probably doesn't need 24-hour nursing care for 25% of his life, so he doesn't get admitted as much. And then you make the goal of the acute care visits not to try to treat a crisis that's never going to get better because he has chronic daily pain that averages 6.5 out of 10, no matter when you ask, and instead look for a regimen that he can use at home. So treat him with all orals. And then you rearrange things so that he sees his outpatient team weekly instead of every however God knows how many months when he's finally out of the hospital. And they start prescribing his opioids regularly, and he is then titrated up on long-acting opioids to 60 oral morphine equivalent a day, and is now on chronic opioid therapy for his chronic pain out of the hospital. We did that. Wasn't his fault. Let's see. So this is that thing I showed you earlier about our clinic. So this is almost exactly 90% of the patients we prescribe opioids for. What's that? Yeah. There are outliers, right? They're not many. And so you don't have to do for atypical patients what's right for typical patients, right? But you do have to do what's right for typical patients. Yeah. So I think for these folks, all the guidelines are exactly right? I mean, we know how to use chronic opioid therapy pretty safely, I think. We know how to treat crises, even though our system's not great at getting people back fast enough and triage fast enough and triage right and treated with the right dose and all that. But we know how to do it. Now that's an implementation task. There are people for whom we got to rethink whether we should be treating with a frequent acute events paradigm versus a chronic pain paradigm. And there are people who are on doses of opioids that are probably not doing them very much good and putting them at risk. And we got to think about how to change that in some risk-aware way, which is not easy. But for most people, mostly we should just treat them right and relax. But don't forget about my folks, the 5%ers. They need extra help and clear thinking. I mentioned that when I did that correlation thing, that this upper outer quadrant was missing, and I wasn't sure it's the same everywhere. So one thing I've wondered about is that we have transitioned a fair number of people that we think have failed chronic opioid therapy in some way to buprenorphine. And so, for example, I think almost all of these folks, I think this person here is that person there after they taper down a little bit. But we've transitioned to 60-ish, maybe more by now, probably more by now, people from opioids, full agonist opioids to buprenorphine. And one of the things that seems to happen is, first of all, they disappear from the graph, so you lose track of them. But acute care utilization tends to drop off. Now, this all happens in the context of a treatment system that uses the principles I've been talking about, So I have also heard stories of people with a patient who has hard to treat pain, frequent acute pain, whatever, that someone has read this paper and says, well, if we can just get some buprenorphine under their tongue, maybe the miracle will happen. I don't like that. You need to have this sort of approach. You need to have an ongoing relationship with people. You need to have a strategy behind it. It ain't just a pill, I think. But anyway, it may be that one of the reasons this upper outer quadrant is missing is because a lot of those folks were in that cohort that we put on buprenorphine, just so you know. Yeah, I think I already said all that. I think I'm done. So if anybody's got any questions or, dead animals or rotten vegetables to throw, now is the time. Yes, ma'am. You got
Lots of food for thought. Passing the mic back.
Hi, thank you. I appreciate all of the information you just shared. I have several questions. We
Yeah.
probably can't answer them all here today. But
Yes,
if
ma'am.
I can go back, I don't know. I got 2 pages, but if we can go back really quick, thank you again. This was great information, and I appreciate your support in the sickle cell arena. I'm sorry. I'm Alexis.
Hi.
I serve as the president and CEO of Sickle Cell Foundation of Tennessee. Okay. And I live with sickle cell disease. So I have a couple questions.
Yeah, you said you
Can
wanted me
we-
to back up to something?
Yeah, can we go back to the piece where you talked about the sensitivity to pain?
Yeah. Tell me where.
There was about central
Central
sensitization. Yeah.
So up in here somewhere. This one? Or there?
One more back. Let me see.
That one?
Yeah, one more, I think.
One more? This one?
Let's.
I'll just page through the whole thing.
Yeah, you're good. You're in that area.
Okay.
So
somewhere in that block.
Somewhere in that area, you talked about the sensitivity to pain.
Yeah.
And before I make a statement about it, can you tell me a little bit more about what you meant when you say that, about the sensitivity to pain piece?
Yeah, so it's a way too simple word for way too many complicated things. So there's this set of tests called quantitative sensory testing, right? So stop me if I say something you already know, but a lot of it involves giving people stimuli that are either just at the threshold of pain, right? And sort of ramping it up to find out where the pain thresholds are, or doing weird stuff to see how the spinal cord and the brain react to pain signals, or doing things to figure out how the brain sends signals back down to the spinal cord to gate pain out. So there's 3 or 4 different kinds of things and multiple different modalities. So cold pain, heat pain, pressure pain, they all have slightly different parts of the nervous system that operate, right? So when I say sensitivity, it's way oversimplified. But generally speaking, I think, yeah.
So there's literally a machine,
Yeah, machines.
that this is a simple way that I like to think about it, how I explain to people. Imagine a machine is pinching you. Okay, it's pinching your skin. And at some point you say ow. And it measures when you say ow.
Well, you say ow, or you press a button, but yes.
Yes. And there's a machine that gives you a cold feeling. And it says, when is this uncomfortable? That's what he means. These are machines that test your perception feeling of pain.
Yeah.
Does that make sense?
That makes it even more clear. So that really speaks volumes. If you're talking about a machine,
It's a machine.
to
This is-
simulate the
Yeah.
feeling of pain in a real human being.
No, it's a person. It's not a
It's a
simulation.
person,
So it's a
okay.
person who gets
They
like
pinch me, yeah.
yeah, like
Yeah, pinch me. Yeah. Right.
yeah, or zaps you on the finger. So what's that? Yeah. Yeah. Yeah.
It's just asking, yeah.
Yeah.
Okay.
But it's a way to exact a discomfort in many different people and see how they feel about that discomfort.
Well, it's to get really precise. It's kind of about the numbers, right? So it's about, like, a very typical one was like, tell me in some way, press a button or whatever, when this becomes painful. And then how painful was that? One of the things that's funny about it is people never say 1. So they have always say like 4. So it's kind of funny that we have a pain scale that goes from 0 to 10, but people say it's painful at 4. But anyway, so it's that sort of thing. So it's really quote unquote primitive. You know, it's sort of like not about how you cope with pain, how you think about pain, how you tolerate pain, how you endure pain. It's just like sensation, you know, how much stimulus does it take for you to feel that as painful?
Okay, and I think some of that in clarity, just as we just bounced around trying to get a clarification on it, can be a little confusing when you're presenting this information to a set of nurses or a set of physicians or providers, and they see sensitivity to pain. And I don't know about anybody else in here, but patients are typically hyposensitive, right? So we have a much higher pain threshold, well, in my opinion, than most, in my experience.
In the technical sense of the word, probably not true.
Right. And so that's why
it
we need
may
to
be more
clarify
that you've got a lot more practice enduring. And I think that's almost certainly true. But this is way more primitive than thought, coping, endurance, any of that stuff. It's just, you know, how the very basic bits of the nervous system perceive pain.
Okay.
Another thing that's true about this is like the humans, just humans. If you zap like 20 people on the finger with exactly the same stimulus, you will literally get pain ratings from 0 to 9. So that's the normal variation in human sensitivity to pain. It is massive, which is part of why like these comparisons are really hard, because when you have high variability, there's almost no such thing as average, right? Every individual is just radically different.
Thank you. I appreciate that. I think there are some differences that we need to work on as a community with the scientific community as well, to make sure we clearly articulate that.
Yeah,
in the sickle cell community as a whole.
It's a very technical thing. Yeah.
But I don't think it's unexplainable though.
Yeah.
I think there are some things that we can come to say, this is what we mean when we say this.
Yeah.
I just don't want it to be taken out of context if someone sees it.
Yeah, this
you
is
know, we
very
have a
technical.
Sensitivity to pain.
Yeah.
That's it. Thank you. I appreciate that.
Yes, sir. Dr. Cantor is the who are you person today.
Yeah, so it's bang food with ECU. I think what she's saying is very, very pertinent. And I think as we discuss this, individuals with sickle cell disease are always very, I don't know what was used, very sensitive at any suggestion that they may be more sensitive to pain, or their pain may be, they may be feeling pain worse than other people would. And my question to you, so
if I might suggest, is it about how often people are suspected of faking it? I mean, that's what happens, right?
Yeah, so I think we have contributed to that.
Yeah.
But my question to you is, you also mentioned it's not just sickle cell, it's other chronic pain conditions, osteoarthritis.
Yeah, where this central sensitization and such happens. Yeah, right.
Yeah. I remember back in the 90s and early 2000s when we used to be more aggressive with pain, and pain was the fourth vital sign. We really insisted that you want to limit pain experience, including for infants and very young children, because experience of pain then sort of induces them to be more sensitive to pain. So
Yeah,
what is the
Dr. Cantor-
mechanism that really, when you look at these other chronic illnesses or pain syndrome, do we have a clear mechanism how that renders people with sickle cell disease and other pain to be more sensitive?
Short answer is we don't know, I think. I mean, I'm not the world's greatest expert on everything to do with pain, like by any stretch. But my conclusion is we mostly don't know. I suspect, and this is opinion, all right, this is opinion, that the idea that the subjective experience of pain is what produces more pain is itself a bit of a problem. And the idea that giving any particular medicine rearranges the nervous system to prevent it also is an untested hypothesis. So I think we sort of start out with this observation that as people develop chronic pain, they get these sort of sensitization things happening. And the going hypothesis, I remembered back in 1990 something, was related to the idea of kindling, the idea that there's some sort of learning process that's happening that the brain, the spinal cord get used to a particular state that they're re-exposed to. So reasonable hypothesis. I think the question then is, did the prescribed treatment do the job? And I think it probably didn't. So this idea that if you give analgesics and reduce the pain, first of all, presumes that the analgesics reduce the pain, which means they're sort of universally effective, or you can find something that's universally effective. For chronic pain, that doesn't seem like the way it operates. Like everything's got a pretty significant failure rate. So I think one place we might have gone wrong, particularly with chronic pain, less for the acute pain, but particularly with chronic pain, was the idea that we got this set of things that can make the pain go from an 8 to a 0. And if we do, it'll never be an 8 again. I don't think we got those things, first of all. And the idea that they have no effects that could be adverse on the pain processing system is not the way it's working out. Like, so opioids, for example, right? So if you give an opioid to a mouse at a frequency that it doesn't become tolerant, just very intermittent, it's always an analgesic, like the 30 minutes or whatever after it's given, pain thresholds go up like they ought to. But with repeated exposures after that, pain thresholds drop below normal. So you get this cycle of analgesia, hyperalgesia, and with repeated exposures, the analgesia gets less and hyperalgesia gets more. So one of the things I suspect is that there are these central mechanisms that happen in the course of inflammation, the central nervous system constantly being fed pain signals, et cetera, that probably are not necessarily directly or massively reversed or changed by most of the pain meds we got. And then opioids in particular can cause the upregulation of all kinds of pronoceceptive systems that might shoot them in the foot even if they could from their analgesic effect. So I think it was too simple a hypothesis and didn't take into account what the medicines actually do. And again, that is like all opinion, right? So that's what I think. You ask 1,000 other people and see if they know better. Sure.
Toby Moma, University of Mississippi Medical Center, Primary Care. I'm speaking as an academic who trains medical students and residents, and my residents and medical students always come in, unfortunately, with a bias.
Oh, yeah.
Handling sickle cell patients.
Yeah.
How do I get around that concern that they have in the hospital, mostly in the hospital? I tend to do the opioid risk tool. And if it's above 8, I refer them to an addiction psychiatrist. Do you think that's something not worth pursuing?
Absolutely not. Don't do that. Yeah.
Because they're trying to put barriers, and I'm trying to say, okay, why don't we use this as an alternative to just put in barriers?
I understand. So for those of you who don't know, so there's a couple of, well, more than a couple, but 2 that I think are relevant instruments that are supposed to screen people for risk of bad outcomes from opioids, mostly aberrant opioid use, et cetera, et cetera. The opioid risk tool is one of them. And what the opioid risk tool is basically, it's like a list of risk factors for bad outcomes from opioids. It's things like being younger, male, having a family or personal history of substance use disorders, and having several different psychiatric disorders that all increase the risk of trouble. These things all are risk factors for bad outcomes from opioids. That's for sure, right? So I think the trouble, and then there's another one called the SOAP-R that instead of being a chart review for these things is more like a questionnaire you give to the patient. So it gives you a number like the PHQ that I said for depression. The problem, I think, is that they give you a number and then tell you exactly jack what to do with the number. And so what the appropriate intervention to prevent these bad outcomes is, no one has defined. And so I also ethically, and then now there's all kinds of things to think through on this, but it also means that we probably treat certain people's pain differently and look at them askance, like, let's say, young Black men, which we got to think hard about using tools that immediately put those kinds of like numbers on top, right from the beginning. So I'm worried about that. So what I think is, as I said, the focus on the patient is not the right thing. The focus is on our practice, right? So I can quote you chapter and verse on, for the typical person with sickle cell disease, the right thing to do is triage them right, get them back fast, like get them their first dose of medicine within an hour, use what has worked before, and you get lower hospitalization rates and better pain control, right? I think the place where things go sideways is when everyone is painted with the brush, all patients, I should say, is painted with the brush that we got to watch everybody for this thing we can't see and treat them all with suspicion. So on that, I'm with you, right? I think you're on the right track there. I think the thing to pay attention to is, has this patient been treated correctly? So for example, if you have someone who's in the hospital, who is only in the hospital once every 2 or 3 years, as typical people with sickle cell disease are, and is being treated with a dose that has worked the past 3 times they were there, and when you can say when they go home, they taper off in a week, there is nothing to worry about. And the reason there is nothing to worry about is because that patient has a history. So one of the places I think you might work is less on the opioid risk tool and the SOPAR and that sort of stuff, and more on, this is a typical patient with sickle cell disease with a typical course, and here's how that goes. And here's what you look for in the chart when you talk to the patient and their prior history. And here is the signs you can say, something right here. And this is someone who's being treated with a massive dose of opioids, whose pain's still 8 out of 10 every day, but there's not a lot you can do about it in the hospital. That's an outpatient problem, right? There's ways to treat people more or less safely in the hospital. And there's trials of there are ways that you can use opioids in the hospital that probably increase the risk of acute chest in ways that don't, et cetera. So what I would suggest instead is teach your residents about the right treatment for the overall majority of people with sickle cell disease, and to relax, and what to look out for when something's going wrong. And I don't think the ORT is going to help you. Sorry. Yes, ma'am.
Hi, Sierra Gollin from Augusta University. So I thought it was really interesting when he mentioned addiction medicine. Everybody went, oh, no, 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 no. Because we've not had good experiences with addiction medicine.
I would agree with that general principle, yeah.
One of the things that was shocking to us was their goal to get them off opioids.
Mm-hmm.
We're like, that's not really our goal,
mm-hmm.
And so based on where we're at, and we've worked some with palliative pain management,
mm-hmm.
I think we work more in peds with them.
Mm-hmm.
Where do we send? We do as much as we can, but at some point, what do we do with your 5-10%? If we're limited with our resource, we're not near Hopkins.
Yeah, well.
So we have an answer. Maybe coming. Okay.
There are people in general pain medicine who are deeply interested in sickle cell disease, and I trust with my patients. There are some people in palliative medicine that have an interest in sickle cell disease, I trust with my patients. People in addiction medicine, because opioids are involved, their life is about altering behavior towards abstinence or less risky use of opioids. They don't know this. It's not their job, and we shouldn't ask them. So there's that. Every institution is different. I really don't want to overgeneralize too much, but sickle cell disease is just different. And I think the idea that we can sort of farm out as a clinical community this to other people who don't know our patients, don't see a few hundred a year and don't know what's typical, atypical, going sideways or going straight down the path. I have little faith in that. We've done things better, I think, as we've done it ourselves, to tell you the truth.
Pat, I wanted to bring up two things. I do think that there have been centers that have found a partner who might be someone who does addiction medicine, but also has a lot of experience with pain management that
Yeah.
have been able to help. Like at
Yeah.
Atrium Health had a
Yeah.
relationship for a number of years with someone. So it's not that they can't be helpful,
Yeah.
but you need a special person. I think.
I mean,
is
for heaven's sake, y'all, I'm a
what-
psychiatrist. Like, who would think that you would send somebody to a psychiatrist for this either? So, I mean, to the extent I'm a positive example. But I think the person always matters more than the letters behind their name. And interest in the patients and care for them trumps a lot, and experience trumps a lot. So I'm not, like I said, I want to be very careful about overgeneralizing, because everything I say, I could think of an exception to.
Ophelia Alvarez.
Yes, ma'am.
I have a question pertaining to one of my patients.
Okay. I have a patient who ... Those questions.
Very quick,
Yeah.
but I think it's somewhat difficult to answer. This is an adult with sickle cell who's always in the hospital.
Mhm.
And of course, we recognize we have to change what we're doing. But part of it, we feel could be that we need to evaluate him from a psychological standpoint. As
Mhm.
you know, counseling and all the things that you have mentioned are important
Yeah.
for coping and all that. But he refuses to be counseled. What will be your approach to educate this person of the importance of talking to him and trying to see how this will be, evaluated?
All right. This is where I play the heretic again. I think you're probably wasting your time. I think we have a little bit of a fantasy that we treat people in a way that, like, we make it normal for things that shouldn't happen to happen, and then hope that a psychologist or somebody like me will come in and talk them into a different habit when we don't have to make any hard decisions. So the idea that, a psychologist is going to talk to the guy when he's in god awful pain and is in the hospital all the time and all that, and is going to just talk him out of that pattern when we keep reinforcing it, won't work. So I think the first thing is you got to figure out some method to transition him into sufficiently intensive chronic outpatient care. And then you can start working on that stuff. But that will be decisions you'll have to make within your own care system. I personally don't try that. Like, I work on the care system first, have it so that patients, if it's appropriate, treat it as if they have complex chronic pain. And by the way, that also means you have to build a sufficiently intensive outpatient care system, because one of the problems we got is there's a forced choice between hospital and, Q6 week or whatever visits with a hematologist. That ain't working for some people, right? But if you can build a sufficiently intensive outpatient chronic care system and alter your behavior to shift them to that, then you got a shot. But I think focusing on trying to get them to talk to a psychologist or something, but not changing what you do ain't going to work. I speak from bitter experience, but that's what I think.
This is Julie Cantor. So a couple of things reflecting. So I always tell people I have Pat's voice in my head a lot, which I'm sure drives him crazy. But one of those ways is, I do hear voices. I absolutely hear Dr. Carroll's voice in my head frequently. I think there's a couple of things, and Sierra, this is in part response to your question. You have to, I personally, this is my own personal view, I think that as a sickle cell center, it is our responsibility to build a structure to care for these individuals.
Mm-hmm.
I do not find it right, in my mind, to send them to someone else who doesn't understand sickle cell disease. When we built the Alliance and the requirements for this center, one of those requirements is that you treat their pain.
Mm-hmm.
Some people said, why do you even need to write that? And I said, because I've seen sickle cell doctors that send people to pain specialists who treat everything from a broken toe to a slipped disc. And to sickle cell, they don't know this disease. They don't understand the relapsing remitting. They don't understand all of the bits and pieces that go into it. So that's the start of the answer. we recognize that NASAC recognizes that we need to build a framework to help care for this incredibly complicated 5-ish% of individuals with sickle cell. And that it's hard. And that one thing we all have to recognize is that it's hard. But if you keep admitting that patient, your hospital system, right? You're not doing them any favors. And so what we have done as an example in our system, and a lot of this is harnessing your system. And one of the things I said when I came to UAB, they said I asked more questions than anyone else. I came back 3 times and asked a lot of questions. And I asked the questions because I wanted to make sure that they understood a couple of things. When I put up our shingle as a sickle cell center, we were going to bring in more people, not less. You were going to see increased rates of hospitalizations in ER before you saw less because we had more patients. But we were also going to improve quality of care. But it was also that I and my center is recognized as the lead in this. If you have sickle cell disease, we make the decisions, not the hospitalists, not the ER doctors when it comes to sickle cell pain management. And it's a hard pill to swallow, but, and no, well, pun sort of intended, but it actually has become in our center a blessing to the ED and the hospitalists. So everybody does have a pain plan. And there are a number of individuals for very specific reasons that says if they come in with uncomplicated pain, i.e. they're not going to die, right? This is pain. They don't have acute chest. They don't have sequestration. They don't have severe anemia. This is pain, that they're not admitted and they're immediately sent into our outpatient. You call this number and you get it. We get you into our outpatient area. We get you connected to us. And we talk to those individuals. This is not something we do in secret. We talk to the individuals. We explain what we offer, how we offer it, why hospitalization is going to cause them to die, because that's what we see. The more times you're in the hospital, no matter who you are, by the way, sickle cell, non-sickle cell, hospitals are the worst place you can possibly be. The highest predictor of death, when you look even back at Ora Platt's paper from 94, the number of crises didn't actually, right? The number of crises didn't measure pain crises at home. It measured hospitalizations. The more hospitalizations you have, the higher your risk of death. And that translates almost no matter what. And so we have to change our whole system's behavior if we want to improve those outcomes. And so it's a part of getting your whole system to buy in. And so that's what and so some people, it says no IV opioids in the emergency department, because if we give those certain individuals those IV opioids, they'll just come back to the ER and they won't come to clinic where they get their outpatient care that they need for their sickle cell disease. This is not everyone. This is people that we see weekly, right? We have a very specific plan for these individuals. There is also a group of patients, though, that were using our ER because our ER was, quote, nice, meaning that they admitted patients every time. And there were some individuals who were getting upwards of 900 to 1,200 various opiate pills a month from another doctor outside of our hospital. And they were a danger to self. And we weren't helping them, right? Just by letting our ER giving them IV opioids, we're not doing them any favors. We're not helping them. So we bring those people to clinic. They are always, always given the option of coming to get care with us. And in most of these cases, these are individuals who are seen by community oncologists outside of my hospital. They just like our ER better. That's not safest, right? My patients are safest when they're under my care. There is no doubt about that. These individuals need to be under their doctor's care. And so we give them the choice. You may switch your whole care to us. We will we'll take everything. We will treat you. We will do everything we can to manage your pain, but you can't just come to my ER. I mean, these are ERs right across the city from each other. It's not like this person lives 4 hours away. They literally choose our ER just because they like it. So that has made a remarkable difference, because it gets people back with their doctor. And it gets a lot of people into care that they need, that's actual sickle cell care, not just pain management. Now, we can't just do pain management and not do sickle cell care. We can't do sickle cell care without the pain management. And so I think that's a little bit of what Pat is saying. You have to think how you treat pain because you're also treating sickle cell disease, and you have to do both at once. And we can't separate that any more than we can separate their mental health. So we've put together an outpatient paradigm. And because we live in Alabama and many of our patients are 2 to 3 hours away, instead of coming every week, we do telehealth every week. We have some people that see us, one of us, twice a week by telehealth. I'm sure we're not getting reimbursed for that. I don't care. But that's what it takes to really check in. And I think the other part of this that one of your slides, I think, shows anxiety associated with pain. That is.
It is. And if you look at the overlap between depression and anxiety, when you see anxiety, you are mostly looking at someone with a depression, just so you know.
And PTSD. We see,
PTSD is another one of those words that's thrown around a little too liberally, in my opinion. But anyway.
I don't disagree with you. But I guess what I mean by that is that there is an anxiety. If you've never had really bad pain before, you experience that pain differently than somebody who's had repeated episodes of bad pain. And I mean, I've talked to a zillion and one individuals living with sickle cell, and they fear that next crisis. They fear that pain. Most humans don't walk around fearing pain in their leg. So then I have talked to numerous people who believe that taking their Oxy, Percocet, Norco, name your drug, every morning, they don't take it for pain. They're taking it because they're anxious about having pain. And that is something that we have to talk about, because in the long run, it's not helping them.
So there's another sort of talk I tend to give, which is about a kind of an overarching strategy on management of pain. So I call it like the 4 priorities, but there's 5 of them. So the 0th priority is you got to be the team running the case, because if it's not your strategy, wherever the patient is, there is no strategy, or it's somebody else's, right? And that includes if someone's like mostly seen by hospitalists or ED docs, like you're not running things. First priority is maximize the disease modifying therapy first. Treat the sickle cell disease as your first priority. Second is, which usually dovetails with the 0th priority, if the patient's acute care utilization is itself a problem, alter your behavior to get them into sufficiently intensive outpatient care. Third priority, stabilize the outpatient regimen, evaluate if it's working for the patient's pain, and then do something. If it's not working, change. Fourth priority, look for everything else, the depressions, the anxiety, the AVN, all of those other things. I have them in that order, not because I think the 4th is more important than anything else. It's because I tried it in exactly reverse order 15 years ago. It didn't work for anything. So there is an integrated approach to this, but there is no integrated approach that can possibly be an integrated approach if 15 different people are calling the shots, right? So that's one thing. Another thing, and the patients in the room here can correct me. People with sickle cell disease have had so many people doubt their pain and think they're faking, and et cetera. And you got to be careful sending somebody in who doesn't know sickle cell disease, asking them if their pain's psychological or how to do it. I mean, and particularly if that person doesn't know much about pain, you can have all the best intentions and send exactly the wrong message and do harm. So be careful about that too. And again, the patients can vote by the traditional throwing of dead animals and rotten vegetables.
I'm going to stop us. I know there are a few people who need to check out. Can we please give Dr. Carroll a big hand? We really are trying to build, we all say we would like a Dr. Carroll in all of our clinics. We would I certainly would, but we are trying to build something in the next, it will take us a while, because these things do to get at least his voice or his trainees or this concept in all of our programs. I want to say one more thing before I let you go, because I think it's also something that Dr. Carroll has taught me that is super important, which is there are people who don't want change, don't want fixing, don't want what you have to offer, and you also don't have to be part of their demise. And that has been very, very impactful for me as a provider. And I just want to put that out there. I always tell my trainees, I'm going to give each individual, I'm going to give you 6 months of my all out effort. Sometimes it's longer, sometimes it's shorter. I mean, just depends, right? But you may not want my care and you may not want this way of doing things, and that's okay. There are other, and I am lucky, and this was not true when I was much in South Carolina, but there are other people who would take care of you. They may not do a good job, in my opinion. You're going to probably die under their care if you are in this paradigm, but you still have that choice. You have an autonomous decision, and we don't have to continue to do something that we don't think is right for you, that we think is causing harm, right? Our job is not to cause harm. And so I think that that's something that isn't said to providers in any capacity, whether you're a community provider or a doctor, enough. And so I like to say it out loud because it's something that has rung true for me in situations where I felt like I was causing harm, and that wasn't fair to me or to that individual. So I'm going to have everybody run and check out. I'm going to remind you to come back. We're at 11, right, to restart. And thank you again. All right, guys, we're going to get started. I promise we don't have much longer. So we're going to have everybody come in and get started. Sit down if you want to sit down. Sorry, I made the room too hot. I was freezing. I'm going to make it slightly cooler, hopefully not cold. You guys ready? All right. So I am going to talk to you about linked data, but I realized yesterday that I felt like I should give some of the newer people in the room a little discussion on what this is. And we're being recorded, right? Wherever Sonia is. I think, yeah, perfect. Okay. But I also want to give some updates on the National Alliance of Sickle Cell Centers. For those who don't know what it is, I want to make sure you know what it is, why I keep talking about it. And then if we're going to talk about linked data and why that's important, it was important to tell you the beginning. So I didn't want to launch into the middle of the story. I'm the president, for the record, of the National Alliance of Sickle Cell Centers. I make no money. I get no fees. It's my second full-time job I do for free. These are my disclosures. All right, so I'm going to tell you a little bit about it. I'm going to tell you how we came up with some sickle cell disease center criteria. I'm going to tell you a little bit more about Granddad, the Global Research Network for Data and Discovery, some of our consensus recommendations, and drum roll, we have dates and a location early on for the first time in the year prior for the Alliance for this year. So that's a big deal. We've never been able to plan this far ahead of time. So everybody in this room knows this, right? Sickle cell disease is a rare condition that still limits life expectancy despite our significant childhood improvements. And we know that just like any other person, our healthcare needs get higher as we get older, not just doubles and triples if you have a chronic disease. We also know that healthcare providers with disease-specific knowledge are critical. I was part of this HRSA project 2 cycles ago, maybe 3 cycles, I'm lost in time. And the effort of the project was, let's teach primary care doctors to manage sickle cell disease. And the rationale was, we will never have enough sickle cell specialists. And it was always that a hematologist was required. And it became kind of a rhetoric. We're never going to have this. We're never going to have this. Well, the more we say that, right, the more we don't encourage people to go into this. And it's really, to me, just an ethically inappropriate response, a lack of equity. We're never going to have it, so we're not going to try. So we're going to shift the burden of responsibility to primary care doctors. I'm married to one. They get 15 minutes per patient. That is not fair or appropriate. And so that was a big problem for me then. We just got a paper accepted that's going to prove one of many ways in which that didn't work anyway. But I think it's something that we all have to keep saying. It's not, we're never going to have enough doctors. It's how do we make our resources go further? How do we increase the number of providers? How do we get our younger kids interested? Because if we don't start now, then yeah, in 10 years, we won't be any further. So let's start getting further now. And finally, that we need specific sickle cell disease expertise, right, to ensure the best outcomes. So that's where this all came from. And about the individual, it often isn't even about whether you have insurance, which is what everybody else thought too, right? It's because our patients have Medicaid. No, it's not. It happens to be whether you live in Birmingham, Alabama, near my center, or whether you live in Dothan and you're a couple hours away. You can have the best insurance in the world, but if you're in Dothan, you're a couple hours away, right? It's not always about exactly what your insurance is. It's often about where you live. And so how do we shift our focus? How do we build a program, build a structure, a network to really enhance care and coordination throughout the lifespan? And ensure that everyone living with sickle cell disease has access to that specialist. Now, if they don't want it, that's up to them, but we want to make sure we offer it. And it really means changing the system of care. So we started this and said, let's help build more sickle cell centers. And then we said, what's a sickle cell center? Meaning that there was no paper you could look up that said what a component of a sickle cell center was. There was no criteria. There's criteria, there's, what do you call that, joint commission criteria on a lot of other things. This wasn't one of them. So we got a bunch of people in the room who were experts, who were leading multidisciplinary sickle cell centers, and said what's required. And I have a PDF document, or you can go get it on the NASAC website, that says this in another way. And this was for specifically for adults. The most important was the thoughtful team-based care approach, consistent, comprehensive, coordinated throughout your healthcare system, like we talked about earlier, a center with programmatic emphasis and that coordinates sickle cell disease care. And recognizing that they're not all going to be the same, right? Atlanta is going to look very different than Birmingham, than Kalamazoo, Michigan, where I just found out we have a new sickle cell center. So we said these are the things that are essential, these were optimal, and these are adjunct. We wanted mental health staff to be essential, but so many of our already very functional centers didn't have mental health staff that we couldn't make that a requirement yet. These are also going to be redone every 5 years. So we're actually due to redo this in 2025 so that we can enhance it, right? Things change, we have to improve upon it. Our pediatric colleagues said, I know you say we have everything together, but we don't. So we need to do the same thing. Let's define what is required to be a pediatric sickle cell center. And I was shocked to learn that some of what I thought were great pediatric sickle cell centers didn't have what I think are required, apheresis, didn't have that capability. We're having trouble getting their stroke screens done, their TCDs. So we have a lot more evidence in pediatrics. So there's a lot more requirements in pediatrics because we had the evidence to back up their requirements. To give you another example, there was 15 people in our original adult center study. There was 41 pediatric sickle cell specialists in this study. So and that's, again, why we're going to redo this as time goes on. I'm not going to make you read through all this. I'm going to tell you how to find the information. Most important, all centers provide comprehensive care. That means access to disease-modifying therapy. You don't get to be a sickle cell disease center if you cannot provide transfusion for people living with sickle cell disease. You have to engage in prevention practice. That's where we're going to start measuring quality. You have to have an iron overload management program. You have to do some blood transfusion oversight. We're planning a little bit more of what that means. We already talked about pain management. You have to have some aspect to plan, family planning, and you have to have a plan for mental health, even if it's not embedded in your center. Okay, so models, not one size fits all, but there are some definitions that we can use. So why do we need these definitions? Well, it turns out a couple of things. I've learned way more about the business of medicine than I ever wanted to know, for real. But it turns out if you have things on paper that says this is a requirement, then the C-suite looks up a little bit more at you and they're like, oh, that's a requirement. Okay. If you say I need a social worker because I take care of, 150 disadvantaged individuals, they're like, meh. But if you say it's required, then they're like, oh, okay, maybe you really need it. So we also want to define what an associate center is, like a center in training. And then we want to define what an affiliate is. You can't just be an affiliate because you want to be. You have to be someone. There's an affiliation agreement between you and a smaller spoke. And what does that look like is what we're working on defining. It'll look very different in different places. For me in South Carolina, well, when I was in South Carolina, my affiliate clinic in Beaufort, South Carolina, that I still kind of run, it was a nurse practitioner there. That's all that was there. We had clinic space. We do infusion 5 days a week. We have pain. We have all the right protocols in place. That's what that looks like. At Hopkins, their affiliate was another associate sickle cell center that is learning how to do these things, but they weren't there yet. And so, but they had 2 physicians, they had a social worker, so it can look different, but there has to be some criteria in place. I promised to mention this. Again, I'm happy to share these slides. Obviously, it's really small. This is the Sickle Cell Disease Comprehensive Care Act. It's changed flavors a lot. This is what ASH is supporting. Again, God knows what's going to happen. The goal is to get it passed before January. What bugs me is it's not exactly what they're going to pay for. But what it means is that if your state agrees that you are a specialized medical home for sickle cell disease, and we believe they'll use the criteria that we have described, then you have increased ability to get other access to funds. Basically, that is what it means. And I can send it to you so you can read it more. Services may be provided by a designated provider. That can be a physician, a team of professionals linked to a designated provider. It can also include a community health team. They took a lot of our very clear words, has to have access to coordinated, clear mental health and ancillary services. So this will get more revenue that our centers desperately need. And again, I can absolutely send this to you. It comes only with a 2-year matched funding program, which means the federal government will give money to states for 2 years. So it's kind of a pilot. Somehow ASH never says that out loud. And the goal is that they prove in those 2 years that this method saves money to Medicaid. But in the meantime, they get an extra bolus of money. So you can sell it to your state that way. Get your again, if you haven't started thinking about this, it's something your state Medicaid needs to know is on the horizon, so you can start having the conversation. So what is Granddad? I did not make this up. This is all Jane Little. I like to blame her all the time because I would have called it Grandmom if anything else. But Globin Research Network for Data and Discovery. It's our sickle cell patient registry. It is a prospective, highly curated longitudinal clinical registry. And the goal is because we don't want to just say we're giving good care. We want to measure it, and then we want to learn from each other. I don't know how much you all know about cystic fibrosis and their CFF, the Cystic Fibrosis Foundation. But when they designate centers, the centers have to give data every year, and they publish which centers are doing awesome with their infections and which are not. It's very transparent, but it makes everyone better. And that's what I think is most important. We know we're not all as good as we need to be. When we looked at TCD stroke screening rates across 28 centers, we had some groups who were only getting 30% of their patients were getting screened a year. That's terrible, right? That's what we know best in the world of sickle cell data. We had some groups that were 75%, and 75% was the best. Nobody was higher. And so we looked at what some groups were doing to learn how to get other groups up there. We figured out ways to improve that screening. That's what I told you about the provider minder that we talked about before. But again, we want to do that with everything. So we have to track data. We have to have data to do that. It's still a mostly unfunded mandate. We are providing HRSA sites. So we actually in the Southeast, I'm proud to say we're the only of all of ST, SCD, TDP, all of us, we're the only ones that provide every single site money to collect data for Granddad. It's something both that JG and I believe very strongly in. If we don't have data, we just can't make things better. And it's going to become, we hope, more and more important. It also allows us for real-time investigations. For example, when everything came out across about Voxelotor, we did not see any increase in death rates in people on Voxelotor in our group. Now, it wasn't a huge number of people. I am happy to explain to you all of the risks associated with Voxelotor. And the problem is that the risks are not associated with sickle cell disease centers. They are associated with community health providers giving it out like Skittles and not monitoring it. Again, different subject, but there are things that this is going to miss, which is why I'm going to talk about linked data in a minute. Lots of data points. This is to say that we like our data probably too much. We collect too much, but we do have a minimum data set that we require. We're now at 72 IRB approved sites, which is pretty amazing. We are literally in the process of moving it. It's been under Hopkins all this time. It's going to move to a different central IRB. We're letting Advara and WERB fight it out, actually, who can give us the lowest cost because it's incredibly expensive. Runs about $200,000 to $250,000 a year. In case anybody wonder what those IRB fees look like. So we're working on that. This number is already old. This 4,298, we're actually closer to 5,000 individuals. And we're contending about 100 to 200 a month, which is fantastic. We're doing great. I'm really proud of us. This is an older version of a slide, just looking at one thing that I love to point out. It's the rare moment that you see more adults consented in something than kids. It's because it was started by a group of adult providers. So we really do have information. Why do we need this? These data tell a very different story than the cooperative study of sickle cell disease, which was the previous biggest longitudinal study. The cooperative study of sickle cell disease had some very good truths. If you had persistent fetal hemoglobin, you were very much more likely to live till you were 25. That's what we know from that. But it didn't say what happened after that. What happens that we can see now is even with that persistent hemoglobin, depending on what type of persistence you have, you're at risk of all of those same things after the age of 25. So stroke becomes a risk that wasn't there before. Your endothelial damage catches up with you. So we need these data. There's lots of gaps. We know that. When we started training as part of the ASH workshop, we train other centers to become, or early centers to become centers. Somebody looked at me in one of the first workshops we had and said, you know, how often should I see my 5-year-old or my 15-year-old or my 35-year-old with SC disease in the clinic? I said, that's not really written anywhere, is it? So we got together to start answering some of those questions. How often should you see somebody? How does that differ if they're on hydroxyurea? If they're getting transfusions, does a provider see them every month? Or do they just go get their transfusion? What does that look like? So we developed the consensus. Well, we began using an already developed consensus method. This is not new at all. In fact, we're late to the party here. That is a group of experts in the room that has an independent monitoring system, and you essentially go through a very long iterative process. It's we're using the RAND UCLA modified Delphi panel method. Nice short, easy verbiage there. It's a very formal group consensus process. It has been used by numerous other societies, and it's truth. What we try as much as possible to do is meet in person to discuss things, because we all know it's easier to talk in person, and Zoom limits two people being able to talk over each other, right? But sometimes it means someone doesn't get their something said. So we really try as much as possible to have one of our consensus meetings in person. This is what it looks like. We start off with saying, we are going to talk about how often somebody with SS disease should be seen in the clinic. Please review the data related to what we do know. So then we give out a survey that says, what do you think should be happening? What do we think as a group, as a consensus group, should be happening? We look at where we do already agree. We agree that everybody should be seen at least once a year, no matter who you are or what disease modifiers you're on. We look at the areas that we don't agree, and we plan to talk about them in a relatively organized fashion. You want to see a fight, you can see people talk about echocardiograms and how often they should be done in sickle cell disease. That was a bigger fight than pain medicine. And then through that, we come up with a recommended, that group comes up with a group of suggestions for recommendations. And then from there, we have a final vote. Not everything makes it in, sometimes it does. We have two levels, a standard. This is what we're going to do our quality assessments on. This is what we think has to be done, risk of life and limb, such as TCD screening. And then recommended. We think this really, really should be done, but we don't have enough data yet to say it's a life and limb sort of thing. So those are our two levels. So what did we do? Well, in 2022 is when we started this. We had 41 centers at that original meeting. And we talked about pediatric screening recommendations and adult screening recommendations. And these are now on the website. So you can actually print this off. And what we're doing now is making them into patient-facing documents as well, so that an individual or a parent with sickle cell can say, what should my child be getting every year? So that they know what to ask about. What should an adult be getting every year? We talked about implementation of transfusion recommendations. It's very interesting. So if you look at the current guidelines before this that are out there, the first really was the NHLBI consensus recommendations from 2013. And they were pretty decent, but they were really, again, made for primary care doctors. They were only kind of made for sickle cell centers. Then ASH came out with their very, I think, high level, in depth, right, recommendations for CNS disease, for cardiopulmonary renal, stem cell transplant, neurologic, and pain, and transfusion. And first of all, they're incredibly hard to write and read. If you've tried to read those guidelines articles, they are miserable. I know because I wrote one. Pat can back me up on that. They are not made for the lay public by any stretch of the imagination to read, much less a qualified physician. But they're also very organ specific, and they all say low quality, no data, because we don't have data. The one that is probably of all of them has the most data is the transfusion recommendations. However, it's one of the most poorly implemented. So this is fascinating, right? It's great if we put recommendations in place, but if nobody's looking, who cares? Nobody's measuring, who cares? So when we looked, it's bad. I'm just going to tell you that. Some very top centers are not matching blood the way they're supposed to, because it's more expensive, by the way, to match blood the way you're supposed to. So we started a plan for consensus on not how to do them. We believe the transfusion recommendations are great, but how do you implement them? What's the bare minimum your center should be doing? We only got about halfway through because we didn't include enough transfusion partners. We didn't include our blood bank. We didn't include our apheresis team. So it's coming back to 2025. So that'll be one of our recommendations this year. And we're partnering with multiple blood sources and blood people. And we're going to have our transfusion medicine people at the table, which is what we need. So Jennifer Jones will be leading that. We talked about individualized care plans. We've made it about 75% of the way. We all know everyone needs an individualized care plan, but how do you implement that in the real world and what does it look like? And then how do you operationalize it? And how do you talk about it not from peds to adult, but throughout the lifespan? Because it turned out that we were saying very different things. And then what's a high-risk vaso-occlusive crisis? God, I hope we get this published soon. We had to redefine, there was only one paper that defined multi-organ failure syndrome. It was Kathy Hassel and Jim Ekman's paper from over 10 years ago. It was a case series of like 20 something. It probably is 20 years now. So we needed to redefine that. And what it turned out actually that the way it's gonna come out is we ended up staging a vaso-occlusive crisis. And it wasn't being staged for pain. This is staged for when are you likely to die? Like what is happening? And can we provide a guide essentially for community hospitals to know when to transfer someone? When do you need help? I can't tell you how bad this is needed. So we're trying to get the final votes together on that so that we can get that out there. And then our fabulous social workers, some of whom are in the room, got together and said, you know, no one has defined what a sickle cell social worker even is. Let's define that and talk about the different types of social workers that we have. And what it turned out was they were a group that needed a home too. This is where we really learned that the sickle cell centers and NASAC wasn't just for doctors and providers, it was for everyone in the room. And so we really said this has to be a very inclusive community. It's something that I think it's not ASH's job, right? ASH doesn't even, I don't think still allow nurse practitioners to be members. Well, that wasn't your center. Anybody in your center is now a member of the Alliance. Now you can't join the Alliance yet as a single individual. If you live in Timbuktu and you just want to be interested in sickle cell, you can't join the Alliance. You have to join via a center. And there's reasons for that. But that's one of the things I think that we learned most from this first meeting. Then in 2023, we came back in and said, okay, let's talk about transition in sickle cell specific terms. And we wanted to talk about what should be in that transition documentation, not go to got transitions awesome. We didn't need to rewrite that. We needed to say, how do you operationalize it on paper? So that's what we did. We able to define successful transition, which nobody had done before. We then said, knowing that gene therapy was coming, what do you need to do to have a gene therapy center? What does that look like? So those are our transformative therapy centers. That's actually already online, those recommendations. Those recommendations passed with the highest consensus of any recommendations we've done. And we're working on those papers. Coming soon is the iron management and defining a sickle cell specialist. What is a sickle cell specialist? We know not all hematologists are sickle cell specialists, and not all sickle cell specialists are hematologists, but we have to have some rules in place because we've seen some people who think they're a specialist and don't know how to match blood, right? So how do we do that? What does it look like? And then we tried to talk about fever, and there was just way too many unknowns. And so we tabled that and said, okay, let's have a working group so we can really start thinking about how to answer these questions. And then in 2024, we said, boy, we haven't published very much yet. We got a lot to do. So let's not have as many consensus recommendations this year. Let's broaden our conference. Let's start the development of different tracks. You'll see it even bigger this year. So we had a little bit of a social work case management track and a physician track. You're going to see probably 4 separate tracks coming this year. We're adding a sickle cell kind of 101, sickle cell for the like new sickle cell specialist track. And we're talking about business of medicine track. So there's going to be a couple of additional areas of interest there. We're going to soon have a pharmacist track as well as we try to get more and more pharmacists involved. So we had 2 main topics. What is palliative care? A lot of people don't know. What does it look like in the context of sickle cell disease, and how can we make some consensus recommendations? Do we start in pediatrics? Do you start palliative care when you're born? And how do we designate roles? Both everyone and no one wants to talk about who does pain management, right? So there was, and it's different. Some people are like, no, you do it. And the other group's like, no, you do it. No, we do it. We own it as the sickle cell specialist, but it doesn't mean we don't take recommendations and help from others. And how do we do that? This is actually really cool, though. There are a lot of individuals in palliative care who are really, really interested in this, and that is great, right? We want more champions in sickle cell is always good. And so we want to talk about how we make that into something that looks like a livable, ongoing partnership. And then we talked about this really interesting new problem that we have. It's not new, it's just a lot bigger, cancer. Why? Because our patients get older and older people get cancer. So as more and more people are getting older with sickle cell, we're seeing more and more cancer. Unfortunately, we've had a multitude of cancer deaths in my older population, a lot of lung cancer deaths, a couple of colon cancer. Some of those are preventable, right? We know how to do colonoscopies. We know what that looks like, but no one was doing them because they weren't seeing primary care doctors. And so by the time we caught things, it was very late. But then we started talking about how do we do this with sickle cell? What do we do with hydroxyurea? What do we do with transfusions? How do we manage pain? All the hard questions that go with regular cancer management, but you have to add in sickle cell disease. So that was this year's topic, and they're still working on getting their information together. Then we started broaching early discussions. These are work groups. So we said, we're not ready to answer this question about who the right person is for gene therapy. Nobody's ready to answer that question, but we have to come up with some plan to triage. That's reality. And so what does that look like, and how do we agree on it so that you don't have rogue people doing rogue things? I was at a transplant meeting in Boston before this, or gene therapy meeting in Boston. And I made fun of my transplant colleagues in the room. And I said, look, I love you guys, right? I can't do gene therapy without you, but you would take my oak tree and make it a rose bush if I asked you to. They would transplant my right leg and put a left leg on there. Like that is, they're like kind of like surgeons in that way. And we don't want them doing that to our patients without contextualizing what is happening in sickle cell and how they have to go about all of those things. So it's become a very interesting discussion. We're trying to figure out about how to ask those right questions. And I'm really looking forward to the next step. And then we talked about how do we operationalize the relationships that we're trying to learn in this room? How do we put on paper what it looks like to be a CBO affiliated with a sickle cell center? What are the rules? And this is a lot harder because not all, right? While we've streamlined what a sickle cell center is, we haven't streamlined what a CBO is. And that's not our job as the Alliance, but we do have to be able to put into place some guidance for if you want our names attached to each other. Somewhat for legal reasons, somewhat for financial reasons, somewhat just because if you're in this room from a CBO, you're a very elite group of community-based organizations. There are less elite groups that will just be a community-based organization because it gets the money from the state. I'm going to be perfectly honest. Or you're very well-intentioned and not operationalized. We had to close, before I came to Alabama, they had to close one in Alabama as a result of something like this. Well, they didn't close it. They just stopped giving them state funds because there was fraud, right? So we have to make sure that we have these relationships in healthy ways. We also need to make sure that the centers are sending patients your way. What does that look like? What is an MOU and a DUA and all the things we're dealing with? So that's what's happening here. And then what we've also seen, what happens if the CBO changes leadership? How do we have to redo those agreements? What does that look like? So that's where this is just starting as well. These are just the original questions. So NASAC 2025 will be in Stowe, Vermont. Why Vermont? Because it's July. And so nobody liked when I had us in Las Vegas. 110 degrees. Yes, I actually really liked Las Vegas. It was very easy to plan. So Stowe, Vermont, July 21st to 25th. More information is coming, but we're really excited. We're essentially taking over an entire ski resort. It's a very great family-friendly environment. Lots to do if you bring your family there. So anyway, we're really excited. There's more information coming. We're just happy to have it on paper. Burlington. So Burlington's the closest airport. We've already looked at flight prices. They're shockingly great everywhere except from Philadelphia. Was the most expensive of all the ones we did a lot of. We did a lot of Google flight stuff, looking at different prices, but it's actually not as bad as you think it's going to be. And we will arrange shuttles from Burlington to and the hotel is doing all that with us and all that stuff. So that's the plan. This is the web address. How do you get involved? If you're not already involved in the Alliance, how do you get all the stuff I just showed you? It's all downloadable online. For real, we're going to have a newsletter. For real, as my kids say. And our meetings are also becoming more open. There'll be different rates. So you can come if you're a member center, you're one thing, or if you're a community-based organization, you're another thing. If you're a pharma person, you got to pay a lot more. That's the basic gist. Any questions about that? Any questions? Yes, of course. Oh yeah. It's really pharma and industry who doesn't get discounts. Everybody, well, we did come up with a response. Yeah, that was ours. Yeah, and we did it in collaboration with the SCDAA, but yes. It is somewhere. It should be on the website. I have to make sure it's linked. But it was supposed to be, so hopefully it is. All right. Any other questions? Okay, yeah. Oh, I think sickle cell care is going, if I have anything to do with it, at least, if the Alliance has anything to do with it, we will continue to improve sickle cell disease care. I do a whole grand rounds these days on how gene therapy saves sickle cell disease, and it has nothing to do with gene therapy. I mean, it doesn't with the actual gene therapy. It has everything to do with what resources we can harness. And most importantly is data. The problem, so if you look at diseases that have done really well, chronic diseases, cystic fibrosis, hemophilia, HIV, they've been collecting data for years. And you just don't get answers unless you have data, right? We have heard a zillion warriors tell us that hydroxyurea is not for everyone. Who's it not right for? We have no idea. So just by having a longitudinal data collection that can start to collect the data to answer the questions will improve care. But gene therapy, because it's going to be a multi-million-dollar therapy, they're going to want some rules around who gets it. And we're going to use all of that to our advantage to make sure that transplant doesn't walk away with the bonus here. We're going to make sure that the sickle cell centers and community-based organizations and that we gain from this, not as much financially, we don't care about that. We care about manpower. We want to make sure we are well-resourced to do what we need to do. So I do believe it will get better, and I believe we can help. So I think that's a whole nother discussion. So I think obviously we know that the United States has the kittens share of sickle cell disease, right? Sub-Saharan Africa, India, other areas of the world have a lot more. We also can't compare apples to apples in any way. And so I think there are many individuals who have global expertise in this area, and I am the first to tell you that I am not one of them. But I do believe that if we can set up a structure, especially a true center affiliate structure that works, that is something that can benefit worldwide. Because not everyone does have to be that expert center, that if you can come to your center once a year and get a full assessment and here's your recipe for this year, that can be carried out wherever you live with knowledgeable people. So if we can figure out how to make that work here, it's something I hope we get to take other places. I also think, in this gene therapy meeting, people said, well, how are we going to do gene therapy in Nigeria? And I said, can we start with newborn screening? Because gene therapy is very important, but let's not spend $3 million when people don't have access to hydroxyurea, right? Like, yes, we all want everyone to get these amazing transformative therapies, but we really want as much good for the many as possible. So that's my take. It is not always the most popular. So I'm going to stick with the US for now. All right. Do you want to go to the next slide set? Keep looking. All right. So with that, I want to tell you about all the current registries. And Ms. Newman, I apologize ahead of time. You've seen this before. And a few of you might have also seen this before. Yeah. If you were at the SCDC presentation, it's only changed slightly. But I wanted to explain it and contextualize it for why it's important for us as part of Embrace. Okay. So the title of this is not really what it's about. This is the sexy title that pharma wanted. This is how do you use data to identify people who are eligible for either sickle cell trials or therapies? Again, I put a lot into context of how I use gene therapy to make the world better for all the people who probably aren't getting gene therapy. And this is kind of like that. And this is a true partnership with the Sickle Cell Disease Data Collection Program and the National Alliance of Sickle Cell Centers and even the American Society of Hematology. Same disclosures. Okay, so there are 3 main registries. There are a few more. This is not the only ones, sadly. But these are different registries, so I want to describe them because I know, especially if you're newer to sickle cell in the room, you've heard us throw this language around, so I thought it was important to describe it. So we have the SCDC, which is the Sickle Cell Data Collection. Unfortunately, ASH's SCDC is the Sickle Cell Disease Coalition. The CDC came first, just gonna say that. So sometimes when you see SCDC, it means the coalition, sometimes it means the data collection program. In Alabama, we call ours Allstate. Not all of them have a name, that's just what ours is called. We just talked a lot about Granddad, and then a little bit, I'm gonna tell you about what ASH is doing is their data hub. So we're gonna talk about how these different variables are different and how this is gonna help us. All right, so the SCDC program, this is the surveillance data you've heard about. These are all the synonyms: surveillance data, CDC, SCDC, collects information about people with sickle cell disease. It's been going on since 2015. It is now in 16 states. And CDC continues to do this a little bit more as an act of good than a funded act. In fact, for a long time, they were minimally funded and only through their foundation. Now we actually have some federal line item funding. It's not nearly enough, but at least it's moving in the right direction. We are going to learn so much about sickle cell disease in Texas that we really are clueless on. I think it's going to be a really interesting, insightful learning this year. So I'm going to use Allstate, which is our program, as an example. So these are all the different data sources that all of the programs collect. I'm telling you about them specific to Alabama, but they would be the same if you looked in Georgia. We have center cases. So these are who is being followed for sickle cell disease in your center, who has a definite, what we call level 1 confirmation, a laboratory confirmed diagnosis of sickle cell disease. And we collect these from all the different centers in Alabama. In Alabama, there's 3 main centers we're connected. We have ours, which is the Lifespan Center that connects UAB and Children's. We have USA in Mobile as the only other center. And then we have Huntsville, which is St. Jude's, has an affiliate there, and they follow about 50 to 60 kids. So those are our database center collections. And then we are, as we started our affiliate in Mobile Infirmary, we're able to identify true cases from that data. Then we have all the administrative data. So some of that is newborn screening data. That's also level 1 data if it's confirmed, right? We know who those kids are who have sickle cell disease. Then we have discharge data. Some states have databases that are for all of the discharges in the whole state. Alabama is one of 4 states that does not have that because we're just that awesome. Some of the states, it's not as good as others. South Carolina has a fabulous all-payer database that can be used, that we used when was there. So what we have to do in Alabama is go to each and every hospital and get their discharge data. Obviously, we can't go to every hospital. Just think of the number of data use agreements we'd have to have. We have a whole spreadsheet of our data use agreements and which one is due. So we go to all the biggest hospitals and all the UAB affiliated hospitals, which still covers about 60% of the state. Not as much as we want, but it is the best we can do at this moment until we have that all-payer database. What that looks like is a list of patients, all of their names, the address they used when they came into the hospital, their insurer, their length of stay, their ER visits. That's what we get when we get that. If you don't have a good informaticist, it is like so much overwhelming data. And not all of those people have sickle cell disease, right? Because we're really bad at coding as doctors, or whoever codes for us, which is not always the doctors. We have a coding service. They keep wanting to give my patients the diagnostic code of essential thrombocytosis, meaning high platelets. Oh, it's driving me crazy. I'm like, no, please stop. Somebody's gonna accuse me of insurance fraud, and I'm not even doing the coding. So again, it's a hot mess, but we get it all together and we put it together and then we can make it less of a mess. When you take all of that in Alabama, we actually had about 40,000 cases. I said greater than 25,000, it's now greater than 40,000. Only about 10% actually have sickle cell disease. So when you just have a big data dump, that's what that looks like. And that's from anybody who had 1 inpatient or 2 outpatient codes. So we refine that into definitions. And these are the definitions. So a level 0 means we know you do not have sickle cell disease. You have an electrophoresis that tells me you don't have sickle cell, right? I know that. Level 1 means we either have a confirmed hemoglobin analysis, that's either case-based data or EMR-based data, electronic medical record, or we use the SCDC definition, which is that you've had 3 unique visits, meaning 3 separate visits. So it can't be someone who comes to the clinic, the ER, and the hospital on the same day. That's 1 visit. It has to be 3 separate time points within 5 years or 2 visits in 2 years. That has about a 94% positive predictive value. So in all the studies we've done, that is usually accurate. That usually means somebody actually has sickle cell disease. I will tell you, it also depends on where you are. Now that I've looked at Mobile Infirmary's data, theirs is much lower because they keep calling people with sickle cell trait sickle cell disease. So there are caveats to it, but overall, it's a pretty good measure. We have level 2, which we developed an algorithm that I can take all the EMR data from someone if they don't have an electrophoresis and tell you if they likely have sickle cell disease or likely don't have sickle cell disease. We're working on this. We're actually working with Georgia on refining this and improving it, but that gives us a level 2 definition. A level 3 definition is I have a lot of data and all of these people have codes for sickle cell disease. And when I look at your EMR, I really don't think you have sickle cell disease, but I can't say you don't because I don't have anything that says you don't have it. So then you're a level 3. And then we have level 9, which is you actually have sickle cell trait. We've confirmed that you have sickle cell trait. We've made some more levels since then, but this is the basic gist. And now we're getting all of the SCDC to use our same terminology. So level 1 is all we're going to talk about from here on out. We already talked about Granddad, started in 2015, started by Doctors Little and Landskron to build this shared database. We stopped using all of our center-based database and then adopted by NASAC. 72 sites, we get everything. This is highly curated data. So one of the things that makes Granddad so important, as many of you know, is that if you look at an MRI report, the impression may say no acute stroke if you're looking at the report. And then you read and it says areas of hypoattenuation concerning for microvascular changes. They've had a silent stroke. They don't write that in the impression. And so unless you know what to look for, you can't use that data. If you just got that in like that MRI, the impression, all it would come out with is no stroke. So it's highly curated, meaning someone goes through, reads it, and puts it into a definition. The same is true in multiple other ways, just the MRI is the clearest. But I'll tell you the second clearest, TCD. We just published about TCD quality and how bad we are at putting something in the same uniform way. We looked at 28 centers. When they reported TCDs, they reported them in, you got it, 28 different ways. There is no standardized form. This is ridiculous. You're looking at very specific measurements. When you do a CBC, right, a complete blood count, you get very specific measurements. And regardless of what hospital you're in, you're going to get hemoglobin, hematocrit, white count. That is not done for these other things. So it's very hard to take that data and operationalize it easily. So it means that each patient, when we load a new person into Granddad, it takes our coordinators on average 90 minutes. We have managed to get that better by making the physicians work a little harder, by making an annual note where we have all that information so they know right where to look and they're not looking all over the chart. Very, very important, we also collect patient-reported outcomes. Right now, we collect them every year. We would love to collect them more often. People get very tired of doing surveys, but also it's just very hard to financially operationalize that at our level. But over time, for example, we were able to compare outcomes for people in the in Granddad here to those in a center in England to look at what quality of life looked like in 2 different places because we use the exact same measure. So that's pretty cool. And now we can do project specific. So my R01 recipe is going to use Granddad. Well, why is that important? When I did this whole display study I told you about with 28 centers, we have 240,000 case report forms from that study, and it will all go to waste. And what I mean by that is there's no central place that data lives. It's in its own group over here. But if I said, I want to know, in 5 years, if the kids from MUSC are doing better than the kids from Miami, I can't ask that question because that data didn't stay in one system. If we keep using this same system to add new case, so for recipe for unaffiliated patients, I'm going to be able to tell you if you established care with us versus established care at Augusta, what your outcome is going to look like in 2 to 3 years by what we did for you. And that data is not going to die when my grant goes away, right? I'm not going to lose my data source. All of these studies, all these pharma studies, the STOP study, they're all in their own little silos of data, which means you can't take information from STOP and put it into Granddad. And it's a huge travesty in the data world because we lose all this money. The other thing is we spend all this money setting up a new database. So let's use what we already have. That's the whole idea here, so that we can make this worth everybody's time and money and get the answers we need to take care of people. What is the ASH Data Hub? You may have heard of this. I'm very confused, so I'm probably still going to use the wrong titles for things because ASH has changed them. But American Society of Hematology has a research collaborative as part of it. Part of that is the Sickle Cell Disease Data Hub. They collect data in 2 diseases, multiple myeloma and sickle cell disease. It's an experience. It is, they take everybody in my EMR system, right, in at UAB, take everybody with ICD 9 or 10 code for sickle cell disease and put it in this, along with all their lab data, and then try to do this. Basically, they try to say, we know who has sickle cell, we know what meds they're getting, we can identify best practices. Try. Okay. This is what they have so far. This is their slide, not mine. There's a lot of concerns because they keep saying we have 25,000 patients in our database with sickle cell disease. No, they have 11,000 that actually have sickle cell disease in the database. They can't tell us what genotypes they have unless they ask Granddad or the physicians for those genotypes. It's got some issues, to say the least. The other thing is it's just UAB data. So if my patient goes to Piedmont Hospital in Columbus, none of their data is in here. It's just UAB EMR data. They can't answer the questions about TCDs and MRI reports because I already told you those reports are not translatable in a useful way. So instead, they made all the centers go back and fill all this out on each patient. Looks like Granddad. Huh, funny how that worked out. As you can imagine, we've had some tension, us and Data Hub, because we want to work together and we care, well, let's just go with that. We want to work together. So, okay, how do these all fit together then? I've just told you about 3 separate data sources. We have them all. What does that look like? This is how I think of it. The purple is curated Granddad patients. I know they have sickle cell disease. I do patient-reported outcomes. I look at all their complications. We have a good, solid knowledge of those individuals. Data Hub gets more patients because it's pulling people that don't have sickle cell disease. That's why that circle is bigger. But it also may pull people who've gone to UAB Hospital but aren't in my center, right? They have sickle cell. They're just not seen in my center. So they're a little bit, they cast a wider net with less specific outcomes. And then there's SCDC, which is my red circle here. It is population level data. It is from the state. It has the most accurate acute care data because it captures wherever that patient goes. And it's the most accurate for medication fill data because it has not just prescription history, but did the patient actually fill it history. Doesn't mean they put it in their mouths, but it means they brought it home or took it out of the pharmacy. So what are each of these things tell you? These are all the different sort of data groups. And when we originally tried to make this Venn diagram, by the way, it's really hard to make a Venn diagram in PowerPoint in case anybody wanted to know, because you can make the 3 circles, but you actually can't make them with a centerpiece that overlaps. Doesn't work. So it's not a Venn diagram. Anyway, what? Yeah, I'm not good at Canva, but I'm trying. Anyway, so these are all the different things you get out of each. What's bolded is what is clear. You can clearly get this information out of each one. So when we started looking at what actually overlapped, because that was the first question that we had, I'm going to skip and go back to this. Very little. These are the three things that overlap. There are specific patients that are in each database. You can get their medications in each database, and you can get when they died in each database. Those are the only three clear things that overlap. Not great. But if we look at how we use them in partnership, you can get better answers. So as an example, if I wanted to enroll you in the current the phase 3 Bluebird study, we looked at the bare minimum criteria. What can I figure out that we're going to be able to answer? So you have to have a sickle cell anemia phenotype. You have to have had at least 2 VOCs per year for at least 2 years. You have to have failed, tried, taken, looked at, thought about hydroxyurea. You have to have a comorbidity assessment. You can't have moya, among other things. You have to have a current assessment of kidney function. You can't have ESRD and be on the study, end-stage renal disease. And we can look at your medications. And you can see here where you can find all of those different data points. None of them are in one single registry. So then we say, well, what if we want to follow someone? What if we happen to maybe be CMMI and we're trying to maybe develop a model of payment-ish for gene therapy, and we're going to reimburse or we're going to require pharma companies to reimburse hospitals or insurers if the patient doesn't do well. They don't have the best outcomes. What does value-based care look like, and what are we going to call that, and how are we going to measure it? So right now, I will tell you, CMMI and Granddad are not partners. We want to be. But how do we follow? Well, they want to know how much anti-sickling hemoglobin they're making. They better look in Granddad. They want to know the vector copy number. That's only going to be in Granddad. They want to know if they're getting acute care use. Well, they can look in ASH, the data hub, if they're at UAB. But if they're anywhere else, you have to look at Allstate. When you want to know about new comorbidities, did they now develop a stroke? Are we wrong? Was this not as protective as we thought? That's not actually anywhere but Granddad. Current assessment of post-gene therapy labs, that's where Data Hub comes in. We can get those labs out of the EMR. And what about their current medications? So again, this information is in different places. So I told you where the overlap was. It's pretty minimal, but you can link patients. So it turns out we're not as cool as we thought we were. We're not the first to do this. You can link people in different data sets with an ID that cannot be tracked back to that person. So I, Julie Cantor, am in Granddad, and I have this thing, it's called a hash. Please don't ask me to explain this in any appropriate information technology terms, because I will absolutely fail and will have to ask my son. And I'm already over time, so I'm just realizing that I'm in a hurry. But this is really important because I want people to understand the privacy things here. When you use the hash it's really a combination of my name and date of birth, you will get a 12 string of random letters, numbers, and symbols, right? 2, 3B, hash, exclamation, question mark, whatever. When you use the same hash on my same information in Allstate, you get that same 12 string. There is no way to reverse that. You can't take that 12 string and find Julie Cantor in the date of birth. It's actually not possible. Don't ask, because I really didn't make this up. But it means that I can be here and here, and you can know I'm the same person. And I can be here, here, and here, and you can know I'm the same person. It also means we can take people in Granddad and connect them to our patients from other trials if we have those data points. So we might be able to go back and say, what happened to our displaced patients 5 years later using this linkage technology? And it makes all of our systems more powerful. It becomes de-identified non-human subject research data because it literally cannot link back to your HIPAA information. Again, we didn't invent it. No one else had used it for reasons that are beyond me. So When we think about this gene therapy question, we can get answers from each of these different places, but you need the information from all of the above. Really, you can do it all with Allstate and Granddad. Just saying. But I get in trouble when I say that too loudly. So I'm going to say we can use all three to work together. But it was only in this room. So how does each registry interact to give us the big picture? Here's our clinical longitudinal information that we want. Here's how we can get all of the different information. The colors quote to where you get them from, as you can see. And we're going to be able to, I think, harness all of this to give us the answers that we're looking for, if we can make everybody play nice together, which is the hardest part. 3 main registries, they all give you something different. Granddad is the only one at this point that's giving actual patient-reported outcomes and phenotypic information. The surveillance data is the only one that really gives us population information and helps us discern differences between patients treated in centers and not treated in centers. And Data Hub is the only one that can give you real-time laboratory assessments. We really don't have time for questions because I'm late. So I'm going to have you email me for any questions that you have. I'm happy to share to share these slides. Just recognize that it's not published and yeah, that kind of thing. But I'm happy to share. So JJ, I'm turning it over to you.
And I think we can use some of our next wrap up to help with the questions, because we have a little bit of wrap up time. So those are my disclosures. I'm going to start out by talking about the current guidelines for the management of acute sickle cell pain, which, as you've heard today, aren't perfect, but are a good starting point. And then really the focus is how you implement system-based approaches to improve acute pain management. And this is really focused on the sickle cell centers, but there's also a big piece of this for the people with sickle cell disease in this, where we really need to work with them. So this is Carlton Haywood, who I think some of you knew, but who I worked with and Pat worked with closely at Hopkins, who was a person living with sickle cell disease. And he did a lot of seminal work to put numbers on some of the things that we know that happen to people with sickle cell disease when they go to the emergency department. So we know that people with sickle cell disease wait longer than general emergency department patients, including longer for pain treatment than the general population. We think that's mostly explained by bias based on race, but they also wait longer than patients with long bone fractures after accounting for race and triage priority. And we think that's a sickle cell specific stigma, excuse me. And because of this, we know that many people with sickle cell disease delay emergency department care when they need it. And those that have more frequent ED visits, so the people that spend the most time experiencing the ED, are the most likely to delay care. So the more you interact with us, the healthcare system in the emergency department, the more likely you are to delay care. And when you ask people, they say it's experiences with stigma as well as low satisfaction with the quality of their healthcare. And then, specific things people say, their credibility and trustworthiness is often questioned by providers. The request for specific medications is labeled as drug seeking. And even within our own system, we have one emergency department that will not prescribe hydromorphone dilaudid for anyone in their ED. They're dilaudid free, even though we think that for some people that's the best medicine. And that's what we have in our pain plans for them. In the words of one person, it's devastating for a person to be in pain, but not to be believed. It makes you feel less than human. And the trust is broken when the person you come to for help reacts negatively. And from some other work that Carlton, Dr. Haywood did, we know that perceived discrimination, that sense that you're being discriminated, against, is associated with a greater burden of pain. So it hurts people. So these are the American Society of Hematology Sickle Cell Guideline Initiative, and Pat and I were both on the pain protocol, which the goal was to synthesize the best available scientific evidence on sickle cell disease based on a systematic review of the literature. And they used the grade process to rate the quality of evidence. You can see there were 5 of them, like Julie talked about. And then I think there was one other important thing that's not on this slide, that there were 2 people from the sickle cell community that were not healthcare providers or psychologists. It was one parent of a adolescent that had moved into adulthood, but so one parent and one person living with sickle cell disease that were on the panel, and they weren't just on the panel, they voted, they were full members of the panel, just like everyone else. So what did we come to? So for severe acute sickle cell pain, a vaso-occlusive event or crisis, that people should be treated within 60 minutes. That's 60 minutes of arrival. They should have tailored treatment based on their baseline treatment and prior effective therapy. And I'll point out that those that are in italics or suggest, what suggest means is that it's a weak recommendation, usually based on the quality of the evidence. You should use individualized pain plan or a sickle cell specific protocol in that setting. Providing non-steroidal anti-inflammatory drugs unless there is a contraindication that there is some reason that there is increased risk for the person. That sub-anesthetic ketamine for opiate refractory pain be considered, and then also regional anesthesia approaches for opiate refractory pain. And then no recommendation for or against continuous IV opiate infusion, and that's with the PCA when you're getting some opiate all the time, which is more commonly done in pediatrics than in adult medicine, but just not enough evidence to really say whether that approach makes sense. And then no recommendation for or against IV fluids based on a lack of data. I think there's some data that have emerged since the guidelines that make us, I think, less excited about IV fluids in people unless they are clearly dehydrated or unable to take adequate oral intake. And then other things that are non-pharmacological approaches. So again, a weak recommendation or suggestion for massage, yoga, transcutaneous electrical stimulation, virtual reality, and guided audiovisual relaxation is all things that can be effective for severe acute sickle cell pain. And then inadequate data for biofeedback or acupuncture in that setting. To use only oral antihistamines, and the things in blue are consensus panel expertise. So there wasn't enough evidence for these recommendations necessarily. And then to reduce the risk of acute chest syndrome, to encourage the use of incentive spirometry. That's in bold because it's the only strong recommendation, and that was based on a randomized controlled trial. So we want people when they're hospitalized to have their incentive spirometry or something equivalent if they're younger. And then to monitor for excessive sedation by an objective scale and oxygenation, gradually titrate down opiates as the VOC or VOE resolves. Again, expert consensus panel expertise because we don't have good studies of how to reduce people's opiates when we've been treating them for severe acute sickle cell pain. And then to not transfuse packed red blood cells unless there's another indication other than pain. We don't think it shortens the pain event. And to administer oxygen if someone has low oxygen saturation. All right. I wanted to move on to, what can we do as far as disease modifying therapies? So not treating the pain event or trying to prevent complications, but, are there things we can do? And there've been many unsuccessful randomized controlled trials to interrupt acute vaso-occlusive pain. I put up 3 that are more recent that I was involved in: Rivapansel, inhaled nitric oxide, and Poloxamer 188. And then also some non-opiate treatments for acute pain. So ketamine decreased opiate utilization and pain rating, but not length of stay for people that were hospitalized with sickle cell disease. And then there was a gabapentin phase 2 that decreased pain scores in a subgroup, but not overall, and also didn't shorten hospitalization. So we really are struggling. I think the one thing that has been shown to decrease sickle cell pain once it started is high-dose corticosteroids, but there were lots of side effects from the high-dose corticosteroids, and that's not an approach that we typically take for sickle cell pain, but it was successful in getting people out of the hospital faster, but some of them came back with really severe sickle cell pain. So that's not something that we do. So we're still looking for those therapies. And this is something really, really important, but really, really hard. It's hard to stop sickle cell pain once it's started. So what should we be doing in the emergency department? So the first step is people need to be triaged appropriate. We think that people with severe sickle cell pain and severe pain, that the definition is typically a pain score of 7 or above when we talk about severe versus moderate versus mild. And that it should be triaged as high priority, that's ESI 2, since at risk for significant morbidity. And that's the same as other conditions which are severe enough that you're likely to be admitted to the hospital. But you're behind the ESI ones, gunshot wound, penetrating trauma, strokes, acute myocardial infarctions, that sort of thing. And then to check for signs of other complications, stroke, sepsis, acute chest syndrome, pulmonary embolism, and cholecystitis as some examples. That the pain should be treated aggressively. So beginning analgesic management within 30 minutes of triage or 60 minutes of registration, and to consider alternative routes to IV, including subcutaneous or intranasal opiates to speed that time or other novel approaches. And then to administer IV opiates every 15 to 30 minutes until pain relief is obtained, and that you can increase the initial dose by 25% if not effective and there's no excessive sedation, and using non-pharmacological approaches such as heat and distraction, and then beginning a PCA for those needing admission. And these guidelines were highlighted as a point of care resource by the American College of Emergency Physicians. So a bunch of ED providers and people with sickle cell from the sickle cell disease community, including some patients, as well as sickle cell pediatric and adult providers, were involved in developing this. It's on their website, it's free, and it's actually the second most commonly accessed point of care tool that they've developed. So it's, in the grand scheme of things, it's been well utilized and is something that is a good resource for people working in the emergency department space, because it's written in their language, not in my language or Pat's language. I mean, like if Pat's talking to the ED, they're like, "What are you talking about? I need to go mountain climbing," you know? So I want to move on to how do we develop individualized pain plans. And I think there's a debate over whether individualized pain plans are better than a sickle cell protocol in the emergency department, but there are lots of things about individualized pain plans that people like. They're made for you, they're kind of bespoke, right? So the first is you need to decide the focus, outpatient or emergency department or inpatient or both, whether you want to do those as two separate processes or two separate documents. You need to talk with the individual with sickle cell disease. Why? Well, you might know that when you get morphine, it makes you scratch yourself to death or vomit, but I might not know that, even though maybe I should, right? But I haven't been in the ED with you. And if all your ED utilization is 90 miles away, I might not have that detailed record to be able to figure it out without asking you. So we want to know the location, timing, and type of pain that you have. Make sure that we're helping to distinguish what could be more non-sickle cell acute pain from other pains. We want to know what your current medications are, what your response to various treatments have been, and also your preferences. Like maybe something doesn't work for you because you know that when you go to the emergency department where you are, they don't have it, right? Like I want to give you IV buprenorphine, but maybe that's not something that they have. So even if it works for you at Duke, it might not work for you in Fayetteville. And then you need to write the pain plan and assure access. Well, who should have access to it? The patient, the sickle cell team, the ED and hospital providers, and both within and outside your health system, your institution. And remember that's a guideline and a starting point and not set in stone. And I'm not there with the emergency department provider. So sometimes they're seeing something that I can't see, I'm not there. And sometimes I can't get them to do what I want, even if I think it's the right thing to do. And sometimes we have to agree to disagree. And unless I'm going to walk in there and see the patient and take care of them, they're going to have to do what they think is best in their clinical judgment. But we try to make sure they have the same knowledge that we have about the patient. And here are some examples of more outpatient plans, and at least the one on the left and the one on the bottom, which you can see one's the green, the stoplight system that was adapted from asthma, where you have green, which is mild pain, things that you can do for mild pain, yellow for moderate pain, and red for severe pain, and you kind of work through your interventions. Here's the top of another pain plan, and then here's an older version of one of our individualized pain plans that we used, but just different approaches for different settings. And then this is what we are using currently at Duke for individualized pain plans. And this was based on a discussion with almost all of the North Carolina sickle cell centers, where we sat down and we talked about what should be on a pain plan. Not everyone was on every call, but we talked about what is kind of the core elements that we wanted. So you have that it's an emergency care plan. You have something written to the emergency department provider that has a little bit of information about what it is and the patient. You have who their doctors are, how to who their providers are, how to contact them, whether they should get opiate prescriptions at discharge from the emergency department or not. And then we have alerts. This alert is for someone who seldom comes to the emergency department, which is Pat taught us is a lot of people, and that you should be have a high awareness that something else might be going on, because sickle cell pain is not their usual that brings them into the emergency department, even more so than in the average person, where we always want people thinking about other things. And then you have their acute sickle cell pain management, which is typically focused on the first couple hours in the emergency department. And then if that's not successful, moving on. Oops. I lost the second half. We'll come back to the second half. We'll hopefully turn up somewhere in the slideshow. I'm sorry. And then, what do we want these individualized pain plans to be? So easily access and expected that they will guide care. How do you expect that they'll guide care? By partnership with the emergency department, because they want to do the right thing. But when they see the person who's coming in 100 times a year and is getting IV opiates, they start to wonder whether that's the right thing for anyone with sickle cell disease, if you don't have a good plan for that person coming in 100 times a year. They need to be dated, updated, and briefed. Why dated? Well, because if it's from 4 years ago, I don't really want them to use it without thinking pretty hard about it, because I don't know what's happened in 4 years. So we try to update them in 12 months. That might be a little long, but it's feasible for us at least. Specify the opiate, the name, and the dose. And then for admissions, PCA settings, and at least setting the idea that they should be started in the emergency department. And that's because that time for when you go to the emergency department until someone's really taking care on your floor can be a couple hours to get orders. Getting a PCA set up on the floor is hard because you need 2 nurses to check it. This can be a challenge getting them to do it in the emergency department, but it does make things better. And then advisories, those complicating medical conditions, opioid sensitivity, respiratory depression, and delirium. I do worry about one group of people, especially with sedation, and that's people that have obstructive sleep apnea. So they're wearing their CPAP at home when they sleep. We give them a bunch of opiate. They've been up a lot. They fall asleep, right? That's what people do. And then they obstruct and bad things happen to them, like an acute respiratory event that can be life-threatening. So we want to make sure that information is shared with people, restrictions if appropriate, and then opportunities to provide other specifics. So I wanted to talk about a study that was done through the Sickle Cell Disease Implementation Consortium to improve access to ED care plans. And this trained ED providers on sickle cell triage, diversity, equity, inclusion, implicit bias, with a focus on sickle cell disease at 8 academic medical centers. And then they had the hematologist develop individualized care plans. They entered these into the electronic health record. Sorry, typo there. And then they shared the individualized pain plan with the patient, so they could have it, so they could get through it through the patient portal. So MyChart, if you're on Epic, but they could pull it up on the app on their phone and show it to someone. And why that's important is that when we talked to emergency department providers, they kept on telling us that they wanted to use the patient's pain plan, but they had to make sure that it was verifiable, that it was up to date, and that it was from a provider. And the way to do that is to come in through a recognized patient portal or some other source. Back 10, 15 years ago, there were all these efforts to set up secure spaces to store these records for patients. And what we discovered is that the emergency department provider did not want to have something where they had another password that they had to log in and go through all the security to keep that information private. But now we have patient portals where someone can just walk someone in. And then they collected patient feedback about how things went and assess the ED provider comfort with the process. And that's the other half of the individualized pain plan. So we do adjunctive medications, which you can see there, something for nausea, additional things for pain, something for itching typically. And then we have their PCA settings, their patient allergies, and the time that is updated. All right. And then finishing up with this. So this study was recently published, and you can see that Lauren Sweeney, who's an ED provider with a focus on sickle cell disease now at Duke, and Paula Tanabe, who's been doing research on how we can better treat people in the emergency department with sickle cell disease for about 20 years, were the people at the beginning and end on this. So what they showed is that patient perceived ED pain treatment the quality of that as being high at baseline and post-implementation of the individualized pain plans, but they didn't see a difference. So they already were pretty happy with their pain care, at least at these centers. Provider perceived their comfort of managing vaso-occlusive events increased, but it was not a statistically significant increase, but 60% were extremely comfortable. And then almost all providers, this is about 1 out of 40 encounters ordered the recommended medication. So people really followed the plans, and all 8 sites successfully implemented the individualized pain plans. And both patients and providers endorsed it as being successful. So it seemed to work, at least at these 8 centers. I want to move on to the North Carolina Governor's Council on Sickle Cell Disease. One of the things that happened at the retreat, and this was a couple of years ago, is that sickle cell pain treatment in the emergency department, and more broadly, emergency department care, was identified as a priority or an unachieved need for high quality care. And because of this, a group of people, and that included physicians, nurses, state and community representatives, met and worked on this issue. And it was actually 2 subgroups. One was it's called the Medical Research Committee, but it really is the Healthcare Provider Committee. And then it was also the Community-Based Organization Committee, are the 2 groups that worked together on this. And it was led by Paula Tanabe, who did most of the heavy lifting, and me. And the focus was really on implementation. And we identified a focus on the 20 emergency departments that saw the most people with sickle cell disease. And that was based on that CDC effort, the sickle cell surveillance, that allowed us to look over a period of 5 years where people were going. And I tell people that there were surprises in that Cone Health, which is in Greensboro, was the ED that was seeing the most people with sickle cell disease, which surprised a lot of people, including all of us. And we developed a toolbox, and the goal is to disseminate it to 20 emergency departments. We've started out with the first 5. There's a letter to leadership, the CEO of the hospital, the emergency department nurse and medical director, so those 2 directors. And then there was a letter of support from North Carolina state officials, as well as from the North Carolina state sickle cell programs. And we had letters from the Emergency Nurses Association for the state of North Carolina, as well as the Emergency Department Physician Organization for North Carolina. They had letters of support as well. And then we also incorporated that there was going to be a new measure looking at ED care that was going to come out through CMS. So there was both kind of a little bit of a stick. The stick's coming, not us, but the stick is coming. And then the carrot was that we had the support from the North Carolina State Sickle Cell Programs and people on the committee that they were going to have a coach, along with providing some materials, a coach that included both an emergency medicine expert in sickle cell care, as well as a sickle cell disease expert to help them. So what's in the toolbox? So we had the evidence-based standard of care for acute sickle cell pain. So really had some of those things that we've talked about, some core principles and best practices, including references, a North Carolina sickle cell syndrome program referral form. So when you have that patient that's in the emergency department and they don't have a sickle cell provider, there's a form where you can refer them to our state program, and they will be contacted by one of the sickle cell educator counselors, which might be through a community-based organization, might be directly through the state, and they will help get them into sickle cell care and navigate now our rather difficult framework of multiple Medicaid providers, some which can go some places and not other places. The insurance landscape has gotten a little more complicated, or if someone doesn't have insurance, there are some other options through the North Carolina Sickle Cell Syndrome Program. And then also some suggested indicators to measure quality of care. I think that we've talked about those before, but time to first dose, proportion of people that are able to leave the emergency department and return home versus being hospitalized, the amount of time people spend in the emergency department, and then some weight-based opiate charts and individualized dosing guidelines. And then for the North Carolina State Sickle Cell Program Services, we made a commitment that we would help develop individualized pain plans with the emergency department, even for patients that we weren't caring for. That's a little bit different because we can't really provide direct medical advice, but at least creating a framework where we can help walk them through how they can make a plan for a patient that's coming to the emergency department and isn't being seen in clinic as well. And then consultation for new patients. And then we already talked about the coaching for the emergency department programs. And so far, we sent out the packets to 5 hospitals, all responded to the packets and identified a team to work on this. We've had an initial meeting with 2 of the 5 centers. Some of the people have started attending our multidisciplinary, our multi-institutional pain management group, which I can talk a little bit more about. And we had our first follow-up meeting of the committee later today after having these materials sent out. All right. And I just wanted to present some data on opioid safety in unmonitored ED areas. So one of the things that happens at some centers is that you get treated in the waiting room or the hallway. And those are considered to be unmonitored areas because you're not on a monitor. And if you're in the waiting room, there's some people around, but you're in the waiting room, right? That's not the emergency department. And this has become necessary because of problems with ED overcrowding that I'm going to talk about. And this is work that Lauren recently presented. This is from October at the big emergency department meeting. So what's the need? There are increased patient volumes and increased ED boarding. And ED boarding is when you have 90 people in the emergency department waiting for beds for a day. And if it's a psychiatric bed, it might be 2 weeks, right? And those people take up space and you can't get other people in, right? The ED gets rather congested. So you have patients in the hallways and waiting rooms for many hours. I had one patient that was telling me that I really need to work with the ED to get more comfortable seating because if you're going to be sitting there for 8 hours, it makes your rear end hurt. And I said, I did share that. I got a little eye rolling and saying, we need those plastic seats that you can wipe off quickly and, get rid of those germs. But that wasn't a patient with sickle cell disease, but it still made her rear end hurt. And then we want to be able to rapidly treat people with severe pain. She did not come to the ED for pain. And then the concerns, so there's a risk of oversedation with opiates. There's a risk of respiratory depression. And there's the need for rapid recognition if this is happening and reversal with naloxone to keep people safe. And I have not had anyone die in the emergency department, but I did have one patient who with obstructive sleep apnea that had a respiratory event, developed acute renal failure and rhabdomyolysis and was very ill, and then managed to get better, but certainly can happen. So the study design was a cross-sectional analysis of electronic health record data from a large urban academic emergency department for 2 years, 2022 and 2023. And they included any dose, frequency, or route of administration of an opiate. So this could be IV, sub-Q, intranasal, oral, any route. And it was areas without continuous vital sign monitoring, and that's triage, the hallway, and the waiting room. And I can say that I see the patients in the waiting room, right, that are getting this. So it's not just that they're already back in the hallway or that they're in triage. Sometimes they're just out there. And the outcome of interest was naloxone administration. That was something that was easy for them to pull, very discreet. So they administered opiates to 11,732 patients. It's a lot of people, isn't it? In an unmonitored area. Most of these people did not have sickle cell disease. We see about 1,100 people a year, right? So maybe a couple thousand of them had sickle cell disease, but the rest of them had other conditions. The average age was 47 years, 54% at ESI 3 presentations, so a step down from that ESI 2 that we talked about should be for sickle cell disease. A quarter had abdominal pain, a third were admitted to the hospital, and 38% of them received IV hydromorphone, which is probably the most common treatment that we're giving to the people we care for with sickle cell disease in the emergency department. And they had to administer naloxone 7 times, right? This is a rare event, 7 times out of 11,000, anywhere from 4 to 18 hours between the initial opioid dose and naloxone administration. And one patient required emergent naloxone in an unmonitored area that presented for acute on chronic respiratory failure. So that adverse event rate, very, very, very low. And this is information that one of the things that we identified as we went out to other emergency departments is that some places were very worried about giving opiates in unmonitored settings, even to people with known opioid tolerance and pain plans that really were, I think, well positioned to receive this. So this hopefully will help with that. So to conclude, for acute pain, we need rapid assessment and treatment. We need appropriate doses of opiates, IV fluids if unable to take oral hydration, concurrent non-pharmacological interventions. And I haven't talked about those because they can be hard for us to do, and the systems to provide consistent care. And I have some more information on outpatient opiate prescribing that we can talk about if you want to, or more about buprenorphine. But I think that we should probably take some questions instead.
If I'm correct, said 125 mils per hour on the IV fluids.
Oh no, that's our pain plan. There are no guidelines from ASH on IV fluids.
Okay.
But in general, if we're going to give people IV fluids, and we still do in our day hospital, for a lot of people, well, we stopped during the IV fluid shortage. But we still, if people don't have problems with volume overload, we will often give them IV fluids with D5 half normal saline at 125 an hour.
Base it on the weight more than the standard,
Yeah. Yeah. I mean, sometimes if someone's small, we'll go down on that. But it really depends. And I think that it's very reasonable to say that oral hydration is suitable, and you definitely need to be careful about sodium load. And we have a definite substantial group of patients that come to the hospital and someone's giving them a couple liters of normal saline and their legs swell up and their legs hurt from being tight. And but I think it's more the sodium load than the free water that causes the problems. But when you give half normal saline, if you're giving 3 liters a day, that's quite a bit of sodium still.
So you worked on those ASH guidelines. We have had trouble convincing our people to let us use ketamine. Do you have experience, or how are people doing this nationally? Are they letting it on the regular unit? Are they going to intensive care, ED?
Sure.
We're having trouble getting them.
Yeah. So I would start by saying that ketamine is not that good. I mean, it probably helps some people. Some people really don't like the dissociation from it. We do ketamine on the regular floor with ketamine infusions without any difficulty. It is supervised by our anesthesia pain team. In the emergency department, same thing. These are lower doses of ketamine than you would typically use if you're going to relocate someone's bad fracture. So it's a lower dose. And places do it in the emergency department as well. I think that there are some programs that are using a lot of ketamine in the emergency department, really opiate sparing approaches. I'm not sure if that's the best approach, but we aren't using it much in the emergency department. It's mostly once people are in the hospital, though there's interest in studying kind of early ketamine versus late ketamine as a strategy.
So we use ketamine a fair amount at Hopkins. This will shock no one in the room, but I'm a bit skeptical about some of the research on it. So there are a couple of randomized trials of ketamine in sickle cell disease that are advertised as showing an opioid sparing effect. They are single dose substitution studies where you would expect them to reduce the amount of opioid by exactly 1 dose. And that's what you saw, which doesn't cross the line for me for an opioid sparing effect. The observational studies are usually after we started ketamine, the patient's pain got better, which means we started in the last half of their crisis. So yeah. So I'm with JJ. I mean, I think it's a reasonable thing to try for refractory pain when you're up a tree and it does something, but we got to be a little careful interpreting some of these studies. I think they're a little over advertised. We do it at Hopkins. We do it on the regular floors. Our colleagues in chronic pain manage it mostly. We've had some difficulty with variation in tolerance of risk for ketamine in our various consultants that we work with. We do it in the ED, and we recently got approved to do it in our infusion center, which we did for a little while, but frankly, we lost some nursing capacity, and the folks we were able to take on were temporary intra-staff kind of things. And so we kind of put the brakes on until we had people that we thought were more capable of monitoring.
So you mentioned the adverse reaction rate when you use the non-monitor setting. Do you know how this compares to the adverse reaction rate in monitor setting?
Yeah, so I don't have high quality data, but I can tell you in our sickle cell day hospital where we see a little less than 1,000 encounters for pain a year, probably about 900 now. It's about once a year that we give someone naloxone. It's so that's higher than this, right? And that's a monitored setting. They didn't compare it to their monitored data. I think that the people that are monitored are probably include more high risk people as well. So it's probably higher. I'm not sure it's apples and apples, but if you give a lot of opiates, you're going to give someone naloxone. And I'm shocked by how low it was, but I think it reflects that they haven't gotten burned. They haven't gotten burned by this approach, right? And it really speeds up. If you have to get back to a room, 6 hours often. It really changes your time to that first dose. And getting people trying to jump the line. When I call up and when we send someone down with a PCA, right? They don't let you have a PCA in the waiting room. And those patients don't get a room and they stop the PCA and their pain gets worse and then they end up getting admitted. I mean, it's horrible, right? But like when you call down and you talk to the charge nurse and try to push someone through, it takes someone with more. I don't have the pull to do it. I can say that. Sure. So we've focused on a couple of different things, right? From how do we get people primary care and engaged in their care to how we treat emergency department sickle cell care. And I think that while this is all a continuum, right? Our goal is to shift people from needing the emergency department to being able to manage more and more of this in the outpatient setting, whether that's a sickle cell day hospital when they're having acute pain, or how do we achieve better disease control? And I think it comes down to what's at the basis of this. Well, we need to be able to support the people we care for in outside of the hospital. And that's the community-based organizations and the sickle cell treatment programs, and ideally the primary care providers all working together. And we need to make sure that we can get people to have that team to support them and to convince them that it's important. Because I think we heard from Pat that you can't mandate someone's going to do something and expect it to be successful. You can use we can get people to show up if they need to show up to get their opiates, but we need to overcome a lot of barriers to do that. And maybe opiates are not the best approach for everyone. So for our next steps, we'll talk some today. I think that we are probably getting to the point where we're getting close to being able to share that toolkit. We've been reluctant to share it until we had rolled it out and run through it and kind of figure out how things work. So I think that's something that we'll talk on our meeting today about whether we're getting close to being able to share that toolkit. I can certainly share the individualized pain plan template that we've been using, and people can adapt that for their own situations. And I would encourage people to think about how they can effectively communicate both within and outside their center. One of the things that we've done in conjunction with this in North Carolina is that we have a provider meeting with people from multiple institutions, focused on people that have complicated pain or other things with their sickle cell disease that increase their risk. So if someone is really hard to transfuse and goes to a bunch of different hospitals. And we've gotten pretty good traction with the programs in Southeast, Central, and Eastern North Carolina if they share patients with us, because they're patients that go to these multiple health systems, and we find that sitting down and talking about them together, making a plan and making sure that plan is shared and addressing the concerns. One of the things that's really important with the partnerships with the hospitalists and the emergency department providers, and I think with primary care as well, is making sure that we address their concerns. Like primary care is concerned that they're going to have to prescribe the opiates, and that's a heavy lift if you're in a 15-minute visit. I can't do that in 15 minutes and keep it safe for the patient and safe for me. So I think we have to be clear about what we're asking and how we support our partners across the way. And the same thing for community-based organizations, right? Like I heard that you don't want to be the ones trying to convince people to be on hydroxyurea. But you want to be able to maybe support them when they ask questions about it, but that doesn't fit well in your job when you're trying to work with the patient. So I think we need to figure out how to support people so they can work within their scope effectively and not have to be worried that they're going to be asked to do things outside of that. And then I think it's an exciting time for data and resources. I think that it might be more challenging than Julie thinks to get some of that money away from the stem cell transplanters. At least for me, they got a pretty tight grasp of the finance side right now. And I'm taking a lot of heat about the finances, and from hospital leadership, they want to make sure that we do this in a way that doesn't land them on the front page, I think is the sense I get.
This was great. This was really fantastic. I want to bring Sonia up here. I want to embarrass her with a really loud round of applause for all of her efforts. You the best. You the best. Really, thank you for making this happen and moving and getting it all straight and set up. And I am going to turn it over to you for last minute thoughts.
Okay, well, just a couple of things. Your pickup time for the shuttle is here on the screen. So if you're not sure, most people are going to be riding in one of the vans. So most people are, let's see, start at 2:50 and 3:30, and then a few outliers later on. Is there anyone that has a problem with me sharing your slides with the whole group? Okay, great. And then one other thing, if you haven't, don't forget to turn in your wristband for the room, for your hotel room, because there is a fee if you haven't turned it in yet. So wristband for your hotel room, yes. Yeah. Yes, they'll charge you. So if you have your wristband, please make sure you turn it in, because I think it's like $50 for each one. So they didn't, but yeah, so they did at the check-in. Yes. And last thing, lunch is next door, box lunch to go. And yeah, that's it. So thank you all. It's been great.